Comparison of acute skin toxicities of 1-week schedule of whole breast radiation versus 3-week regimen in early breast cancer, a prospective observational study. Breast cancer remains the most common invasive cancer among women globally and continues to be a major health issue due to its significant increase in incidence over the recent decades. Its treatment typically involves a combination of surgery, either mastectomy or BCS, radiation, chemotherapy and hormone-therapy. Adjuvant radiation is employed to decrease the likelihood of local recurrence and enhance the overall survival rates. Traditionally, radiation was administered at, as 50 gray in 25 fractions. However, trials have shown that hypofractionated regimens such as 40 gray in 15 fraction or 26 in 5 fractions are just as effective. Currently, radiation is often given as 40 gray in 15 fraction, yielding similar results to the conventional fraction due to the low beta ratio of breast tissue. Hypofractionated schedules can achieve effective tumor control without significantly increasing the damage to normal tissues. Further reduction in the number of fractions such as 26 in 5 gray fraction schedule could be advantageous for patients by reducing treatment costs, shortening treatment duration and minimizing the need for multiple hospital visits and allowing for more efficient use of limited resources. Acute skin toxicity from radiation to breast is a common cosmetic issue that impacts patients' quality of life. It can lead to physical discomfort, body image concerns, emotional distress and disruption of daily activities. From the methodology, I had done a prospective observation study. The objective was to compare the acute skin toxicity of 1-week schedule of whole breast radiation, that is 26 and 5, with 3-week regimen, that's 40 gray in 50 fraction in early breast cancer patients. The study was included newly diagnosed breast cancer patient who reported to the Department of Radiotherapy at Government Medical College, Trivandrum. The duration of study was 1.5 years, which was from February 2023 to September 2024, starting from the date of approval by Ethics Committee. Patient who met the inclusion criteria was enrolled, included age over 18 years with performance status 0 to 2 and diagnosed with invasive carcinoma breast. Eligible patient who had undergone breast conservation surgery or mastectomy with axillary staging and dissection and had PT1 to T3 or N021 M0 disease. All eligible patients were informed about the nature of the study and the intervention involved. The study group was selected and treated with 3D conformer radiotherapy using either a 26-5 fraction or a 14-15 fraction regimen, depending on the factors such as patient performance status, cardiac comorbidities, hormone status, age, and willingness to participate. Patients receiving the treatment regimen on an outpatient basis were closely monitored weekly during the course of radiotherapy to assess the toxicity of the therapy. Skin toxicity was graded according to the modified radiation therapy oncology group RTOG criteria. Evaluation for the skin toxicity was conducted every week during treatment, as well as 2, 4, 6 weeks following the completion of treatment. Statistical tool data was entered in the Excel sheet and analyzed with the SPS software. Categorical study variables were expressed as proportion with the confidence interval. Cosmetic outcomes toxicity were presented using descriptive methods. Descriptive statistics were applied to test hypothesis with a p-value less than 0.05 considered to be statistically significant. Fisher's extract test and chi-square test were used to assess statistical significance. Coming to the results, in this prospective observation study, all pathologically early breast cancer who satisfied the inclusion criteria attending radiotherapy OPD, MCH, TVM during the study period, that's February 22, August 25, are included in the study. The sample size was 47 in each arm. There was total 94 patients and follow-up end of the study. The age of participant between two studies at 1-week schedule was an average age of 54.15 years and 3-week regimen was an average of 57.55 years. There was around 52% of present with CA left breast and 42 patients of CA right breast, and out of this 61 patients who are done an MRM and 33 patients who are done an BCS, and nearly 10.6% was stage 1 disease and 89.4% was on stage 2 disease. Now coming to the comparison of acute skin toxicity of 26 in 5 and 3-week regimen. in 26 in 5 fraction, most person recorded grade 0 toxicity, nearly about 33% showed 70.2% of grade 0 toxicity, and nearly small number of fractions of patients showed grade 2 toxicity, which is the highest toxicity I have recorded, which is of 4.3%. This was the weekly assessment of acute skin toxicity, and toxicity observed in 26 in 5 was seen from week 3, which which I observed grade 1 toxicity in 11 patients, and that is 23.4%, and highest toxicity recorded in 26 5 in grade 2. Which was observed in week 6, which was 4.3%. This was a graph evaluating the recorded toxicity. And in this study, the comparison of acute toxicity between 26 grade 5 fraction and 40-50 radiation reveals a significant difference. The 26-5 regimen demonstrated lower incidence of skin toxicity with 70.2% patients experienced grade 2 toxicity compared to just 14.9% 14 grade 15 fraction. Conversely, the 14-50 regimen associated with the high rates of grade 1 toxicity, that is 63.8%, and grade 2 21.3% toxicity, where the 26 and 5 regimen show lower grades of these grades, that is grade 1 observed in 25.5% and 4.3% experienced grade 2 toxicity. There were no instances of grade 3 or 4 reaction in either group. The statistical significance of these findings with a p-value of 0.001 indicates that the observed difference in toxicity level were unlikely to be TANs. Weekly assessments are done and skin toxicities were monitored. During the week 1, no difference in skin toxicity were noted between the groups. In the week 2, 14-15 regimen showed a higher percentage of grade 1 toxicity compared to the 26 in 5. By week 3, the gap widened significantly with the 14-15 regimen exhibiting substantiating highly grade 1 and grade 2 toxicity compared to the 26 in 5 regimen. This trend persisted through the week 6 and 8, and where the 14 grade 50 fraction regimen consistently showed higher grades of grade 1 toxicity and similar grade 2 toxicity, reaffirming a significant conclusion. In 26 in 5 regimen, 72% experienced grade 2 toxicity, indicating minimal to no skin reaction. In 14-50 grade reaction, 49.9% had grade 0 toxicity, while a high percentage experienced 40 grade 1 and grade 2 toxicity. Difference in toxicity between the two regimens is highly significant, confirming that the 26-5 regimen is associated with lower levels of skin toxicity. This studies had a limitation in terms of being observation study with small number of patients and shorter duration of follow-up. Randomized control studies including more number of patients and longer duration follow-up may be benefit to the society.
Hello. So what was your hypothesis to start with?
I am assuming that 26 in 5 will have it.
Can you speak in the mic?
Assuming that the 20 comparing to 14-15 to schedule, 26 will 26 5 fraction will have a lower skin toxicity.
So you know, breast cancer we have been treating since ages. We started with 50 gray, then 40 gray, now the fast forward kind of thing, right? Forward. So are we really worried now with modern radiotherapy technique about the acute toxicity? Do we really see such a
No.
high? So what was the idea of conducting this study? Because with modern radiotherapy we don't see such a severe acute toxicity that we need to have more concern, right? So when already with 40 gray we are not seeing much toxicity, right? And so your idea that 40 gray will have less toxicity than 5 fraction, so what was the rationale basically? Why 40 gray will have less toxicity?
40 why this 26 in 5 was a new fraction regimen which was introduced recently. So
okay, Dr. Sanapati.
Hello. Yeah. What was your title? What was the title of your thesis? Can you go back the first slide?
Comparison of skin toxicity.
Okay. So do you think that the acute toxicity will have any value? Why you didn't think about the chronic or late reactions? Because the cosmesis is also one of the important factor. And your study period is up to 1.5 years. So in the meantime also you would have studied the late complication.
Nice.
Because I don't know, you have not separated that how many patients are for the BCT and also the MRM. Okay. So if you would have added the late toxicity, the cosmesis aspect, then it would have also some more insight for this paper. Okay, thank you.
Thank you, Dr. Meenu. The next participant for the paper presentation is Dr. Mohammad Fahim from RCC Trivandrum.
Good morning. My topic of the presentation is dosimetry comparison of simultaneous integrated boost for left-sided breast cancer using field-in-field IMRT versus hybrid VMAT versus ring gantry VMAT. Hyperfractional radiotherapy plus or minus tumor boost is the standard of care for breast cancer following breast conservation. Usually the boost is delivered sequentially with the whole breast RT. But in simultaneous integrated boost, we shorten the treatment length, which were around to 3 weeks, by giving simultaneous to the breast. The aim of my study is to compare a target coverage and oral organic risk sparing achieved with field-in-field IMRT, Siam Linac accelerator hybrid VMAT, and ring gantry VMAT for simultaneous integrated boost for patients with left-sided breast cancer. The objective is to compare the target volume coverage in terms of efficacy parameters such as dose to boost, planning target volume, conformity index, and homogeneity index. To compare the dose received to organoid risk such as heart, lung, contralateral breast, and other normal tissues. The study is a comparative dosimetric study from 1st June 2023 to 31st March 2024 at the Department of Radiation Oncology, RCC Trivandrum. The study was approved by IRB. Coming to the inclusion criteria, the age is more than 18 years, histologically confirmed invasive breast adenocarcinoma with stage 1 to 3, and patient who undergoes breast conservation surgery and are planned to receive whole breast radiotherapy and primary boost. Patient who have surgical clip in situ sarama for localization of the boost clinical target were also included. Exclusion criteria is diagnosis of a synchronous bilateral breast carcinoma, history of prior breast or chest radiotherapy, patient who required prone breast radiotherapy, patient plans for electron boost, patient who required internal mammary node or full axillary irradiation, patient from whom the defined mandatory plan constraints for simultaneous integrated boost cannot be met by any techniques, and my sample size is 30. Coming to RT planning, the free breathing, non-contrast planning CT image datasets were used for the study. Target volume innovation, the whole breast target volume was contoured based on ESTRO consensus guidelines version 1.1. The CT boost was defined by the surgical clips of seroma. A PTV 5 mm expansion of respective CTVs and a PTV eval of 5 mm was cropped from the skin, and also contoured the bilateral lung, heart, and contralateral breasts were contoured. The whole breast received a 40 gray in 15 fraction over 3 weeks with a simultaneous integrated boost of 8 gray over 15 fraction. Nodal RT was given in indicated cases, and we compared the patient was generated for each plan and compared with the whole breast and for the field-in-field 3D CRT, hybrid VMAT with the combination of field-in-field and VMAT, and ring gantry VMAT. This is the minimum plan acceptance criteria. Coming to the dosimetry comparison, for the target coverage, the whole breast PTV mean dose and volume receiving 95% dose was compared. Breast PTV eval, the mean dose, volume receiving 95%, 98%, 107%, 110% of prescribed dose was evaluated. Homogeneity index and conformity index were calculated. And the organic risk we calculated for in the herd we used for the mean dose, volume receiving 30%, 30 gray, and volume percentage of the volume receiving 5 gray. In ipsilateral lung mean dose V12 and V20 and V5. In contralateral breast we evaluated for mean volume percentage of volume receiving 5 gray, combined lung mean and contralateral breast mean and volume receiving 3 gray. This analysis for the left-sided breast cancer, and we analyzed it for 15 patients. The ANOVA test, the difference between the mean value of 3 categorical group, post-hoc beneficiary tests were compared between 2 groups, and a p-value of 0.0 was considered significant. Coming to the result, the mean boost, coming to target dose, the mean boost BTV dose laser point. Coming to target dose, mean boost PTV volume receiving 95% and 98% were comparable among all. From the conformity index of their rapid arc VMAT, ring country VMAT was 0.78, hybrid VMAT of 0.44, and a field-in-field of 0.19. And the conformity index was very high, very good for the ring gantry VMAT with a statistically significant value in all. I mean, the homogeneity index is 0.07, 0.05, and 0.06. Better for the hybrid VMAT with a p-value of 0.05. We'll compare with the field-in-field, the p-value of 0.02. Coming to the volume receiving 30 gray, it was comparable between rapid arc VMAT and hybrid VMAT, and significantly worse for field-in-field with 0.01. The ipsilateral lung dose volume for 20 gray, the rapid ring gantry VMAT compared to the hybrid VMAT, the p-value of 0.04. While comparing with the field-in-field, it is 0.03, and hybrid VMAT and field-in-field were comparable. Coming to the volume receiving 5 gray, mean dose to the contralateral breast and the combined lung dose, rapid ring gantry VMAT plan yielded the worst, and hybrid VMAT and field were comparable. Coming to the mean heart dose and volume receiving 5 gray, percentage of volume receiving 5 gray, not statistically different among the techniques. And in contralateral breast, the mean dose was significantly higher in ring gantry VMAT, and a hybrid VMAT and field were comparable. High dose zone and low dose zone have no significant difference. Coming to the results, this is the dose distribution isodose color wash for the field-in-field, hybrid VMAT and ring gantry VMAT. For the 47 gray, 40 gray, and 38 gray and 3 gray. We can see a good conformal index in the ring gantry VMAT with the low dose pills was very high. Coming to the conclusion, ring gantry VMAT provided superior target, conformity and homogeneity, heart and ipsilateral lung sparing, but with significant low dose pill to the whole lung and contralateral breast. Hybrid VMAT plans appear to provide similar PTV coverage, albeit with lesser with conformity index and acceptable OR sparing. Thank you.
So in your conclusion, you have not, just go to your conclusion slide, so you have not given any conclusion regarding the field-in-field. So just ring gantry and hybrid VMAT. So because you compared 3.
Yes, sir.
So what's about the field-in-field? What is your conclusion about the field-in-field?
In field-in-field, the conformity index is less, and high dose of ipsilateral lung and heart dose were there. So,
So what exactly, if I ask you that, what should I practice between all the three? So what will be your...
I just analyzed the left side at present. Both left side and right side need to be considered before taking a
Okay,
decision.
whatever you have, based on that data,
Now,
what you will...
hybrid VMAT is a, my conclusion will be a hybrid VMAT. Thanks.
Thank you, Dr. Fahim. I request Dr. Sanjay Aravind, next participant from Amrita Institute of Medical Sciences, for his presentation.
Very good morning to one and all. I'll be presenting about bilateral breast cancer patients treated using IMRT, a single institutional observation study. I'm Dr. Sanjay, a second year resident from Amrita Hospital. So in our common clinical practice, we do see tons and tons of cases of unilateral breast cancers. And synchronous bilateral breast cancers tend to be rare. The incidence is overall low. But in the last decade, I think the incidence is slowly rising up due to improving diagnostics, improving patient awareness and education. And the overall incidence rate seems to be around 1.4 to 12% in the bilateral breast cancer group. And the prognosis of such cancers has been overall reported to be worse than the unilateral breast cancers, as due to the biological aspects and as well as the optimum therapy, and the treatment modalities tend to be controversial and tend to be limited based on evidences. So the objective of our study was to evaluate the clinicopathological factors and the dosimetric profiles of bilateral breast cancers treated with intensity modulated radiation therapy. And it was a single institution retrospective study. We got all our data from the electronic medical records and the planning system, and we took patients from 2018 to 2024 treated with IMRT with or without boost, and the weekly assessment of all these patients was also done, and toxicity was graded according to the RTOG criteria. So the demographic, we had around 14 patients from the year 2018 to 24. The median age was around 55 years, and the follow-up period, median follow-up was 24 months with a range of 8 to 60 months. And the majority of the population in our study was postmenopausal, and we had 4 premenopausal cases. And coming to the histopathology, the invasive breast carcinoma of no specific type was of the majority, and we had around 13 cases on the left side and around 9 cases on the right. And the invasive lobular carcinoma was just 1 on each, and other histologies included DCIS, and we also had a few cases of neuroendocrine carcinoma, mucinous and papillary also. The other histologies. So coming to the comparison, I mean the left and the right, the histological subtypes. On the left, it was almost equally distributed around 3 and 3, that was HER2 enriched and the luminal group, and the triple negative and the luminal B was the majority. I mean, out of the 14, 4 cases on the left were luminal B and triple negative. On the right side, it was a majority of luminal B cases, and we had 1 DCIS. So the clinical grading and the staging was done, and we found that on the left side, it was a majority of 8 cases with stage 2, and when it comes to grading, again 8 cases of grade 2 and 5 cases of grade 3 on the left side. And on the right side, we can see that it was stage 2 cancers with 5 cases, and again grade 2, and which was around 8 patients on the right side. So the treatment details, the radiation details, as we have seen, it was 40 gray in 15 fractions to the whole breast or chest wall, and tumor bed boost to 10 gray in 5 fractions. The patients who received bilateral chest irradiation was 4 cases, and whole breast was 3. And almost all of them received regional nodal irradiation, and only 3 cases in our study group received the IMN irradiation, and that was also on the left side with bilateral RT. And patient who underwent surgery, bilateral MRM was done in 3 cases, WLE in 2, and at least one of them, at least 9 patients, 64% of the cases, at least one side they underwent MRM. And coming to the chemotherapy also, I think around 8 patients had a neoadjuvant chemotherapy in our cohort of patients. The dose parameters, this is the color wash picture of the our IMRT plan, which shows a good homogeneous distribution of the dosimetric profiles, with the red color indicating about 3950 centigrade and slowly gradiating down, and the low dose pill was around 10 gray. So this was the dosimetric comparison between the left breast and the right breast and the tumor volumes of the SEF and axilla. We had the D90 good coverage around D90, D95 with more than 95% of the dose covering each of this. And also on the left side, the SEF and axilla was also noted to have comparable good coverage. And this was one more plan where on one side we did not treat the breast, but the axilla was treated on the contralateral side, and the other side we had to treat the whole breast and axilla. And we had also included the IMN in this plan, which received the color was shows around 36 gray. And the mean dose to the left lung was around 12 gray, and right lung was around 14. And the bilateral combined lung volume, we had a very less dose compared, because the V17 and V20 was less than 35 gray. According to 35% was the according to the guideline. We got a coverage of 26. V17 and V20 was 20%. So this was the mean lung dose with nodal and without nodal. It was around roughly around 13 to 14 gray in the nodal irradiation. Without nodal irradiation, we had the coverage of around 11 gray. And this was the mean hard dose. We kept the mean hard dose with bilateral dose less than 6 gray. We were able to keep it around 5.9 gray. But with IMN radiation, there was a slight increase in the mean hard dose to about 8.5 gray in those 3 cases alone. And this was the OIR profile, and the homogeneity index over the right and the left sided breast cancers. And the toxicities were also documented. We had around grade 1 skin reactions at completion around 6 cases. There was no other grade 2, grade 3 skin toxicities as such. And coming to late toxicities, there was edema in bilateral lymphedema in one of the cases out of the 14, because they had undergone both MRM axillary clearance on both sides and then RT also. So the conclusion of our study was just that it was cohort mainly considered for node positive cases, luminal B, HER2 negative, invasive breast cancer of no specific type. And we think that these breast cancers should be treated aggressively with multimodality approach. And IMRT achieves, tomotherapy achieves a good dosimetric outcome with respect to PTV coverage and OAR sparing. And these were the references. Thank you.
Can you quickly tell me your title? Of, just go back to your title of
Bilateral breast cancer patients treated using intensity modulated radiation therapy, single institution observational study, sir.
And your aims and objectives?
And
just go.
The objective was to evaluate the clinicopathological factors of bilateral breast cancers and the dosimetric profiles of these patients treated using IMRT, sir.
All right. So in your title you missed the first objective, so which is not reflecting in your title. So it's, in title it's just the dosimetric or who are treated with IMRT.
Yes.
So there is a mismatch in the title.
Yes.
And conclusion, you have not mentioned in your conclusion about the, this first objective, the clinico-pathological. You just, confined your conclusion to the IMRT only. So there is some mismatch between your title and the objective and your conclusion, right? So they should be taken into account.
Okay, sir. I will do that. Yes, sir.
Yeah, so this is a good study, but there is some discrepancy.
Yes, sir.
You are treating with Tomo?
Yes, sir.
Okay. Have you thought that if you will go for the, instead of IMRT, if you will think for the VMAT?
Yes,
What's
sir.
your comment?
Sir, ideally speaking, VMAT with deep inspiratory method would have been the ideal technique with good OIR sparing and reduced dose constraints.
Okay.
But I think in view of practical difficulty, in, because the VMAT planning in our system might take a lot of time, and the treatment time is also increased. So, and
So the second question.
yes, sir.
Have you analyzed the clinical pathological aspect? What about any family history and also any BRCA1 and BRCA2?
Yes,
Because
sir.
they have the bilateral breast disease.
Yes, sir. Since bilateral breast cancer is an indication for BRCA testing, in our patients, we do advise the patients to go ahead with BRCA
But
gene
none of the
testing.
patients have undergone all this study.
Yes, sir. Actually, around 6 patients had undergone. I didn't include it in the slide.
Okay,
Maybe I
fine.
should have, but
Yeah. In your study, only 2 patients having the lobular and rest of the IDC. Am I correct?
yes, sir.
Lobular carcinoma.
Yes, sir.
And rest are the IDC.
Rest are IDC with no specific type, sir.
Usually it's not matching.
That, yes, sir. That histology was again not matching.
And particularly the majority are the luminal type B,
Luminal B, sir.
bilateral breast disease.
Yes, sir. According to the studies and the review articles, ideally it should have been a lobular on both sides and luminal A probably. But I think this was the data that
Okay, because
we
this
had.
is only small data, 14%. Thank you.
Yes.
Good presentation. Go ahead.
Okay, thank you, sir.
Thank you, Dr. Sanjay. The last participant for today's paper presentation is Dr. Arya Suresh from Amala Institute of Medical Sciences.
Good morning, everyone. I'm Arya from Amala Institute of Medical Sciences, Thrissur. I'm here to present on extracorporeal irradiation for bone sarcomas experienced from a tertiary cancer center. Introduction. Extracorporeal irradiation, or ECI, is an effective and established method for limb conservation in the management of bone sarcomas. It consists of en bloc removal of the tumor-bearing bone segment, removal of the tumor from the bone, irradiation of the segment, and re-implantation back in the body. The irradiated bone acts as a size mesh allograft with good union, approximately 77%, and with minimal complications. ECI has been selectively used in our center as part of limb preservation surgery for bone sarcoma since 2014. Aim to analyze the oncological outcome following ECI in bone sarcoma treated at our center. Objectives is to assess the local control, to assess the disease-free survival and overall survival. Materials and methods, study design, retrospective cohort study, and the study setting was at the Department of Radiation Oncology, Amala Institute of Medical Sciences, Thrissur. Study population included those patients who were diagnosed with bone sarcoma and treated with ECI. Study period was from January 2014 to December 2023. Treatment details. En bloc resection of the involved bone and soft tissue component was done, and the bone segment was washed in antibiotic-containing saline and then tightly wrapped in wet sterile wrap. This enables to minimize the air gap that can affect the radiation dose homogeneity. And the bone segment is sealed in 2 plastic bags under sterile precaution. The bone segment within the plastic cover is then surrounded by an additional water equivalent material for uniform dose distribution, and all the patients were treated with a mid-plane dose of 50 gray. And the irradiated bone was re-implanted with fixation device with or without a vascularized autologous bone graft. Statistical analysis. Summary statistics was used to define the cohort, and the disease-free survival and overall survival rates were calculated using Kaplan-Meier curve. Results. Demographics. We have included 8 patients who have received ECI, and the median age was 41 years, ranging between 9 to 57 years, and it was found that males constituted 62% and females were of 38%. Histologic subtypes. We had 3 cases of chondrosarcoma, 2 of osteosarcoma, and 1 each from Ewing sarcoma, leiomyosarcoma, and the primitive neuroectodermal tumor. And the location of the bone, we found that the right humerus, we had 2 cases, left femur 2 cases, and 1 case each from left humerus, left tibia, right tibia, and the left to 30 centimeter, with a dose rate 200 monitor units per minute and 300 monitor units per minute. Outcomes. The median follow-up time was 24 months, ranging between 2 to 89 months, and all patients had a local control of 100% during their survival period. and 4 people developed distant metastasis, and it was found that the 2-year disease-free survival rate was 56.2%, and the 2-year overall survival rate was 58.3%. And this is the disease-free survival curve, which shows that at the end of 24 months, or the 2 years, the disease-free survival was found to be 52.6%, and the overall survival was found to be 53.8%. Discussion based on various studies done where the bone sarcomas when treated with a single dose of 50 Cray and with a median follow-up, it was found to have the local recurrence-free survival was very excellent. And with our study, where we have done the study in 8 patients, 3 of chondrosarcoma, 2 of osteosarcoma, and 1 each from leiomyosarcoma, Ewing sarcoma, and the primitive neuroectodermal tumor, delivering a single dose of 50 Gray, and with a median follow-up of 24 months, the local control rate was found to be 100%. Limitation of our study was the small sample size, and the conclusion was that we suggest that the ECI is technically feasible, cost-effective, and also it provides excellent local control in malignant bone sarcomas. These are the references, and thank you.
So, can you tell us how much total time was taken
For the
for treatment? Yeah.
For radiation therapy,
Not for radiotherapy,
the entire
but
thing,
entire things. I mean, once the bone come to your department after that.
it's around 1 hour to 1.5 hours.
All right. So you have to stop the machine for 1.5 hours for routine patients.
Yes, sir.
Right,
The
right.
radiation treatment will
And,
be completed in around 28 minutes,
But
30.
for rest of the things you have to hold
Yes,
the
sir.
machine. And second thing, all these patients were given preoperative chemotherapy.
Only few of them have received, like Ewing sarcoma case, they have received a neoadjuvant chemotherapy prior to the surgery and the
No,
radiation.
because osteosarcoma also now the preoperative chemotherapy.
Only one case they
is
have
a standard
received.
of care because
Yes, sir. Only in one case they have received the chemotherapy. In those patients who were included in our study.
So that is something surprising because osteosarcoma, that is the now standard of care, and that may, ultimately, if you don't give chemotherapy, that may result into distant failure
Distant
even
metastasis.
after that. Yeah. Dr. Senapati.
Yeah, that's a good comment. Actually, in osteosarcoma upfront surgery, how far it is feasible. Okay.
Thank you, sir.
And go back to your result. Go back the result slide. Yeah, wait. Yes. So this is disease-free survival, isn't it?
Yes, sir.
So your aim of treatment that you give radiation, so there is better local tumor control and also better disease-free survival. So this is your hypothesis, I think so.
Yes, sir.
So is it due to the radiation as such or the addition of chemotherapy? Because all the patients might have not treated with radiation. They might have also subjected for this chemotherapy, if I am correct. Except that chondrosarcoma, you are having some chondrosarcoma.
Yes, sir.
Okay. That they might have also treated with chemotherapy.
Chemotherapy.
So it would have better that your endpoint would have the local tumor control. You have already highlighted that there is 100% local tumor
Local
control.
control was 100%.
Do you think that on subsequent follow-up, that might have, these patients might have also reviewed the literature. In subsequent follow-up, do you think that there might have more number of failures and also the incidence of fracture?
Yeah, incidence of fracture will be more if the radiation dose is more. But the radiation dose that we usually give in our institute is 50 grain single fraction. And if you are increasing the rate of the radiation, might be the outcome will be better, but there will be more risk for fracture of the bone segment that has been involved.
Okay, this is a good study, but just you review, because we don't agree with the treatment protocol, particularly osteosarcoma, upfront surgery, and also limb sparing surgery. Okay, this is not a standard practice. Okay?
Okay, sir.
Thank you.
Thank you.
Thank you, Dr. Arya. With this, we come to the conclusion of today's paper presentation session. The paper presentation will continue tomorrow, and we look forward to another enriching session. As a token of appreciation for their time, expertise, and invaluable contributions to the event, we would now like to present mementos to our esteemed judges. I request Dr. Jayakumar sir to please do the honor of presenting the memento to Dr. Surendranath Senapati sir. I request Dr. Francis V. James, sir, to present the memento to Dr. Manoj Kumar Gupta, sir. As we move forward, it's now time for Professor R. Mahadevan Memorial Oration. To introduce and present the prestigious oration, I invite Dr. Suresh Kumar K., Professor and HOD, Radiation Oncology, Government Medical College, Kottayam, to present. I also request Dr. Francis V. James, sir, and Dr. Shabri Nath, sir, to chair the session.
Good morning, everyone. Respected President of Kerala Chapter, Secretary of Kerala Chapter, my dear senior teachers, and dear students and colleagues. It's in fact a mixed sort of emotion to be here standing and delivering Dr. Mahadevan Memorial Oration for me, because he was very close to me in a lot of ways. My senior resident who taught me the basics of radiation oncology, as well as a brother for me in many respects, and my unit chief, and then my head of department, and so on and so forth. A lot of times, we have spent together. So to speak about an oration in his memory is a difficult task for me. I am talking about this. Yesterday is but today's memory, and tomorrow is today's dream. We have reached to this level in radiation oncology just because a lot of our seniors who dreamt about the specialty and the development of cancer care in Kerala is actually a dream of many. And many who have stood before us, holding our hands, and now it is the responsibility of us to take it further and take the specialty in the new era with a lot of evidence, as some of you, our youngsters do. So I'm happy that, they have done it. They have taken the specialty forward. And to establish such dreams, we need dream makers. Mahadevan sir was one among them. He was born in Trivandrum, 1961. DMRT from Medical College Trivandrum, and he was completed a MD from RCC in 2004. He joined the Kerala Medical Education Department. He was an assistant professor in Government Medical College, Kottayam, and then he became an associate professor there and unit chief there. He transferred to Thrissur as the professor, and then he came back to Trivandrum. He had his heavenly abode in February 27th, 2023. He was a man with a lot of dream. He was the brilliant academician, a big organizer, an excellent clinician, and an administrator with a vision. He was the medical superintendent, additional medical superintendent at Kottayam. He was the medical superintendent at Thrissur. He was the head of the department at Thrissur. He was instrumental in bringing the tertiary cancer center at Thrissur. And he was contributed a lot to the specialty as well as to the association. He had worked with us for almost 6-7 years in Kottayam, conducted big conferences uh, and contributed to PG education. This is some of his services he delivered at Thrissur. This is the tertiary cancer center inauguration. This is his family, and I respect my homages to his soul. He was a brilliant colleague in many respects. We can identify some of these faces. Probably a much lean doctor, you can see Suresh Kumar there, as well as the person who is standing here. This is Dr. Cecil, Dr. Anand is here, Dr. Bindu is here, Ajit, I don't know Ajit is here or not. Dr. Shama is the professor at Pondicherry. So Beena was the professor at Amrita. So we were very close. We were as family when we are doing our post-graduation. So that's many of you, I understand. So it's really painful to lose somebody from the family. That's the feeling I'm having at this point of time. So I have kept this talk as a kaleidoscope. I'm taking few memories from what I have been taught by some of my teachers and how I have reached to this level, or delivering a narration in the state conference. This is my alma mater. I'm proud to be a Kottayam Medical College alumni. And as many of us have envisaged, Professor Krishna sir was inspired a lot of us. He inspired me a lot because mere presence was simply a gigantic feeling. You will feel blessed to be taught by this great man. RCC gave me a lot of opportunity, especially the library and the teaching facilities. It was excellent. And these are some of my mentors. I owe a lot for these senior faculty members. I can't add more because these are some of the greats in the specialty who has taken the Kerala radiation oncology forward and expanded it in the clinical oncology way. And these are some of the persons who introduced me the global vision, as well as given me training in their respective centers. After training, I have reached this corridor. It was full of dirt. It was full of packed furniture, broken furnitures. Here, I mean, I think Salahuddin sir, Dr. Emma, Dr. Aravind is here. We dreamt about making this back to its prestigious level, Trivandrum Medical College. And it's the hard work of all the persons who work there. Now it is one of the better department in the state. We have many students who have passed out from Trivandrum Medical College are now doing excellently well abroad also. So this was a vision which we dreamt about, which was materialized, and we are very happy, and I'm really happy and proud about this moment, because I still remember the time when we sat at the Ward 13 and taken the debris out of the Ward 13. Aravind still remember all those things. We actually dreamt about making it a big department, but we never thought that this will happen in this quick succession and in a quick period. I also remember Professor Sudharan sir and all the teachers who are contributed immensely for the development of Trivandrum Medical College. Pediatric oncology was one specialty which was really challenging for anybody who, after completing the MD, came back to Kottayam, started working. Pediatric is a difficult world for me. And at that time, we had very limited facility. We have only cobalt machine, and we have to treat these children. One of the patients referred to me was a 12-year-old boy, referred from RCC, present with headache, vomiting, It was difficult to walk. He had a biopsy from a CT, diagnosed as a medulloblastoma. At that time, there was no molecular testing, was not routine. Referred for craniospinal radiation because they are from, he cannot stand, he can stay back at RCC. They are from poor socioeconomic background. They are staying near to Kottayam Medical College, referred to me. So at that time, we had only 4 LINACs in Kerala, Cobalt machines, 8 of them, conventional simulator 3, CT simulators 2. And the rationale with which we have to give craniospinal radiation is that CSI plus posterior cranial fossa boost will make them 53% chance for 5-year survival. So that is the treatment recommended. This is a telecobalt machine. So this patient was a high-risk medulloblastoma. As you are remembering, the standard risk is less than 3 years, more than 3 years, no mets at presentation, not more than 1.5 centimeter cubed residual tumor, a CSF should be negative. All others are high risk. Now molecularly we can have an average risk also. So current recommendation is CSI for 23.4 gray for average risk plus a posterior tumor bed boost with the concurrent VCR as the chemotherapy followed by adjuvant. And high risk CSI of 36 gray in 20 fractions, 1.8 gray per fraction with concurrent VCR vincristine plus a posterior fossa boost of 18 gray with the systemic chemotherapy for another 6 cycles. No molecular risk assessment was done at that point of time. Now we have the moleculars. We have the WNT type, SHH type, and the group 3 and group 4. And based on that, we are even having some studies recommending de-escalation also and the CSI dose. At that time, there was no such facility. So there are a lot of issues related to CSRT. The positioning was difficult. It's a challenge because you have to keep the patient prone always. And prone immobilization is a tough challenge. And plan, when you are lucky that you are not seeing the plan. Because if you see the plan, it will be very difficult to proceed with that. And the matching of the junctions is still another challenge. And, with the limited motion available for these machines, we have to match the at least two junctions. For a 12-year-old, you have to match 2 junctions. And you have to do a daily tethering of the field because there is, since the junctions are coming, you have to daily go there and do the tethering. And you have to do the concurrent. Vincristine has to go concurrently. And you have to address the toxicities because it is very difficult to give concurrent with the CSI. And adding to that, there was no SR, no JR, and I was the junior most. So I have to go there and do it regularly. If you see the dose distributions, now there was no dose distribution available. But this is what I have treated. There will be a definitely photon spill. Now we have got electron with less spill or a proton with with a beautiful conformity to the spinal cord. So that was another challenge. So we had some results available on that period as 2018 data from Florida suggests that the median survival is 15.4 years for medulloblastoma. 10-year OS is 67%. 10-year disease-free survival is 67%. A 10-year progression-free survival is 71%. And we can reduce the RT toxicity by reducing the dose to 28 gray and incorporation of systemic treatment. And this is a 15-year follow-up, 15-year data. So we can see that the grade 3 toxicities were significant because of the techniques used at that point of time. There was 20% severe hearing loss, 18% cognitive impairment, and second cancers like leukemia, GBM, RMS, and meningioma. We have treated 3, all high risk, One survived 5.4 years. One had developed a second malignancy at 10 years. One is still surviving 20 years plus. And he is now working in Kottayam Medical College as a ECG technician. And after 2015, most of these patients are either go for tomo or proton. So we are not routinely treating them with these techniques. So this was one of the patient I have blessed with, because it was a real challenge to treat that patient daily, because I have to be there with the radiographer. Next up, the commonest pediatric tumors are pediatric sarcomas. They constitute 10% of childhood tumors. And bone sarcomas, both osteosarcoma and Ewing's, and soft tissue sarcomas constitute the majority. About osteosarcoma, 20% of all bone tumors, it has got a bimodal age. There is a younger age group, and there was a 60 plus. Usually present with bone pain, initially with activity and then with rest, swelling near the big joints, or radiology can get the diagnosis. Whereas in Ewing's, it is less than 10%, median age is 15 years, a risk of early mets, present with the swelling and pain, and especially swellings in the long bones or pelvis. Radiology, it's almost similar. You can see that the location is critical. One is at the metaphyseal region, other is at the diaphysis. You can see the Codman's triangle, the sunburst appearance you can see in both situations. And there is a wide zone of transition, but a typical osteoid formation in osteosarcoma. Pathology, Ewing's sarcoma is a blue round cell tumor, you all know. And workup, basically, you have to incorporate bone scan and PET scan. In Ewing's, you need to add molecular studies and bone marrow in addition. The molecular markers are very critical for Ewing's sarcoma diagnosis if there is a confusion with histopathology. You have to look at this fusion gene, the EWS FL1 fusion gene, for confirmation. And the prognostic factors, male patients, older age, and large tumor size, non-extremities, osteosarcomas, poor chemotherapy response, metastasis at presentation, and non-surgical treatment are the risk factors of osteosarcoma. Whereas Ewing's, it has got a distal lesion, tumor volume less than 100, normal LDH level, adverse, no adverse are present, then it's a favorable outcome. If it is metastatic or poor response to chemotherapy, you can have an adverse outcome. So the management, when we look at, it's as we have already discussed, in the low grade you can treat with surgery in osteosarcoma. High grade it is mandatory to give primary system. So the initial biopsy is very critical. By the surgeon who is doing the conservation surgery has to do the biopsy. And it's primary systemic therapy, cisplatin, adriamycin or the MAP regime. And you have to assess the pathological grading at limb sparing surgery with the Hughes grading. And if the margin are negative, you can complete the chemotherapy. Or if the margin is positive, there is a role for radiation. In Ewing's sarcoma, again you have to go for the chemotherapy. And the RT has to be typically planned at 12 weeks in the warmer protocol. And if there is a stable disease, then you can continue with the chemotherapy. If there is a progression, you can go for palliative chemotherapy or palliative radiation. So this is the management in a nutshell. For the high grade with good response, we can continue the adjuvant treatment, adjuvant chemotherapy. If there is poor response, you have to change the schedule to MIP in osteosarcoma. If it is inoperable, you can go for radiation alone. Whereas in Ewing's sarcoma, you have to go for the initial tumor plus 2 centimeter margin either side, and then you have to go for a countdown boost. Initially 45 gray in 25 fractions, followed by a boost radiation up to 58 gray. That is the usual practice. And we have treated 6 patients with osteosarcoma. We have few patients lost follow-up. I don't know, because of the transfer, I don't know where these patients are now. But 4 are now surviving, and they are doing good. And we have, for the long survivors, we have to do resurgery again. That's a major problem when we are treating children with pediatric sarcomas. So this girl undergone 2 surgeries by now. Now she's 14 plus, I think she's planned for another surgery, because as the length increases, you have to do the resurgery for better mobilization. And fertility preservation is another critical issue. This is a patient with a 4-year-old girl. Now, gradually we have improved. Our facilities also have improved. In the LINAC era, this is what we could achieve. This is a 4-year-old girl with orbital rhabdomyosarcoma. She had 2 recurrences in 1 year. And after the 3rd surgery, the surgeon referred to us. The lesion was here. So we have planned for radiation, discussing the various complications and etc., etc. And then we have treated her. Now it's almost 4 years. She's doing good. All stories are not success stories. This is another 4-year-old girl with astrocytoma. We have treated her under anesthesia at Thrissur Medical College. You can see that the entire team is there. We have tried our level best to treat this girl. She had 30 days radiation with anesthesia for all days. These are difficult tasks to achieve in government medical college, but Thrissur made it possible. And we have treated her. Unfortunately, she didn't survive. She survived only for 1.5 years. She's now passed away. At that time, it was my mentor and my visionary leader, Professor Madhusar, was treating all these young leukemias. This is one of the patients I was treated under his guidance, ALL. He's still going good. She came to me a couple of months back. You can see that she's now a grown-up man. I'm now dare to touch an ALL, but these are actually happened in 2005, 2006 era. So this was our experience, my small experience with pediatric oncology. Now, when you see this, you are all confused. What to do with the beef and padamburi or banana fry? This was a surprise for me. When I was reached Angamali. Then I slowly tested it. I found it's a very good recipe to have. Similarly, I am now adding brachytherapy to this pediatric oncology, because this is not for discussing anything, just to tell my youngsters. Now we are worried that AI might take a lot of our contouring, etc., etc. But this is one art which you can practice and which is there in your hand. And the only thing is that you should know when to practice it and and need good collaboration. I am really lucky to have my mentors. All of them are excellent brachytherapists. Professor Madhusar, Professor Ramdas sir is here. They were actually taught me how to do it. And this is one of the tongue implant I have, because I'm having a very confident surgeon with me. So I said, you go ahead and do it. It's a 3 centimeter lesion. I have implanted through the submandibular approach. And we have successfully done it. Still closely evaluating for the nodes. Nodes are a concern. So if the surgeon can take care of the nodes, then definitely when it appears, we should be closely review these patients, and then if we can act early, probably it will not affect the survival. This is a breast implant which I have done under the guidance again of Professor Madhusa. I can't forget all those things, because being the professor and head of the department, he came to my operating room, he stood with me and he said, Suresh, go ahead, you do it. I'm not very sure whether this is probably the first case which we have done in the state. In the state, I'm not very sure about that, but it was all because of the courage which he has given me to accomplish this. Molds now largely forgotten. I think the students should take this, because this is a sarcoma of the finger, and we have marked and we have treated. There's a buccal mucosa being implanted. You can see that, no surgeon can match this functionality. A lip being implanted. I think this is the case which Dr. Unni, who is now a medical oncologist in Caritas, has done. And he was very actively doing brachytherapy at Ernakulam when he was posted at GH. Now he's forgot all those things. He was busy practicing medical oncologist. Success is a journey, but it's not a destination. The doing is often more important than the outcome. So I am trying to say that you should do it, practice brachytherapy with pride, and you should know when to practice it and which are the situations which are apt to do it, so that you will be successful at one day. Because it's a largely forgotten branch of our specialty. This is my last slide. Thank you. I'm still remembering Mahadevan sir, who was never stood alone. He was every time in the group of his friends and colleagues, and will be remembered always by all of us. Thank you very much.
Thank you for presenting the oration, which spans 2 decades of your experience, especially in pediatrics radiotherapy. Thank you.
Thank you, sir. I request Dr. Mathu, sir, President-elect Aroy, to please do the honor of presenting memento to Dr. Suresh, sir. And memento to the chairpersons of the session, Dr. Francis, sir, and Dr. Shabrinath, sir. I request Mathu, sir, to present the mementos to Francis, sir, and Shabrinath, sir. Thank you, sir. We now move on to the next session in our academic program, an interviewing couple session titled Beyond the First Sight, Strategies of Recurrence in Head and Neck Cancer. To lead this engaging session, we have 2 renowned experts in this field, Dr. Malu Rafi, Associate Professor, Radiation Oncology, RCC Trivandrum, and Dr. Anoop R, Clinical Associate Professor, Radiation Oncology, AIMS, Kochi. I also invite Dr. K. Ramtha, sir, Director, Clinical Operations, Karkinos Healthcare, India, and Dr. Anand R.K., sir, Associate Professor, Government Medical College, Alapura, to chair this session. Dr. Anand, sir, will join the session soon. We shall start the session now.
I think you can start straight away.
Good morning, everyone. So this is the first so-called couple session of this meeting. So both of us, we would like to thank the organizers for giving us this opportunity to share our thoughts on the topic beyond the first fight, strategies for managing recurrence in head and neck cancers. So we'll start with a scenario. We have a 58-year-old male patient with an ECOG performance status of 1. He is a smoker with 60 pack years, and he has comorbidities of coronary artery disease, post-PTCI 2 years back, and diabetes mellitus of 10 years duration on OHA. So he was staged to have T2N2B moderately differentiated squamous cell cancer of the left buccal mucosa with enlarged nodes in left level 2 and 3. And this patient was unwilling for surgery. So he underwent radical chemoradiotherapy using VMAT technique, and a SIB protocol of 66 and 54 gray in 30 fractions each was delivered. And concurrent chemotherapy used was cisplatin, 40 milligram per meter square in a weekly fashion. So this was the plan that was used for treating the patient. The OIR doses, the mandible point dose was 67 gray, spinal cord received a max dose of 35. There was no parotid sparing on that side. And brainstem and brain max dose was less than 35 gray. And he completed treatment uneventfully in 2019 and was disease-free at 3 months post-RT and was on regular follow-up. And this was in 2019. In 2022 November, he presented with a recurrent lesion in the left buccal mucosa corresponding to the treated area, biopsy proven to be squamous cell cancer. And staging workup showed the disease localized to the left buccal mucosa, again staged as T2N0. Now he has a disease-free interval of 3 years. So now I would like to hand over the mic to Dr. Anoop to share his thoughts on this scenario, how he would approach this patient, and what would be the evidence based on which he would decide on treating him.
Thank you, Malu. So here we have a 58-year-old man with a recurrent carcinoma buccal mucosa. So in head and neck tumors, it is a big challenge for all of us, because it is when the recurrence comes, the recurrence, it is usually an aggressive biology, and limited treatment options are only available, and usually the prognosis and the quality of life is a major concern. So these patients should always be investigated or together managed by a multidisciplinary team, and should have a comprehensive assessment, including the speech and swallowing therapy, nutrition, and the pain and symptomatic care. So basically, when you're looking at the options are in these patients are either surgery or re-radiation. So in surgery, it offers advantage because it is it's a complete tumor removal in one setting, and is usually preferred in small, well-localized recurrences with clear surgical margins. The limitations are when it's close to the critical structures, it is inoperable, and there's a higher surgical morbidity, especially in post-radiation setting with fibrosis and poor tissue planes and poor healing. And also, the functional status and the nutrition of these patients are also very important when the surgical recovery is considered. The advantage of radiation is that basically it is inoperable or unresectable cases. That is the only option available. You can target microscopic disease beyond visible tumors, and the advances in IMRT and SBRT has actually made the radiation quality better. And option of combining chemotherapy and immunotherapy has also improved outcomes. The limitations are, again, because of the poor overall tolerance of the tissues, the severe late toxicities of the carotid blowout and osteoid necrosis of the mandibles is frequent in situations. And those limitations are due to the cumulative radiation exposure as mentioned, and large radioresistant tumors, it is of not much use and probably requires careful dose summation to avoid overtreatment. When you look up the factors, we look up factors like the tumor factors, the patient factors, then we have the previous treatment factors, and also we look up the functional outcomes of these patients. So in a clinical scenario, which we commonly come across, so these are the preferred treatment because of the logistics and the patient preference and outcomes. So in small localized tumors, where the interval of radiation is less than 6 months, usually is preferred for surgery. And in unresectable tumors, or with when the disease interval is more than 12 months, depending upon the site and the patient preference and on multiple factors, we decide mainly for re-radiation. And patients with distant metastasis, usually they go for a palliative care or systemic therapy. So when you compare the outcomes of surgery and radiation, we see that it is more or less similar, with the 40 to 50% overall tumor control, and overall survival rates are also almost similar. Only thing is that the late toxicities are slightly lesser in the surgical arm compared to the radiation arm because of the poor tolerance of the tissues, with an improvement in the functional aspect in the radiation arm than the surgery arm. So in our patient, we offered the two options of salvage surgery versus the re-radiation to this patient, and the patient was not willing for surgery, so we gave radical re-radiation to this patient. So in re-radiation to this cancer, in head and neck cancers, basically the techniques of comparison, we compare the techniques. We have the IMRT, proton, SBRT, and to some extent we have brachytherapy as well. So IMRT offers the high precision, that it actually changed the practice of re-radiation with less sparing of normal tissues. And proton therapy, even though it is highly superior in limiting the dose to the OARs, having a limited availability. And SBRT is usually preferred for small tumors, and mostly with patients who prefer for shorter treatment durations. When we look up the dose and fractionation, to what dose we should treat, and what is the fractionation regimes we should treat. So when you look up different data across, but we should be balancing the tumor control with the risk of toxicity, and the total cumulative dose must be, you should have an idea of the previous dose before, and the optimal BED for effective tumor control should be around 60 to 70 gray with alpha beta 10, and the cumulative BED for critical normal tissues must be below 100 to 120 gray to minimize the toxicities. So what can we do to optimize the biological effective dose in re-radiation? So we have the advanced techniques like the IMRT and the adaptive radiotherapy. The fractionation modification, whether to go for hyperfractionation or to hypofractionate. So this is another question. And dose painting, that is, you look up the previous dose, previous plan, and you find out where the higher dose has been, and you identify those areas as high risk areas, and you probably reduce the dose to those areas. And if the previous plan actually is having a colder area in this plan, probably can actually improve that dose in the coverage area and probably optimize the plan. And careful patient selection with good performance status, small tumor volumes, and longer treatment intervals prior to radiation are also important in optimizing the BED. So when you're looking at the fractionation schedules, we can hyperfractionation or hyperfractionation has been used basically, and the recent trials are more favoring a hyperfractionation because when you look up the BED, you can see that the hyperfractionation, even though the tumor BED is around 86.4, the alpha beta ratio of the normal tissue BED is actually much less. So if you look up the long-term toxicity as a concern, you should always prefer for hyperfractionation, and this is suitable mostly in postoperative patients with a positive margin. Only issue is the feasibility we have, because we treat both these patients both morning and evening, and the machine time has to be available. The target volume delineation, we have a high risk area and an intermediate risk area. You identify the tumor as such, as the primary tumor has to be identified with the adequate appropriate imaging. And then we give a margin of 5 millimeters usually to the high risk CTV, and probably you create an intermediate risk CTV with another margin, and you are looking at the possible sites of infiltration also. And low risk areas are usually omitted in re-radiation because it increases the toxicity, and it has not been found to be useful. So when you're looking at the target volume delineation on a workflow, you have an imaging proper. We have to contour the GTV based upon this imaging, and your CTV delineation has to be appropriate for the patient. And PTV adjustment, if you are using an IGR technique, probably you can limit your PTV margins and probably do daily imaging. And technique of selection, like whether we have IMRT, proton, or SBRT, based on tumor location and size. And those constraints, like you should always be very cautious, and priority should be mostly on the OIR protection. And you should also use a deformable image registration to find out the previous plans, and you sum up the dose to these areas to see where you can actually optimize the plan. And adaptive plan on a weekly basis actually helps very much in reducing the dose to the critical OIRs. When you're looking at the post-op situation, probably your GTV is not there, so your high-risk margin will be the tumor bed plus margin, and your intermediate risk will be a margin around that. And a PTV margin of around 3 millimeters is usually considered adequate. So in our patient, we had buccal mucosa recurrence, which is close to the mandible, and it was the skin was not involved. It was a T2 tumor. So we identified the tumor with the MR and the CT, and we had created a margin of around 5 millimeters around the GTV to create the first high-risk PTV, and an intermediate risk PTV around that to create the intermediate risk of 60 gray. So we treated this patient with 66 gray in 33 fractions and 60 gray in 30 fractions on a conventional RT basis. So when we look up these patients, the most important thing that comes to our scenario is the recovery of the tissues, whether the spinal cord or the brainstem recovers well. The spinal cord is capable of subliminal radiation damage recovery, and recovery is usually slow and incomplete. And it depends upon the time interval, the total cumulative dose, and the fractionation schedule and the technique used. The partial recovery model suggests that approximately 25 to 50% recovery happens within 6 to 12 months, and about 50 to 70% recovery can happen around 24 months or longer. But we should always be cautious that the full recovery is very, very unlikely, and you should always cap your dose to maximum of 70% of the recovery. And when the time interval is less than 6 months, it is expected to have a minimal recovery only, so you should avoid radiation to the spinal cord or on brainstem as much as possible. If it is within 6 to 12 months time, you can plan radiation, but always with caution. And if it is more than 12 months, it has a better recovery, but still requires careful dose planning. When you are looking at the cumulative dose constraints, you should see that if the spinal cord is already, you should assume that the spinal cord might have received 45 gray at least from the previous plan, and if the previous plan is not available. If otherwise, you should look up the previous plan and sum up the dose and then decide on the maximum dose possible. So in less than 12 months time, probably we look up the cumulative dose to be less than 50 gray is much more safer. And if it is more than 12 months, probably you can scale up to about 60 gray cumulative. So the combination with the systemic therapy, where we can combine either with chemotherapy or immunotherapy, which has been addressed in the recent trials. And it is the concurrent chemoradiation with cisplatin has found to have an improved survival, overall survival in one of the studies which has been recently published. We should always be considerate about the toxicity and the risk management of these patients are supposed to have a higher chance of complications. We should be mindful of that. And when you're planning and all, we should be careful about the mucosa, and we should contour these structures precisely. Avoid dose to the normal tissues as much as possible. The swallowing structures, the mandible, the nearby soft tissues, the carotid arteries, all needs to have special concern in our plans. And the clinical outcomes, when you look up, we see that it varies with the tumor site. Mostly the oropharynx, nasopharynx have a good tumor response and good overall survival rates, whereas the larynx, hypopharynx, oral cavity are usually poor subsites. And the mean overall survival is usually around 10 to 18 months in many of the studies, and the quality of life impacts and the balancing efficacy with toxicity is always a concern for us. When you look up the clinical outcomes, the local control rates are in the range of 40 to 70%, and the median overall survival is in the range of, say, 10 to 18 months. The factors improving outcomes are the good performance status, small tumors, and the long interval between treatment. And it's always a trade-off between the tumor control and the toxicity. The local control rates with IMRT, proton, and SBRT find it is almost good, with approximately about 40 to 40% in many other studies. And the future directions are mostly in favor of looking up with combining with immunotherapy and systemic therapies, biomarkers, adaptive therapy, and the flash radiotherapy also is becoming much more popular in this scenario, because you're delivering a very high dose with a very ultra short time. It is supposed that there is very little chance of having a late complication. Late toxicities are supposed to be much lesser. So these are the phase 2 and the phase 3 clinical trials which has been published in this situation. And in this patient, we treated this patient with 66 gray in 33 fractions 2 years ago. And after 2 years, he presented again with us with a PET image which shows that he is having a level 2-3 node recurrence and has multiple lung metastases. So in a situation where a multiple recurrence is happening, but still it is confined within the head and neck area, we always go for a local therapy. But in scenario like this, I would like to know what Maulu is planning to do. Thank you.
Okay, so now we clearly have a disease which is not amenable for curative intent local treatment, because it has spread systemically and also to the neck. So, so we would have to look at what are the systemic strategies for managing recurrences. In this scenario, the outcomes usually are dictated by patient and disease-related factors, and they have a dismal median survival of 6 to 15 months, and almost all these patients require symptom-directed care along with definitive anti-cancer treatment. And the choice of systemic treatment is made based on patient-related factors like the performance status, the comorbidities, treatment-related factors like the previous therapies that were used, the time to relapse, and also tumor-related factors, which of late include the PD-L1 status as well as the HPV status. Now, in patients with a good performance status of 0 or 1, and having prior response to chemotherapy and having longer time since completion of definitive treatment in HPV-associated tumors, and also patients with a high tumor PD-L1 expression, they are found to have good outcomes and longer survival than the others. So these are the weapons that we have in our armamentarium for dealing with this group of patients. This includes, apart from cytotoxic chemotherapy, the molecular targeted agents as well as immune checkpoint inhibitors. Cytotoxic chemotherapy has been used traditionally for a long time. So here the question that we need to answer is whether we need to are you going to use combination chemotherapy or single agent chemo. So the balance that we need to achieve here is between response rate and toxicity. And this choice is often guided by the patient condition and the previous therapies that he has received. And it is to be noted that there is no much difference in overall survival, irrespective of whether we use cytotoxic combination or single agent chemo. So this is one of the very early trials which looked at combination versus single agent methotrexate. And they found that even though the response rates, as expected, were higher for combination chemo, there was no much difference in overall survival for these patients. So now this is the trial which sort of like catapulted cetuximab into this scenario. This is the EXTREME trial, which for the first time showed an improvement in overall survival of recurrent metastatic patients when they were given, cetuximab was added to the PF regimen, which used to be mostly the standard of care in terms of systemic chemotherapy for these patients. So there was an improvement in median overall survival from 7.4 months to 10 months with the addition of cetuximab to PF regimen, and this was statistically significant. And this improvement was seen irrespective of the HPV status of patient in a retrospective analysis. And this was done because it was traditionally thought that this group is not responsive to EGFR inhibitors. And then came the KEYNOTE study, which established the role of immunotherapy in head and neck cancers. The KEYNOTE 048 study tested the role of pembrolizumab in recurrent metastatic head and neck cancer patient not amenable for curative and local treatment. And they made a series of publications. And these patients were also analyzed based on their PD-L1 status. And this study was a 3-arm study which looked at pembrolizumab monotherapy, pembrolizumab combined with chemotherapy, and the standard arm was the extreme study arm, which was PF regimen with cetuximab. And so they found that in PD-L1 stratified subgroups, pembro, when compared with the extreme arm, produced an improvement in median overall survival from 10.8 months to 14.9 months when pembrolizumab was used in the group of patients who had a combined positivity score of more than 20. And the median overall survival was 12.3 months versus 10.4 months in patients who had a CPS of more than 1 also, compared to the extreme trial study arm. And in the total population, when the survival difference was estimated for pembro versus the extreme arm, it was found to show improved results in the overall population also. They also published a post hoc analysis which looked at patients with a low PD-L1 expression and found that this was a group which perhaps didn't benefit with the use of single agent pembrolizumab. So in patients with a combined positivity score of less than 1, pembrolizumab alone did not improve outcomes over cetuximab plus chemo. But when pembro was combined with chemo, even in this subgroup, the outcomes were found to be better than the chemo-cetuximab arm. Now, I've compiled this into a table showing that pembrolizumab alone, even in the CPS more than 20 group, did not produce very impressive response rates, but they had a duration of response which was much higher, that is 22.6 months compared to all the other patients in the CPS more than 20 group. And in patients when pembro was combined with chemo, they had impressive response rates of around 43%, and you can also find that the toxicities are comparable, and as expected, the toxicities were least for the pembro alone group. So nivolumab was also tested in this setting, and this was the Checkmate 141 study, which actually randomized patients who had progressive or recurrent disease less than 6 months. That is, this was in the platinum refractory setting. They were randomized to nivolumab single agent versus investigators' choice of chemotherapy. And they found that nivolumab produced a significant improvement in overall survival when compared to the standard therapy arm. So there was a 30% lower risk of death in the nivolumab arm compared to the investigator's choice chemotherapy arm. So this improvement was seen in patients who had, it was more pronounced in patients with a PD-L1 percentage of more than 1. And there were more futile attempts to improve outcomes. This included combining cetuximab with other chemotherapy drugs like taxanes and cisplatin. Again, did not show any improvement with the change in chemotherapy protocol. Then pembro was combined with cetuximab in this setting. Even though they had impressive response rate, it did not improve outcomes. Then cetuximab was combined with nivolumab. Again, and the conclusion was that there was no role of combining cetuximab with immune checkpoint inhibitors. Combination immunotherapy was also tested in phase 3 trials. This is a Checkmate 651, where nivolumab was combined with ipilimumab versus the extreme regimen. Again, a negative study. And nivolumab plus ipilimumab was tested against nivolumab single agent. This also did not show any benefit, and so it can be concluded that there is no benefit of combining immune checkpoint inhibitors in this scenario. So then comes the metronomic chemotherapy, which most of us use quite a lot. And this is actually low-dose chemotherapy, which is administered more frequently than the conventional chemotherapy. It has definite advantages of less toxicity, and it might be more suitable for our kind of patients who have performance status of 2 to 3 and who are like not that well built. compared to the Western population. So the metronomic chemo acts by slightly different mechanism by inducing anti-angiogenesis and immunomodulation. And methotrexate remains the most widely used regimen, and we do have some data with this regard also. And as expected, most of these studies are from India. So this is a low-cost oral metronomic chemotherapy versus intravenous single-agent cisplatin, which was tested in a phase 3 trial by the Tata group. And they found that oral methotrexate plus celecoxib, when compared to cisplatin single agent, resulted in better overall survival in the methotrexate group with much lesser grade 3 or higher adverse events. Then we also have another phase 3 study which tested oral metronomic chemotherapy versus physician choice chemotherapy after failure of platinum-based therapy in advanced head and neck squamous cell cancers. Again, it is found to have a median overall survival of 9 months versus 5 months with a better toxicity profile in the metronomic chemotherapy arm. So TKIs also play a role in this scenario. One of the most commonly used drug remains geftinib in our patient group, and this was tested against methotrexate 40 milligram per meter square given weekly in a metronomic dose scheduling, and it is found to produce similar survival outcomes. And in the second line setting, afatinib was tested against the weekly methotrexate and found to have similar objective response rates, similar rates of grade 3 toxicity with no difference in overall survival. Now, a recent trial which was published was the low-dose immunotherapy in head and neck by the Tata group, in which they combined the oral metronomic chemotherapy along with low-dose nivolumab, that is a 20 milligram flat dose given every 3 weekly, and this was tested against oral metronomic chemotherapy plus erlotinib. And they have reported an improved overall survival outcome with the addition of low-dose immunotherapy with a favorable toxicity profile also. So the efficacy, however, the efficacy of the low-dose regimen in comparison with the full-dose regimen is unknown. And this is a single institution study, and there was a large number of oral cavity primary tumors in this trial. So after listening to all this data, so the take-home messages that I would like to highlight is in this flow chart. So if a patient comes with a recurrent or metastatic head and neck cancer, we will first look at if he has received previous systemic therapy or not. And if the answer is yes, then we look at the duration after which he has progressed. If it is within 6 months of platinum-based chemo, then the obvious options are immunotherapy based on the Checkmate trial. We can use Nivo or Pembro. And if the answer is, if the progression is after 6 months of previous chemo, or if he's not received previous systemic therapy, then we recommend PD-L1 combined positivity score analysis. And if it is more than 1, and if the patient is eligible for chemoimmunotherapy, then we look at the progression rate of these tumors. And in a patient with a rapidly progressive disease, our choice of treatment would be chemo combined with Pembro, because the response rate for single agent Pembro is not very good. And if the disease is not rapidly progressive, and if the patient is not fit enough for a combination regimen, we can consider single agent Pembro. If the combined positivity score is more than 20, then the options would include single agent Pembro or Pembro plus chemo. And if the CPS is unavailable, or if the patient comes in a poor performance status, then we could still think of combining chemo with Pembro, or think of the extreme regimen, that is chemo combined with cetuximab or chemotherapy alone. And in patients with poor performance status, our obvious choice would be single agent chemo, perhaps a metronomic chemotherapy, or even best supportive care. So at this point of time, we've now heard a lot of options which could be used in this group of patients. So we can consider re-radiation, and in patients not fit for radical local treatment, we can think of multiple options of chemotherapy. But after all this, what we should remember is that our aim, the ultimate aim should be to improve the quality of life of these patients. So eventually our choice should be made to achieve this goal. Thank you.
Thank you. Very good presentation, Malu and Dr. Anup.
Thank you.
So, is there any time for a discussion? I have a question to Dr. Anup. When you consider re-radiation, what is the role of brachytherapy?
So there is recent data from Japan which shows that brachytherapy is a feasible option in re-radiation to accessible sites like the lip, gingiva, buccal mucosa. There is a Japanese study which has shown that it is feasible and it is without much of a toxicity as it is expected. So, but the data is limited, sir. In overall, it is limited.
In this particular case, which was discussed, it was confined to the buccal mucosa. It is an accessible site.
It was closer to the bone, sir. It was closer to the retromolar trigon area.
It was close to the retromolar.
The bone had already received 67.
Okay.
In this case, brachytherapy was definitely not option in this case.
No, sir.
Yeah, so as an extension...
If it is anteriorly situated, then definitely there is a role.
Anup, as an extension to question what sir asked, where do you see specially fractionated radiotherapy coming into the picture in such recurrent scenarios? SFRT or grid therapy? Grid therapy. I was waiting whether any of your slides mentions that or not. So typically this case is not ideal for grid therapy. You know, many of our patients, they cannot afford all complex chemotherapies or immunotherapies which ma'am referred to. We can do SBRT or irradiation, which again causes some element of quality of life compromise during that irradiation context. Say whatever proton or whatever technology used. We started using SFRT for such kind of complex cases where the lesion measures more than 7 centimeters. You have to place a dose grid inside. So the mechanism is basically through what I would say activating the bystander effect of the surgical doses of radiation which we'll be shooting. And we have seen some very good interesting results and we are writing the paper on that. But I would suggest, you know, in such cases, it is worth trying grid therapy also as one of the options. I don't encourage you to use it somewhere inside the oral cavity, but nodal failures, large palliative situation, grid is the best option is what I personally feel.
So basically one comment and one question. The comment is that regarding the systemic treatment, you know, especially the immunotherapy, if you see all the keynote address trials, the performance status is very important. Most of the patients who have been accrued in these trials are having, you know, ECOG 0 or ECOG 1. But I have seen in my, you know, most of the time what happens that our patient already compromised, you know, general condition and people right and left are, you know, prescribing the immunotherapy. So that is one comment. The question is that any guideline for re-radiation about the dose constraint to carotid artery?
So it is supposed that you should limit your dose to the carotid to less than 100 cumulative dose possible. And your BD you should be more careful about the carotid because the carotid blowout chances are the most common thing which happen in a re-radiation setting. So you should contour your carotid, you should give contrast, contour the carotid, limit your dose of carotid if possible. But many times what happens is the tumor will be very close to the carotid, and unless we have a proper image guidance available, it will be very difficult and probably maybe suicidal also to try to reduce dose of the carotid sometimes.
So
but it's a major concern, sir.
Yeah, it's definitely a trade-off, especially for carotid. Even in SBRT, that is a major challenge. So I feel that like if the carotid stent is very much available now, if you have that much risk, actually you can put a stent and then re-radiate. If you leave, there is a disease will take over and there is a burst. If you treat, there is definitely the less burst, less actions of like in terms of carotid blowout. So you need to weigh between and have a trade-off. So one more comment actually, very nicely presented. So you came up to the the metastatic setting. It's a clearly oligometastatic at that site. So you didn't go the one step ahead.
We didn't mean it to be oligometastatic.
Yeah, so it is, if you are not maintaining it as an oligomets, the node will disappear, the lung mets will also disappear. There may be lesions which may be residual. That is an ideal cases for the SBRT to take care at that point.
We didn't actually touch upon the oligometastatic scenario because...
Thank you, sir. Unfortunately, we are running short of time.
One more question. Yeah, sir, please.
I know. Just a comment regarding the immunotherapy, as sir said, no, it's a main concern is the patients who have in the first line and second line treatment. We need to understand that the patients, the clinical trial checkpoint 048, only 0 or 1 patients were included. So performance status is really important. The patients where if a patient has his performance status 2, and whether the patient is having a first line or second line treatment, and there is no evidence to give immunotherapy, and that's one point. That second point is that always we should consider that the patient's inclusion criteria is that the patient should not be a candidate for local treatment. The patient who is not a candidate for revision surgery or re-radiation, then only you should consider the immunotherapy. Okay, thank you.
Okay, thank you, thank you.
Thank you, sir. As a token of our appreciation for their invaluable contribution to the session, we would now like to present the mementos to esteemed chairperson and the speakers. I request Dr. Aravind S. Anand, so Professor, Head of the Department of Radiation Oncology, Government Medical College, Trivandrum, and Chairperson, Scientific Committee for our event, to do the honors. We now move forward to our next session. Our next session focuses on an exciting area in the radiation oncology, SBRT for prostate cancer. To deliver this insightful talk, we have with us Dr. Sridhar PS, Senior Consultant, Radiation Oncology, Lead Cyberknife, Apollo, Bangalore. And to chair the session, we are honored to have Dr. Jayakumar Sir, Professor and Head of Department, Radiation Oncology, Sri Mukambika Medical College, and Dr. Jose Paul Sir, Senior Consultant, Rajagiri Hospital.
Good morning, Doctor.
Slide change.
No. Straight away you can start your topic. You know, SBRT prostate is a good topic. And it's wonderful.
A very good morning to everyone. Am I audible? So, another 30 minutes probably I'll be talking on SBRT for prostate cancer, overall setting. See, if you see the projection of cancers in India is going to be around 15 to 20% increase in cancer patients by 2030. 2050 they are expecting around 30%. And this is the main the cases what we are looking at. Top 10 cancers, even in India, the prostate cancer is going to be in rise. So if you see the mortality, sorry. It's a, yeah. So as we know that the mortality of the prostate cancer is very, very less. They survive, the patients survive a longer time. And if you see that at any given point of time in India, actually there are more than 35,000 to 40,000 prostate cancer patients. Yeah. So if you see the prostate cancer, it has come a long way. See, if you are still looking at radiation is one of the options, there's no doubt about that. External radiation had made a difference in case of prostate cancer. And if you see the risk stratifications, and when you're planning any of these prostate cancer patients, you should also check it out. What is their 5-year survival rate or a 10-year survival rate, T status, PSA, and the extent of the disease. So if you, in a low and intermediate risk prostate cancer, there is no debate about that. The SBRT has come in a long way, and there is a very clear indications that in low and intermediate risk for prostate cancer, the SBRT plays a major role as a monotherapy. So I don't want to touch upon that, because I assume that we are come long way, especially to make sure that SBRT is the standard of treatment if you have the facility to practice. And the controversy is in high-risk prostate cancer, where we have an options of treating with the hormone treatment along with the radiation. So I would like to ask a question here. How many of you are a believer that in high-risk prostate cancers we require a pelvic irradiation? 1, 2, 3, 4, 5, 6, okay, 7, 8, 9. So how many of you believe there is no need of the radiation of the pelvic irradiation in case of prostate cancer, high risk? 1. So other people don't want to believe the prostate cancer should be treated with radiation? So there is, actually I belong to the second group, where I feel that in prostate cancer, treat whatever you see. So if it is not there, there's no need to treat unless we are, since you are using in high-risk prostate cancer, hormone treatment. So that my whole basis is on that. So I don't treat the pelvic radiation, in high-risk prostate cancer, the pelvic nodes, as an elective nodal irradiation. So if you see a node, go and treat only that. So that is one of the things I would like to highlight here. And there's nothing wrong in it. Actually, that is the world is divided in that. They treat with the SPR, like the radiation, the whole pelvis, versus treat only the prostate cancer only. So coming to the SBRT, we know that the SBRT is in thing. We can use an SBRT in many occasions. And I'm sure that you have one of those machines which can be definitely fit to consider SBRT is one of the treatment. And these are the one. And proton therapy is another one which is coming up in a big way. I moved to Apollo. That's one of the main reasons is for the proton therapy. SBRT and the proton therapy is the one that I'm looking at. So the requirement of SBRT, you know that clearly. You have a clear, I'll say it's not coming. Okay. Achha. So it's a small target. To start it as a small target, it's not necessarily a target is an issue. So I think it is against some of the speaker. That's why it's, yeah. So sharp defined margins. And as we know that mainly we're looking at the high dose to the target and as less as possible to the surrounding structures. So I don't want to go detail into that. Different dose fractionation SBRT is in practice now. I usually practice 37.50 in 5 fractions. And alternate day is the one what I'll do it only to the prostate. I'm going to show that. There is enough articles. It may be hyperfractionation, short fractionation, 25 fractions. So from 33 to 35 days of radiation, we have come down to the 15 days of radiation versus 5 fractions. Some people have given single fraction, like 25 to 27 grade single fraction to the prostate. So this whole of the SBRT scenario started with the prostate, and we have get a robust data. And if anybody wants to start SBRT, other than the brain and spine, probably the prostate is one of the best. That is what is my opinion. And whenever it is, this is a short prayer, please go through that. Iris prostate, along with when you are using the SBRT with hormones, it has definitely shown the better local control. And the confusion about in the ADT in those settings is when to start. It may be neoadjuvant, or it's a short fraction, 6 months, or 1 year, or 3 years, depending on your practice, you can consider. So in a very selective patients. So how we do it, risk stratification and baseline evaluation is a mandatory. There is no, as much as possible, I have a multidisciplinary team approach. And we insert the gold fiducials for the tracking. So usually it is with the aseptic precaution and make sure there is no infection, because urinary culture and the blood culture has to be there. Make sure that patient does not have infection. That will unnecessarily hinders the radiation and also the infections. And it may also has an impact on in terms of treatment-related side effects also. So I usually do CyberKnife PET PSMA planning. So I'm going to talk a little bit about that. So for all patients, irrespective of the low risk, intermediate risk, or a localized tumor, I do the PSMA PET CT planning. MRI and the PET CT is definitely one of the investigations which is to be required. Either it may be in terms of metastatic workup, planning, follow-ups, and even in terms of to identify the early recurrences. So how we mark it? I mark only the prostate and the GTV PET as a separate. So GTV PET and the prostate, in this case is the whole of the prostate, and neurovascular bundles and rectum and bladder is one of the organs at risk. 35 gray in 37.5 gray in 5 fractions. Alternate day is the one what we do it. In this is the scenarios actually you can use if you have a spaces. There are a lot of things is come in terms of treatment-related side effect. To reduce the treatment-related side effects, you can use amifostine as intrarectal, or it may be balloon, or it may be a rectal balloon, or spacers. Now what we are talking about, this spacers, so that you can push the rectum to the away. So urinary and GI and erectile dysfunctions to be monitored in a continuous manner. And response assessment depends on biochemical pH. The PSA, I usually do it once in a month for first year, because in the low and intermediate risk, make sure that the spikes are there. It always gets confused and people may think that there is a progressive disease. PSMA PET CT scan, MRI, MRS, and quality of questionnaire to be considered. So with the experience of almost around 5,000 odd cases, only the prostate cancers I might have treated around 500 cases. So some of our work which is already published. In this actually what we did is PSMA, this is actually published in 2018 in Astro. So as one of the thesis, what we did is PSMA PET CT RT planning. So I have a baseline PSA, SUV value like PSMA PET scan SUV value, MRI, and there is always a confusion that if the MRI wise when you take it, only ADC value is the only one. If the PSMA fluctuate, it will confuse. Either it is responding or not. So especially when you are treated low and intermediate risk, the surgeon is already told the surgery is required if the PSA is not coming down. So that is one of the things what we did is to correlation between the PET PSMA, MRI and ADC and PSA, which correlates very well. We have seen in our data itself, the SU value reduction and the PSA reduction is very steep. Within 3 months, you can see that it may come down to 50% of the primary one. So our this one is 50th percentile drop occurs in every month on month basis. At the end of 1 year, it should come to less than 4. So from the whatever the value what it is there. So most of the patients will come to less than 2 at the end of 1 year. So that is to be noted. And ADC value, improvement in the ADC value is one of the things what we see. So if you see here the size of the lesion, the first one is actually ADC value, the MRI ADC value. So there is an improvement which has occurred whenever there is, and there is in some patients it dips and then improves. And the PSA and SUV values, PSMA, the PSA and SUV steadily comes down, and at the end of actually like 1 year, it should come down to the extent of normal levels. So another one in terms of treatment related, this is also we have around around 180 patients. We have used intrarectal amifostine as a radioprotector, because that is the time actually we were, when we started around 18 years back, we were actually scared that what is going to have a long-term rectal toxicity is one of the factors where we always told that SBRT has a long-term side effects, other than the urinary toxicities. So we taken precaution in that. Practically in our series, not even the treatment-related toxicities which requires treatment is not even 2%. So there is a transient grade 1, grade 2 toxicities which occurs, which usually subsides after the after 3 to 4 months. So this is the same. And coming to the high-risk prostate cancers, going one step ahead. So I have not shown our high-risk prostate cancers where we are talking. So there is no, with the hormone treatment. The moment if you give the hormone treatment, there are a lot of things are settled down. Systemic treatment is taken care, then the locally also there is a good action. And only the prostate is where we are treated. There are subset of patients, I get patients across the board. There are a lot of patients comes and say that we don't want hormones. So these are the patients actually I have treated only with high-risk prostate, only with SBRT. So which is as a part, you can take it as a part of the trial. So initially as a 21, I have already reached around 50 patients of those patients where they say no treatment related, no hormone treatment, we don't want any hormone treatment. These are the patients, if I see lymph node with the PSMA, PET scan and MRI, I go and treat only that node and prostate proper. Whenever there is an high risk, we have included the periprostatic tissue, capsular also, and neurovascular bundle is usually, if it is not involved, we always save it. So in our surprise, actually, like it's the PSA, the cutoff for the using the hormones in these cases is more than 50. But some of the patients are 80 years, they say that we don't want the hormones, only one. So we have seen that the only 15 to 20% of the patients had progressed either locally or it's in the metastatic. Majority of these patients usually fail in the metastatic one. If you use in a metastatic setup, the inclusion of the hormones versus early addition in the iris, I don't think so there's a major difference. Whenever you're using in iris prostate with the hormones, you are using only for 3 years. Afterwards, anyway, you are stopping. So actually, this is one of the studies where you can see, you are seeing the biologies, the behavior of the prostate cancers. So in case of here, this is how the planning comes. And prostate only, the outer one blue area, if you see, is actually the 30% of the dose. The pink area is the 50% of the dose. And the treatment related, this is, the first one is the PET-CT planning where we have marked the PET uptake and the prostate. And the MRI wise also, I can see the responses after the treatment. There is SUV reduction and no treatment related toxicities. Going one step ahead, so we have modified the low and intermediate risk prostate cancer with a single PET uptake nodules. This is one of our patients where his PSA was 25 to start with, and we treated with the SBRT. 1 minute, I'll come to this is a prostatic nodule. Whenever you see a single nodule, now it has already come using dominant nodule. So in this case, actually, like extrapolating some of the other places, we treat the multicentric or either is a small nodule uniformly in case of prostate cancers. So here in this, whenever the single nodule, MRI wise says, MRI wise, no problem. So if you, according to the MRI wise, if you see, there is this dominant nodule is there. This dominant nodule is treated, given 45 gray in 5 fractions. So that means like 9 gray per fractions I have given that. And to the whole of the prostate, I feel that 37.5 gray is not required. So I limit it to 35 gray. So 35 gray and 45 gray. So I have dose escalated as an SIB in case of dominant nodule. And then actually, this is the post-treatment exactly after 3 months. The SUV reduction is almost complete. And the PSA, so this is the plan. We are able to achieve 45 and 35 to the whole of the things. So in terms of the MRI wise, the first one is the nodule, and actually the nodule has disappeared actually after the 5. And in the PSA, decrease in the PSA is it started with 25. Within a span of 5 to 6 months, it has come down to around 1. So and it is maintaining without treatment-related side effects. So that is what we are looking at. There is no need to give the whole prostate the full dose. Even in high risk, if you have a good PSA, if the patient is eligible for strong follow-up, and even the MRI is there, if you are able to convince him, I prefer that like to wait and watch rather than addition of the hormones in a highly selective individuals where they say no need of hormones. So, and you need to explain in these patients especially, so the risk of disease progression and addition of the hormones at that particular period. So, this is in high risk. In overall understanding of prostate cancer itself may be different. So I may be sounding very, very radical versus like no. So where we are given 3 years of hormone treatment without the hormones, I am waiting, like wait and watch. Some of my patients are almost crossed 10 years. So like we can really know that and use it judiciously is the one in case of prostate cancer, what I usually follow. Any patients who had a lymph node in the SBRT, we give only 30 to that area and 37.5 to the prostate. So no elective radiation. Shifting gears, oligometastatic disease. So this is my favorite topic nowadays because radical intent with a radical treatment with low and intermediate risk prostate cancers. Whatever you do, 1 or 2 patients will recur. And I always challenge my surgical colleagues, probably the prostate cancer with SBRT is equivalent to or better than in case of like prostate cancer, better than the surgery. So if you see in the same thing, you cannot make 100+% of survival. So it is like no 1 or 2% are failing because of the genetic factors. Yes, genomics is very important in prostate cancers especially, and there is no need to hurry and start everything. So my question for the surgeons is especially there is a PSA starts increasing, we are hurriedly we started giving radiation, we are giving hormone treatment. These are the subset of patients where I have treated like observed for almost more than 10 years now, so we're not really required. It is proof of concept, actually definitely we can go ahead and like propose a trial. Oligometastatic disease, whole of understanding of oligometastatic disease started with the prostate cancer. So this is the definition. And especially the prostate cancer, in our practice we have seen, so like there's one metastatic disease, one bone mets with the prostate cancer, give hormones, same treatment is given, even with a multiple metastasis, same treatment is given. So these are the subset, and N1 is a stage 4 in case of prostate cancer, even a single lymph node, you have given the hormones for minimum 3 years. If you go by definitions, you need to go continuously more than 3 years also. So this is where we are seeing less than 5, polymetastatic disease is oligometastatic disease, less than 5 lesions anywhere in the body is considered to be oligometastasis in prostate cancer. Standard treatment is to start hormone treatment, and then depending on that, local radiation is not done in case of oligometastatic disease in any of those trials, including Stampede trials. So what we did is in this, so this is actually the oligometastatic disease. Up to 5 lesions you can go and treat upfront. That is what we are doing now. And if in the polymetastatic disease, if the chemotherapy is given downstage, and whenever it is amenable, go and treat the metastatic sites, oligoprogression, oligoresidual, versus treat the primary always, is the concept what I follow in case of prostate cancer or any oligometastatic disease. If the primary is not treated in the past, go and treat the primary as early as possible. So there are different schedules is there in case of the mainly the oligometastatic disease, breast cancer, prostate cancer, lung cancer, and the colon cancers. Even head and neck and cervix is one of the best things for Indians especially, because we are seeing the survival. The patients are, at least 15 to 20% of our patients are coming back with the metastatic disease in these cases. So SBRT for oligomets treats mets alone. That is what some of the people say. Why you need to treat the other things? Treat primary, and treat primary alone as early as possible, and then wait for the metastatic to know the response to the chemotherapy or hormone treatment, which I feel that it's not really required. So combinedly we're treating, I think we should treat as early as possible. Treat both primary and mets. Immunotherapy with SBRT is the big game changer. We are going to use this in many of the cancers, not especially for prostate cancers. Hyperthermia with SBRT is another thing. I would like to probably one of the good things, alternative to immunotherapy, and genomics is mandatory in these cases. So advantages for oligomets is 5 days treatment, accurate focused high dose radiation, radiobiological advantages because you are like making the cold tumor into hot or getting abscopal effect. No delay in systemic treatment because it's short duration. Local control is equivalent to surgery. Doing SBRT for more than 6,000 or 8,000 sites, I'll tell you that local control has reached to more than 95%. So definitely only the progression in the site where we are treated is only 2 to 5%. So please go and check it out and start implementing as early as possible. Synergistic effect with immunotherapy, yes, that is known. So these are radiobiological advantages. And in this is the first SBRT in oligometastatic disease treating primary, where Stampede trial started in 2011-12. So we started in 2009, treating both the primary and the metastatic sites. So this is also Astro published. And we have seen that the median survival has actually reached to 117 months. So these are the patients where, like we see, prostate cancer is surviving more than 10 years as an average. So like there is no need to hurry up as early as much. And local recurrences. So in post-radiation or any of the radiation, isolated local recurrences are not even 2 to 5%. So we have studied with the brachytherapy, all other things, telling that the radiation is very difficult. We have treated only the nodule wherever there is a recurrences. I've treated around 12 patients. There are 2-3 patients where there is a local recurrence. So after 11 years, actually one of my patients had a local recurrence. I've treated only local recurrence. Still now I have not given the hormone treatment even after the local recurrence. So that is possible and it is very safe. I usually do a catheter. But during the treatment for the local recurrences, only thing is you can prevent the stricture or urethral injuries, especially in a re-radiation settings. To conclude, SBRT to high-risk prostate cancer, please look into that. Yes, it is possible. It is not like something crime to say that we cannot, because we talked about the quality of life. If a patient wants that quality of life to be maintained, I think we can offer these patients. Definition of oligomets, low versus high volume, timing of SBRT, upfront, sandwich or consolidate as early as possible is the one what I'll tell. If the patient is eligible for upfront, please consider. Combination of FAPI therapy with SBRT is another things which we are starting, where 3 to 5 lesions is there. Give one fraction of FAPI, use SBRT to the sites and continue the hormone treatment in these patients. And SBRT dose, radical versus palliative, I prefer, there's nothing like a palliative dose. So for a particular area, it is a radical dose. Please use minimum of 30 grain 5 fractions for the metastatic sites also. Primary according to the convenience of radiobiological equivalent. I usually go minimum of 100 BED plus or minus. I don't believe in extreme the doses also to going up to 300 BED, like where we are talking about 10 into 5 or 12 into 5. So it's playing in between is the one what is safe, which has worked for me. So SBRT with immunotherapy combination is the one. So thanks to my team back home, and I appreciate your patience hearing.
Thank you, Sridhar, for taking through our journey on SBRT. And I think your overall treatment time would be 10 days, no? 5. Yeah. Alternate day you give.
So in prostate cancer, actually, after the fiducials, it's actually 18 to 20 days. After the fiducials, we wait for 3 to 5 days. And both PSMA-PET scan and MRI is done. And within 48 hours, we'll plan. Treatment is alternated for 5 years. In fact, I have treated 2 patients where, say, the urethral injury was one of the factors what we always thought, because in a plain scans you can't identify the urethra. So it's a brachy-like the dose distributions to save the urethra was one of the things that people practice. But 37.5 alternate day, rectal toxicities and the urethral toxicity becomes very good. But if the patient agrees to have a catheter for 10 days or 5 days, so I feel that you can mark the catheter urethra and then you can give, probably you can reduce to 36 grade. Like no need to go for 37.5.
Do you do SBRT for patients who are TRP?
Yes. So that is another thing actually. So post TRP patients, if the urethra is seen properly, So it's nothing to worry about that. In the series in the past, SBRT is blamed for the patients who have underwent post-TURP for two reasons. One is treatment-related toxicity during this one is a little bit more, urinary disturbances, and stricture. See, any patients who had a urinary tract infection, there is a stricture already there. So inflammation is already there. When we give SBRT, there is a cicatrization it may happen. What I usually do for those patients is, as a planned treatment, as a planned procedure, I usually use 3 to 6 months afterwards, either a one catheterization or get a cystoscopy. It is like a esophageal strictures. If you just use one catheter within 6 months of the radiation, actually you can prevent the urethral injury, urethral strictures.
Again, regarding high-risk patients, avoiding hormone is an experimental treatment.
Correct.
You have done, sir, for some patients, but there are lots of trainees here. So the standard of care is at least...
I want to repeat this very clearly. It is, as for now, for the examination, hormone treatment maybe say, same thing they told me 15 years back also, a lot of places. In case of hormone, there's high-risk prostate cancer. There is, hormones is an integral part of the treatment. If you go one step there is always the people say that, how long we want to give the hormones? That is also in the examination questions. Please read about that also. And if you start a hormone treatment now or a metastatic disease, is there any change in the survival in case of prostate cancer? So that is for everybody to think beyond what is existing in the literature.
Another thing is regarding focal boost, the evidence of level 1 evidence is for MRI based. The PET based level 1 evidence doesn't exist. Now,
So
I agree it may be true.
No,
level 1 evidence.
I'll tell you another point. PSMA PET scan when it came in the Europe. You are all following the US based. Even right now, the PSMA PET scan came in US as a part of the investigations after 10 years. So if actually Vedang is doing a trial on PSMA PET CT based RT planning, so this is published. So we started PSMA PET scan 18 years back. We were not available like at that time. So time, place and person probably makes a difference. I was in a different place.
See there, one last question. If I...
Phase 3 trial doesn't exist.
Absolutely, I agree with that. There's no crime if you don't do it.
See there.
Dr. Sridhar, I'll have to strongly disagree with you on what you said. Okay, personal philosophies are different, but what Francis sir said is the fact. You will never get the spatial resolution of the MR on your PSMA PET. Okay, and that's a fact and the trainees should go, not just the trainees, people should go with the clear idea that PSMA PET is not a replacement for the MR as far as SBRT prostate is concerned. So that's one. That's one. Second thing about high-risk prostate cancer, once again, Francis hit the nail on the head. You cannot advocate it in day-to-day practice unless the patient is unwilling for hormones. So I think Francis put it very clearly.
So, as a continuation of what Sir alluded to, if I'm not mistaken, I remember only 2 clinical trials, the hypo-RT-PC and the PACE-B, which have actually used the localized low and intermediate risk prostate cancer, SBRT versus CFRT. That was the kind of evidence we have. Kindly educate me and the students in the audience, what is the evidence for SBRT versus SFRT, conventional RT, in high-risk prostate cancer? What should be the present standard of care?
See,
the point which I'm trying to make is SBRT in high-risk prostate, I still believe it's a little premature because the maximum evidence we have is a phase 2 clinical trial in 40, 50 or maybe 100 patients.
I totally agree with you.
But you don't have a randomized controlled trial which says, okay, high risk, we can still go for it. We can do it. It's not that...
No, the SHARP trial is talking about that.
No,
this
again,
is SHARP.
I understand that. But the quantum of the patients who are actually included for it, at the end of the day, we are speaking about a comparison between a hypo protocol and an ultra hypo protocol. I don't see that evidence in the literature backing up.
So, I totally agree. I'm not talking about that you need to go and practice tomorrow.
That comes back to the first question. what should be the current practice in a high-risk prostate cancer? I'm still comfortable doing a hypofractionated protocol, the CHIP protocol or whatever protocol, rather than rushing it for this, just for the simple reason that the follow-up data, what we have is less in high risk, number one. Number two, there is no real-time or a randomized control data showing a comparative evidence.
Yeah. So two things. In all the patients, when I am talking about the PSMA PET scan and MRI based, so there is nothing is replacing anything. Both are required. So there is no second thought about that. If you don't have a PSMA PET scan, you are gone with that, okay, telling that no problem. But MRI is a necessity for that. So PSMA PET scan adds a value in terms of local control, local marking, if there is a nodule, or in terms of metastatic workup. And follow-up one, definitely it can pick up even if there is a HRPCs. That is one question, one thing. Second point in terms of practice. In prostate cancers, if you go back and check it out, how the practice has changed with the surgeons in terms of oligometastatic disease, and in terms of high-risk prostate cancers, after hormone treatment, going the chemotherapy, doing surgery after neoadjuvant hormone therapy, he is already practicing. I am not talking about like you have to change the practice, what I have shown. I am telling the trend is, yes, it is a possibility. I have practiced this. Is my personal experience. If you want to go by books, it's your wish.
It's not a question of as you go by. It's question basically we have to go by evidence. So we have to look at the evidence. So what Shankar is telling that in high risk probably hypofractionation is fine, but SBRT probably we still need to generate evidence before we switch over.
For positive time, just one more question, please. Just one more question, sir. One question.
Yeah, it's very clear. The concept till now in high-risk prostate cancer, because it's 3A. 3A means capsular invasion. So in this setting, whatever NCCN guideline or whatever the evidence are with us, we have to go for moderate hypofractionation plus ADT up to 18 to 3 years. That is the standard of care, number one. Number two, yes, Sridhar has highlighted that, yes, this is also a scope that we can extend this concept, particularly the SBRT for the high-risk group, but with the addition of amifostine.
No, not.
Then now the question arises. Wait.
You are talking about treatment-related toxicities. See, you are talking about two different concepts.
No, just, yeah, very clear that your concept that yes, there is also a scope that I can also use the SBRT in high-risk prostate cancer. But I think you didn't highlight the incidence of proctitis. Yes. So what is the incidence?
This.
The proctitis is not even 5%. Grade 2.
And what are the volume of the disease?
Sir, excuse me, sir.
Yeah.
For want of time, I think we'll take the discussions offline. Just one thing I'll add. Page C has reported in the preliminary thing, and actually the SBRT arm shows a higher incidence of proctitis and cystitis. Sort of 25 to 30%. I don't remember the exact data. But I think for the sake of time, I think we'll take the discussions offline.
So here TTE is only prostate, sir. No margins is given. In all the things, they are given minimum 3 to 5 millimeter margins. Even in case of that, any time if you give a margins, then the whole things the reactions will be. I'm not given any margins. SBRT with fiducial based packing and practically no treatment.
Okay, thank you.
Yes. Thank you, sir. Thank you, sir.
Thank you,
That was
Sridhar.
indeed a very informative session. I request Dr. Jostom, sir, Professor and Head, Department of Radiation Oncology, Caritas Hospital, to present a memento as a token of appreciation.
Thank you, sir. As we continue with our academic sessions, we would like to inform you all that the tea will be served in the hall due to limited time availability. Please feel free to help yourself during the session and we appreciate your cooperation. Our next academic session is radio surgery for functional beam indications, thinking beyond the scalpel. I invite Dr. Shankar Vangipuram, Senior Consultant, Radiation Oncology, Apollo Cancer Center, Chennai, an expert in this field, to deliver his insight and knowledge. To chair this exciting session, I request Dr. Siriraj Sir, Associate Professor, Department of Radiation Oncology, Government Medical College, Trivandrum, and Dr. Prema Madam, Professor and Head of Department, Radiation Oncology, Government Medical College, Thrissur.
Are you able to project? Not happening. It's not happening. Shit. Yeah, a lot of time goes by. Give it to me. I have to put it there inside. Shit. Shit. So can we go for the next talk? It is better. Oh, okay, I'm getting it here. So, I usually project from my lab. Why is it that's the reason why it will not transfer. You have removed the connection.
Sir, it's...
Transfer.
Can you please copy to this? Can you please copy to this pen drive?
I'll do that.
Sir, then will we connect.
Okay.
Sir, I will do it.
It's transfer.
It's transfer.
So I'm very sorry about the technical snag I'm facing. So as the process goes on, I just want to know, a show of hands is good. How many of you practice functional radiosurgery? Show of hands. Okay, see, always I know that. Okay. So I'm sure I see good number of residents there. Any idea about the kind of indications that we can do? Beyond neuralgias, trigeminal neuralgia is something which all of us listen to about. I'm so very sorry about all this. Yeah, that's a short note question. So what you'll be listening over the next 30 minutes is something which is not taught to any of us in Paris textbook, I can guarantee that. And probably in neurosurgery textbooks, not into the depths, because what I'll be speaking is an experience which has been garnered over the last 24 years of my practice.
Where is best?
It's not on the desktop.
It's loading.
It's loading. I'm not using it.
Sir.
So, Arvind, if you want, you can take the next lecture and then follow it up with mine. Does it make sense? Because see, do you have an adapter, MacBook adapter with you? Do you have a MacBook adapter? Huh? See. I'm sorry, I think we'll allow the next speaker to come down and then chase it up with this. While we fix this.
Due to technical issues, we'll be moving on with our next speaker. The topic for the next session is Hallmarks of Cancer and its Clinical Importance by Dr. Surendranath Senapati, Professor and Head, Department of Radiation Oncology, SCB Medical College, Cuttack, Orissa. I invite Dr. Surendranath sir onto the podium. I request all the delegates to maintain silence.
Good morning. So at the outset, let me thank the organizer to invite me, not only as a speaker, but as the president of ARI. So I thought that what I have to speak. Radiotherapy, okay. But the recent concept, we are using a lot of IO, lot of targeted therapy. So in front of me, a lot of students are there, but they are busy with the tea. Fine. So I'll cover the basic things, that what is the basic philosophy, that how, because we are all oncologists, and we deal with the cancer. So what is the hallmark of cancer? For last 30 years, I had not understood what is the hallmark of cancer, particularly if you'll see that picture in David. And the basic concept of the molecular or the targeted therapy based on the hallmark of cancer. So with this, I start my topic with praying to the Lord Jagannath. All you might have known from Puri. It's not working. Okay. So my topic of presentation, that is the hallmark of cancer and its clinical implications. Friends, we know the basic three things, that is the carcinogen, whether it is virus, radiation, or the chemicals. Ultimately, its target is the gene. So what happens at the genetic level? So this is the basic concept of the hallmark of cancer. So in hallmark of cancer, that is, there are 6 hallmarks that was coined in year 2000 by the Hannan and Weinberg. But subsequently, in 2011, they added 4 more hallmark of cancers. And in 2022, they added also another 4 hallmark of cancers. So total, that is 14 hallmark of cancer. So what it means? If you'll see here, that is the first one, the sustaining proliferating signaling. This is nothing but only the concept of proto-oncogene. Then comes the evading the growth suppression, that is the tumor suppressor gene. Then comes the histone acetylation and DNA methylation, here the concept that we are all using temozolomide in case of glioma. So it is the methylation of the histone. Then comes the avoiding the immune destruction, that is the cancer immunity. Then comes the enabling the replicative immortality, that is the concept of telomerase. Then the few other concept that also comes to the picture, that is tumor promoting inflammation. Here the growth factor and cytokines that takes the major role. Polymorphic microbiome, that is gut microbiomes. Then comes the invasion and metastasis, a very old concept, and from undergraduate career we are studying this. Then inducing or the accessing the vasculatures, that is the angiogenic switch, where we use a lot of VEGF inhibitors. Then comes the senescent cells, that I will also cover. Genomic instability and mutation, this is well known. Then comes the resisting the cell death, the concept of apoptosis and the drugs against to this. Then very important, the anaerobic glycolysis, that is Warburg phenomenon, that is responsible for the deregulating the cellular metabolism. Unlocking phenotyping plasticity, that is the what the cells undergo terminal differentiation. So these are the different hallmarks of cancers. So I think it's not working. So based on this, for the students, you can hear that this is the chromatid, the structure of chromosome, and in chromosome there are two chromatids, and they are being connected by the centromeres. And the short arm is P and long arm is Q. And if you see here at the end, there is the presence of telomerase. Okay? And we can also, for the nomenclature of each gene or each chromosome, that is the arm P and Q. And again, can I have the button microphone? I think it's not working. Can I have the button microphone, please? That button microphone is either. Okay, so if you can see here, here is the first is arm, that is P and Q, short arm and long arm. Then comes the region. You can have the one. Yeah, I think that's better. And then the region, that is, it starts from the centromere, region 1 and region 2, or region 1 and 2, that is for the short arm and long arm. Then comes the band. Then comes the subband. So by this, as for example, if you go through 8Q2412, that represents the c-MYC gene. So by this, it has been numbered. So these are the concept of the gene, particularly proto-oncogenes, and they are responsible for the tumor promoter genes. And these are the different genes where the different genes are present. What happens? In our body, there is presence of proto-oncogene. So due to any region, it undergone mutation. Then the proto-oncogene becomes the oncogene, and that is responsible, and there also it undergoes point mutation or overexpression or amplification. But just opposite that, the tumor suppressor gene, there is the loss of function mutation. These two are completely different. What happens? Very clear. In our cell, there is the surface receptors are there, like VEGF, PDGF, epidermal growth factor receptor, insulin-derived growth factor. So this is the extracellular domain, this is transmembrane domain, and also this is the intracellular domain. So the growth factors that attach to the extracellular domain of the receptors. So with this, what happens? Once the growth factor binds to the extracellular domain, then that is activates the tyrosine kinase. So this is the key, tyrosine kinase. So once it is being activated, there will be dimerization of the tyrosine kinase. So once there is dimerization, then it will undergo phosphorylation. Okay, by which the down signaling pathway becomes active, like different RAS-RAP pathway, P13 ke pathway, P10. So ultimately, they are responsible for the acts on the DNA, which is responsible for proliferations, chemotherapy resistance, angiogenesis, metastasis, and survival. So this is the basic philosophy. But we have developed some of the drugs that acts against the tyrosine kinase inhibitor. So they are of different types, like A, that is the type 1, gepitinib, erlotinib, and sunitinib. You can see here, this is the tyrosine kinase, and here is the ATP binding site, phosphate binding site. So this is the drug, like the gepitinib, erlotinib, and sunitinib. They competitively binds here, but it is a permanent it's not a permanent binding. So that is type 1. Type 2, it makes a pocket here. Okay, so there comes the imatinib, nilotinib, we are very commonly using that. So that is for type 2. Type 3, we can see here, that is at this side. They actually binds at a different side. There it had made a pocket, but here it binds at a different side. So that is for the type 3. And type 4, they permanently, the drugs permanently binds at the phosphate binding site. So this is irreversible binding, like afatinib, dacomitinib, and neratinib. Type 5, the drugs binds with another molecule, and also it inhibits the phosphate. So this is the mechanism by which the tyrosine kinase acts. And very commonly we use these drugs in our practice. Now comes the concept of the HER2. Breast cancer, we are treating a lot of trastuzumab, pertuzumab. Okay, so how it works? So the trastuzumab binds to the type 4 domain. So this is the mechanism of trastuzumab. But pertuzumab binds with the 2. And the other drugs, like TDM1, what we use particularly in brain metastasis, the DM1 binds with the receptor, then it undergo internalization. And after the cytolysis, the DM1 acts. So this is the mechanism by which the HER2 receptor acts. Besides that, the other drugs like lapatinib, neratinib, that acts in the intracellular domain, particularly the tyrosine kinase. And this is also the VEGF. These are the different VEGFs that acts as the VEGF receptor 1, receptor 2, and receptor 3. Okay? And for the BRAF, because those are for at the receptor side. But for the down signaling pathway, as for example, in case of BRAF, we can use also some of the drugs like vemurafenib. So this is the mechanism that drugs directly acts on the down signaling pathway. Next comes, so these are the list of the different drugs that acts at the which type of malignancy and the receptor side. Then comes the second concept, that is the evading the growth suppression. So here, two things very commonly. The tumor suppressor genes like what we get, P53, then retinoblastoma gene, WNT1, NF1, NF2. So these are all the tumor suppressor gene. So their job is to prevent the development of the malignancy. So I can show you here, this is the G1 phase and this is the S phase. So when the cell from G0 recruit to the G1, then it propagates to the S phase. So very important is this checkpoint, G1 and S phase checkpoint. what happens here? Here the cyclin D and CDK4 and CDK6. Major role is here. And here it is under the control of two tumor suppressor gene, that is P53 and RB gene. The basic mechanism you can see here. So these are the different tumor suppressor gene. Just I am skipping this slide. What happens? Very important is the tumor suppressor gene, that is the P53, that is the guardian of genome of the molecular profile. Okay? Normally, P53 is not there because it is being degraded. But what happens? We can see here. Normally what happens, the P53 is bind with the MDM2. So once it binds to MDM2, it is being destroyed or degraded. So that is the normal phenomenon. But what happens? Once there is some stress. So when there is stress, what type of stress? Stress due to the oncogenic stimulation or stress due to the DNA damage. Ultimately, if there is DNA damage, then there will be phosphorylation of the MDM2. So once phosphorylation of MDM2, P53 is being released. But simultaneously, if there is oncogenic stimulation, that is responsible for the P49 and ARF that binds to MDM2. So MDM is destroyed and P53 is being released. So once the P53 being released, that is responsible, P53, responsible for the, it produces cell cycle arrest. That means at the G1 and S phase of the cell cycle, or it may produce the DNA repair. Once DNA damage, it will be repaired, or there may be senescence or apoptosis. So for that, the drug which inhibits the MDM2, because once MDM2 is destroyed, then P53 will be released. So these are the drugs that inhibits the MDM2. Similarly, story of RB. What happens? That at the gene, S phase gene, there is presence of the E2F site. So what happens? When the E2F is not bind, normally RB with E2F, when it is hypophosphorylated, it is not being bind with the E2F site. So there is no stimulation. But when the CDK4 and CDK6 are active, that is responsible for the phosphorylation of the RB protein. So once the RB protein is phosphorylated, so E2F is being released. So once the E2F is being released, then it is responsible for the activation of the S phase. Okay? So that is responsible for the arrest of the progress of the G1 to S phase. So this is the mechanism. So how to, if you can prevent the CDK4/6, then there will be no propagation of the cell to the, from G1 to S phase. So that is the mechanism, the different CDK4/6 inhibitors that we use. So these are the different CDK4/6 that is being used, like palbociclib, abemaciclib, and also ribociclib. Very commonly, we people are more interested for the molecular staging or molecular classification of the endometrium. So this is the concept where the P53 comes to the picture. If early endometrial cancer stage 1, but P53 is present, then we have to treat in line of high-risk endometrial cancer with chemotherapy or radiotherapy or combination. Next comes, very frequently the examiner asks, HPV, what is the mechanism, how it works? So this is the philosophy. E6 binds to P53 and also E7 binds to RB protein. Clear? Then comes the non-mutational epigenetic programming. What is it? we all are using the temozolomide very frequently. So the basic philosophy is that this is the histone protein to which there is the chromosome is bound to histone protein, and that is responsible for the formation of the nucleosome. What happens? Normally, the histone protein, here is the lysine. So that is positively charged. And the DNA is negatively charged. So when positive and negative charge being bound, they are tightly packed. So the transcription factor are not released. But when it is methylated or when it is acylated, then this positive charge will be neutralized. And the DNA is negatively charged. So there is low binding. So the transcription factor are released. So what happens in glioblastoma? Usually there is methylation. So once methylation, then the transcription factors will be released. And transcription factor release, that is responsible for the progression of the disease. So to prevent that, we use the temozolomide. Beside this, this is also this phenomenon is responsible for the conversion of the epithelial element to the mesenchymal element. And most common factor, the transcription factor, is SOX4, SNEL and Z. How it happens? I can show you here. These are the all epithelial element, and it undergoes the mesenchymal transformation. The fourth concept is that normally in our body, due to any reason like physical carcinogen, viral or the chemical carcinogens, the cell undergo mitotic transformation and there will be cancer. But our immunity is there. So that is called immune surveillance. So first step, what will happen? It will eliminate the mitotic cells as far as practicable. But at a stage, what happens? That it cannot recognize because tumor burden is so low. And tumor try to escape from that phase. So that is the escape phenomenon, or it is called equilibrium phenomenon. Then comes again the tumor cell propagate. So this is the basic mechanism. But what happens? I can show you here. This is the tumor cell. It produces antigen and detected by the dendritic cells, it goes to the lymph node, and here it activates the T cells. And T cell will propagate to the tumor site, and also it will destruct the tumor by the process of apoptosis. But due to any reason, if the antigen produced is lost or the antigen level is low, then the dendritic cell cannot recognize, so that the tumor cell escapes. Or if there is any reason that there is mutation of the MSC1 gene, then also it will not recognize the antigens. Or if there is the apoptosis, because here the apoptosis takes place. But if there is the activation of BCL2 gene, which acts as the anti-apoptotic, so that the tumor cell also will escape. But this is important. This is the basic concept of immunotherapy. You can see here, this is the T cell, and this is the tumor cell. T cell produces PD-1, tumor cell produces PD-L1. So when they bind, so the tumor cell inhibits the T cell to be destroyed. But if we can do one thing, if we can prevent the binding, like use of some of the drugs like PD-1 inhibitor or the PD-L1 inhibitor, then the T cell destroys the tumor cells. So here the concept of immunotherapy comes to the picture. Besides that, the microenvironment is also responsible. So I'm just skipping that slide, it's not much important. And you can see here basic things. I can show you here, these are the PD-1 inhibitor like the nivolumab, pembrolizumab and cemiplimab. And PD-L1 inhibitor, atezolizumab, durvalumab and avelumab. So these are the PD-1 and PD-L inhibitor. Question may ask, you are talking about checkmate. What it mean? The checkmate or keynote related to any clinical trials related to the pembrolizumab. Similarly, checkmate any clinical trial related to the nivolumab. And empower, any clinical trial related to the cemiplimab. Just for the postgraduate that you have to remember. Now comes the monoclonal antibody. You have to know what it is. I can show you here that the last word, you see here, everywhere MAB. So MAB remains same. Just before the MAB, the concept comes, the suffix is MAB, then the antibody source, like Ju, trastuzumab. Ju means here, you can see here trastuzumab. So Ju means it is derived from the humanized. Okay. So this second one, prior to MAB, it is what is the source. Prior to that, what is the mechanism? Like bevacizumab. Okay. Beva, forget about it. C. C means at what it works. Like circulation, we can see here the target disease like C, circulatory. Okay. So bevacizumab. That means C means acts on the circulatory system. Bevacizumab, it is derived from the humanized. So students, you have to remember this in detail. And we had the concept of the CPS score or TPS score. What it means? CPS score means that is PDL1 staining divided by the total or viable tumor cells. Here the PDL1 staining means tumor cells, lymphocyte and macrophage. All these three comes to the picture. And in TPS score, it is the tumor cells divided by the viable tumor cells that came to the picture. If there is no target, how it will work? So the concept TPS or CPS comes to the picture. Now comes the enabling the replicative immortality. What it means? It's very important because we know the normal cell have a finite replicative abilities. Okay. I'm an old man, contemporary of Dr. Madhu, but our Dr. Manoj Gupta is young. He was the press or chair, though he's one step ahead to me. But he looks very young. But I am ugly, my face has become darkened, wrinkling and everything is there. The young girl is so beautiful, but we are very old people. Why? What is the mechanism? The mechanism only answer is telomere. I have already mentioned the second slide. What is telomere? The tip of the chromosome, there is telomere is there. As the age advances, the telomere becomes shortens. But the cancer cell is very smart. We can see here. This is the telomere. Okay. As the age advances, the telomere becomes shortens. But in cancer cells, there is presence of the telomerase. So what will happen? That it will immediately repair the damaged portion. So it becomes normal. So by this, the cell is immortal and cells try to divide and redivide. And that is also under the control of the P53. So for that, there is the most important is the enzyme telomerase. Okay? But there are some drugs that has already developed which is responsible for the inhibition of the enzyme telomerase. So these are the different drugs that can be also utilized to prevent the damage of the telomerase. So the concept is clear, telomerase and the young and dynamic Dr. Manoj Gupta. Okay, so let me proceed further. Now comes that the tumor promoting inflammation. You can see here, in inflammation, we ask, Doctor, when you are going to start the radiation? Breast cancer wound has not healed. But we are not in a position, or carcinoma, oral cavity, wound has not healed. So we are taking some time to start the treatment. But in the meantime, due to the inflammation, a lot of growth factors are there that comes to the picture. So that is also change the tumor environment. So like that, in inflammation, what happens that release of the growth factor, the cell tries to divide and redivides, or there may be removal of the growth suppressors like protease and also the other factors by which the cells also loss its adhesion. So that cell will migrate. So that is also responsible for the spread of the disease. Or there may be release of a lot of growth factors by which the cell will propagate and also produce the metastasis. So this is the basic concept of the tumor promoter inflammation. Now comes the polymorphic microbiomes. So this is also in our flora, a lot of gut microbiomes are there. If there will be alteration, then we may also develop the different cancer. This is very small concept. Now comes the metastasis. What happens? First, the cell has to detach from the primary site. Then it will invade. Then it will propagate into the circulation. And in circulation, the tumor cells are very smart. They usually never go in a straight line, because here the blood pressure is very high. So what will happen? The cell will migrate to the periphery. Okay? In periphery, there is also, it will happen that cell will cluster with the tumor cell will cluster with the neutrophils, and also it is protected by the platelet. So it cannot be detected by the macrophage. After that, the cell will propagate and also it will lodge at a distant site. Very frequently, the patient asks, doctor, when you will say that I am cured from the disease? We say after 5 years, if you are free from the disease, then you are cured. No. In some cases, after 15 years or 20 years, again the disease appears. Because sometimes these cells are in a dormant state. Okay? And the factors, the sustained dormancy, these are the factors by which these cells are in a dormant stage. But if due to the other factors, the escape from the dormancy, these factors takes major role, then this same cell will propagate and also it will produce a distance metastasis after a long period. Then comes the inducing or accessing the vasculature. Very important. It's just like a switch. That is the pro-angiogenic factor versus the anti-angiogenic factor. So mostly the pro-angiogenic factor, the VEGF takes the major role. So when the VEGF is active, that is produced for the spread of the disease. And these are the angiopoietin 2 and others, they are the anti-VEGF factors. So people have developed the different drugs against the VEGF. Already I have covered this slide in the TKIs. So these are the different TKIs like sunitinib, sorafenib, pazopanib, axitinib that we commonly use in different type of malignancy. Then comes the senescent cells. What happened? That in senescent cells are characterized by, in proliferating cells, the cell cycles are being arrested. Even proliferating phase, but the cells are being arrested. What happens? So this is the senescent cells. So it produces some factors. So when it is a short period, then there is transient accumulation of the senescent cells, and for that the cytokines, chemokines and growth factors and protease. So these are the factors that decide the fate. So once it is a short period, then there is tumor suppressor effect. But if it is continued for a chronic effect or for a long period, then it is responsible for the proliferation of the cell. So that is the concept of the senescent cells. And that is responsible for the different pathway like NFK beta pathway, mTOR pathway, P13, and also the P13 MAP kinase pathway. So here these are the factors responsible which regulates the downstream regulatory pathways. Now on the genomic instability and mutation. This is a very clear concept. There is nothing new in it. So either the p53 mutation that I covered earlier, or there may be DNA damage or nucleotide excision repair or homologous recombination factors, DNA polymerase. So these are the different concept of the genetic instability. But another point, that's also very important, that when a cell cycle or cell divides and redivides, the centromeres also divides. But if the centromere will not divide, like if the centromere will not divide, and also the spindle, mitotic spindle assembly will not divide, then instead of 2n, it will be 4n. So the division of the centromere and also spindle assembly also important point in this concept. Now comes the resisting to cell death. Very important, that is the concept of apoptosis. So here the normal cell, there is apoptosis if there is DNA damage. But cancer cell try to avoid the apoptosis. You want to escape. So how it escape? The apoptosis occurs through two pathways, that is intrinsic pathway or the mitochondrial pathway and the extrinsic pathway. But for the development of cancer, the intrinsic pathway that takes the major role. I can show you here simple diagram that due to the radiation or DNA damage or misfolded protein, that is responsible for the arbitrator like BAD, BEAD, BEAM, PUMA, NUXA. It will decide whether the cell has to go for apoptosis or the cell has to survive. The factors that have activated the apoptosis, the pro-apoptotic factor, BAS and BAC. So that produces a nick at the outer membrane of the mitochondria. So that is responsible for the removal or the leakage of the cytochrome C. So the cytochrome C will bound with the apoptosis activating factors. Cytochrome C will bind with the apoptosis activating factor, and that is responsible for the liberation of the caspase 9. Remember, intrinsic factor, caspase 9. But if the cell is very smart, okay, I will activate the BCL2 pathway. What I showed in the previous slide, the immune aspect, the BCL is active, so it avoids the apoptosis. So from this, from the extrinsic pathway, we get the caspase 9, and the intrinsic pathway, the caspase 8 and 10. And ultimately, they will activate the caspase 3 and 6. So these caspase 3 and 6, they are responsible for the, either the cell has to be degraded, or the DNA will cleave the DNA, or there may be apoptotic bodies. So what happens in apoptosis, the normal cell? When there is apoptosis, the cell will shrunken. There is fragmentation of the DNA, and DNA will accumulate at the periphery. Then what will happen? It produces apoptotic body, and to that apoptotic body, it will engulfed by the macrophage. But if there is no apoptosis, if the BCL2 will be active, then there will be escape, and the tumor will propagate, and tumor will spread. So this is the philosophy of the apoptosis. So for that, what happens in mitotic cells? Either there is reduced expression of the death receptor or reduced expression of the death signals, or there may be disrupted balance of the BCL2 family protein. If the BCL2 family protein is very active, then it escapes the apoptosis, or there is increased expression of the IFPs or reduced expression of the caspase. So these are the basic philosophy by which the tumor cell escapes from this. And for these, people also have developed the drugs against the different pathways, like for the BCL2, it is the venetoclax that is also in clinical use. And inhibitor that I have covered. Then comes the, I think 10 minutes is there. Okay. Then comes the deregulating cellular metabolism. What it means? Normally, glucose undergo pyruvate, and then there will be in the mitochondria aerobic, and it will produce the oxidative pathway or oxidative phosphorylation where we need energy. But if it is anaerobic, no oxygen, anaerobic glycolysis. But in malignant cell, it is the scenario is different. That is called Warburg phenomenon. What it means? That the metabolism of glucose to lactate, despite the presence of adequate oxygen, is called the Warburg or the aerobic glycolysis. Cancer cell need energy. Beside that, it needs the structures. The cell has to divide and redivide. So it needs the fundamental elements to produce the DNA, to produce the cell membrane. So for that, what happens? In mitotic cells, the basic concept that there is increased glycolysis, then comes, there is upregulation of the glucose transporter in the cell, so that more glucose will be uptake into the cell. But most important, that it inhibits the pyruvate enzyme pyruvate kinase. So instead of producing the energy, the cell will, the metabolite will migrate, and that is responsible for the production of the more nucleic acid synthesis, as well as more lipid synthesis. So it needs more structural element like the DNA and also the cell membrane. So most important culprit is here, that is the enzyme pyruvate, inhibition of the enzyme pyruvate kinase. So there will be subtle of the metabolite to form the DNA, and also now comes the last one, unlocking phenotypic plasticity. What it means? That during organogenesis, there is organization cells into tissue is accompanied by terminal differentiation, whereby progenitor cell stops growing. This antiproliferative process and constitutes a clear barrier to the continuing proliferation called the phenotypic plasticity. But in malignant cell, you can see here, the normal cell, this is progenitor cell, and usually it develops the normal cell. But it may also undergo de-differentiation. So instead of normal cell, it forms from mature to progenitor cells. So it's not a normal cell. Again, it goes back to the progenitor cells. Or it may also block differentiation from progenitor cells, or it may also undergo transformation. What I told, that from the epithelial to mesenchymal transformation. So these are the 14 hallmark of cancer. To information to all the postgraduates, go through the data and also just clarify this. So these are different hallmark of cancers. Basically the first thing, that sustaining proliferating signaling based on the proto-oncogenes. Then comes the evading growth suppressor, that is the tumor suppressor gene. Then non-mutational epigenetic reprogramming, that is histone acetylation and DNA methylation. Avoiding immune destruction, that is the cancer immunity. Enabling replicative immortality, that is telomerase. Tumor promoting inflammation, that is growth factor and cytokines, what I covered. Then polymorphic microbiome, the gut microbiome. Then comes the activating invasion and metastasis, that is nothing new in it. Then comes the inducing or accessing vasculature, the angiogenic switch takes the major role. Then senescent cells, that is the SAP, that is the different cytokines, what I covered, that is takes the dual role. If it is low amount, then tumor suppression, but if it is a chronic one, then that is proliferative progression of disease. Then comes the genomic instability and mutation. Resisting cell death, that is apoptosis, particularly the BCL2 family. Deregulating cellular metabolism, that is anaerobic glycolysis, particularly the enzyme pyruvate kinase. And the terminal differentiation like unlocking phenotype plasticity. So with these 14 hallmark of cancers, the people have very smart and they have developed a lot of drugs like the different tyrosine kinase inhibitor and RAS, RAF, mTOR, MAP kinase and P13 kinase pathway, the different pathway for which the drugs has already developed. Now for the tumor suppressor gene, that is particularly the enzyme P53 and also RB gene and its clinical implication, that is molecular classification of the endometrial cancer. And HPV, like cervix as well as the oral cavity. Similarly, the histone deacetylation, the concept of use of temozolomide in glioblastoma multiforme. Cancer immunity, like concept of particularly the immunotherapy, PD-1, PD-L1 inhibitor, and also different cytokines. Then comes the telomerase. And for the telomerase, the different drugs has already I have highlighted. Then comes the angiogenic switch, the VEGF family. So these are the very commonly used drugs in against the different hallmark of cancer. Yes. With this, I conclude my talk. Thank you, ladies and gentlemen.
Thank you, sir, for that wonderful presentation. Now the session is open for questions, if any.
Thank you, President, for your wonderful talk. And thank you for your slides, excellent pictures you have put. I know the effort you have taken to make these slides. And for the postgraduates, it's important to know this mechanism, molecular mechanisms, because all new drug developments are based on this alone, actually. And also not only in the treatment of current diseases, but it's very, that new drugs are all development is based for resistant disease. It's very important to know, because drugs development take place based on this molecular mechanism. We have to target different molecular pathways. Any questions from the audience?
Yes, Madhu sir.
Actually, it is not a question. It is only a comment. Congratulations to you for making a wonderful presentation at a time when,
thank you, friends.
At a time when most of our radiation oncology residents are interested only in contouring, SBRT, etc., and not studying much about the hallmarks of cancer and the molecular oncology. You know, your talk is highly relevant, and it goes without saying that we should have more sessions on molecular oncology. Maybe one of the ICRO program can be on this, rather than repeatedly doing image-guided brachytherapy. And image-guided brachytherapy and so many other things are being taught and discussed. It is very good. But what happens in most of the government medical colleges is that even anesthesia is not there. Many of the uploading machines are not having source. And all these fundamental issues are in most of the government medical colleges and some of the private institutions as well. So your talk has opened up a very good subject, and unless we know more about these things and its impact on the conventional radiobiology, these things will have relevance in our fractionation, our SBRT, etc. So all these things have to be opened up and discussed. Thank you very much for the wonderful presentation.
Thank you, sir. Thank you very much.
Thank you, sir. I would like to invite Dr. Shivramakrishnan, Principal, GMC Kasaragod, to felicitate our speaker and our chairpersons with a memento as a token of appreciation. Thank you, Soran ma'am. Next in line, we have a session on radiosurgery for functional brain indications, thinking beyond the scalpel by Dr. Shankar Vangipuram, Senior Consultant Radiation Oncology, Apollo Cancer Center, Chennai. I invite Dr. Shankar onto the podium. To chair the session, I would like to invite Dr. Anand Arke, Associate Professor, Department of Radiation Oncology, Government TD Medical College, Alapi, and Dr. Ansar Suhaid Said, Consultant Oncologist, General Hospital, Ernakulam, onto the dais.
I will take, sir.
Is it coming? Is it okay? Good.
Okay, sir.
Good. Thank you so very much. I'm sorry about the technical snag which happened before. So, I see a good number of residents here as well. So, what I will be doing is flying you to a different world of functional neurosurgery. One of the things which is more passionate for me, and 80% of my load in clinic is functional indications, and I rarely treat cancers. The last cervical cancer that I treated was almost 12 years before, and breast is almost 7 years before. Having said that, this is something which is a lot of opportunities there, and what I will be doing is trying to attract your attention to this new kid on the block. I don't say new kid, it's an old kid. So this is my disclosure, and let me just set the stage by drawing your attention to what are the typical indications for functional neurosurgery. You know, when you say a functional disease, that is anatomically normal, but everything is functionally aberrant there. Now, what are the gamut of diseases which fall into this functional diseases is the neuralgic pains. One is the trigeminal neuralgia, the glossopharyngeal neuralgia, the sphenopalatine neuralgia. The second is the movement disorders, the tremors, the dystonias. The third is epilepsy. And lastly, it's the psychoradiosurgery. Typically in the OCD is something which we practice. So functional radiosurgery actually highlights the gaps in our radiobiological understanding and the mechanisms of radiosurgery effect. Now, having said that, we have done nearly 600 patients over the last 24 years of my practice. Now, this is very important. There has been renaissance of lesioning in the functional indication space. Why? It's because it is less invasive, it's more effective, more accurate, safer, it's simpler, cheaper. We can aim at cure, and more importantly, this gives a neuromodulatory effect. Though we say lesioning, the final outcome, if you look into, it's more modulatory. And this is how it has evolved. There are several commercial delivery platforms that we have in the marketplace because these tools have perfected play the games of sub-millimeter accuracy and precision. In the photons, we have the Linac, CyberKnife, the ZAP, and in protons also we use this. So what I will be doing is flying you through the technologies. What is the advantage of using CyberKnife or a Linac or a ZAP in this particular space? You know, typically majority of the functional radiosurgeries are done on Gamma Knife, but having said that, after my return from Pittsburgh following the radiosurgery fellowship almost 24 years back, I started using the Linac. That's the first tool that I used because that gives us several advantages when we are transitioning from frame-based to frameless technologies. Now, I would like to draw your attention to this important paper from Paddock. which actually compares the different technologies, and that is benchmarked against gamma knife. And if you look into the gradient index, you know, the gamma knife and the cyber knife are pretty close, and that is something which I would kind of advocate in the practice of cyber knife, specifically for the movement disorders. I would suggest to try to avoid LINAC-based tools, because the gradient index what you get is pretty low there. Protons should never be used for functional radiosurgery. This is the dictum which every resident needs to know, because there is something which is very unique in protons, which is the lateral penumbra effect. And the second important caveat for using protons in functional radiosurgery is there are a lot of planning uncertainties you find when you are planning for sub-centimetric clinical targets. Now, when you're thinking like surgeon, you know, after return from Pittsburgh and, you know, having looked in gamma knife, what are the things, you know, I just took my notebook and figured out what should be the kind of technology. If I want to kind of extrapolate the doses, what we advocate for functional indications. The first one is we should have a robust immobilization, which could be stereotactic mass. The second important thing is a beam shaping device, which is a micro MLC or the cones. And more importantly, beam energies. We prefer a 6 MV unflat beams. That is very much doable on a LINAC. Treatment planning system, Monte Carlo, preferable. The grid spacing what we use should be less than 0.5 millimeters. Imaging should be 6D robotics with intrafraction imaging. Now this is the set of criteria that I thought would be relevant for us to practice extreme radiosurgery on a LINAC. You know, if the LINAC suits this particular context, we should do it confidently, and I've been practicing it. So the first thing is we need to connect our theory to the best practices. So when we are coming back to the machine, it should have the ability to detect the errors, and errors in all the dimensions, which includes the X, Y, Z, and the roll, yaw, and pitch. So, and the second important thing beyond detection is it should have the ability to correct it. Now, what is really important in functional space is the lower limit of this connection. Now, this lower limit on a LINAC is 0.3 millimeters below. If an error less than 0.3 millimeters is there, it cannot be corrected. So this is one limitation on LINAC. Having said that, 50% of my functional indications I practiced on LINAC, and I have seen the outcomes over decades, and I can allude much on that. Now, the second important thing is we have robotics in place, the 6D robotics with the ability to correct all the dimensions, understood about it. Now, the second important thing is what should be the beam shaping device. So when I started the program 22 years before, my physics said, doctor, we are not trained to shoot such kind of doses. You know, we are not really confident. I said, okay, let us just go back to our drawing board and do what is scientifically correct. So the first thing, whenever we are using a MLC or a cone, is what we look into the penumbra, number one. Number two is the leaf positioning accuracy. Now this is very important. The leaf positioning accuracy for the micro MLC, what you're seeing, has to be defined in high definition graph chromic imaging. It can't be on the conventional graph chromic imaging. So we procured the high definition graph chromic and run all the sense, all the tests, and you can see here, we looked into the small fields, less than 5 millimeters, because that's very important for functional targets. All our targets are sub-centimetric, measuring usually around 3 to 4 millimeters. So when we have done the high definition graph chromic imaging, you can see the penumbra what we got is comparable with that of the cones. And the second important thing is the leaf producing accuracy. Suppose if the leaf is open like 5 millimeters, you can see here, it's almost like just perfect that we got it. You can see here 2.08, 1.56. I mean, this kind of precision with this motors is really appreciable, and we started our radiosurgery program. Then after getting this confidence, we first use the micro MLC and then swap to the cones, because cones have this, there is no error of leaf reproducing transition there. So I'm pretty comfortable. If on a LINAC, I'm asked to do radiosurgery, functional indications, I'm pretty comfortable doing it with cones. And number two, with 6D robotics. Now, the third important thing is the real-time imaging. That's very important, because there could be some errors during the treatment, which I'll show you in the future part of the presentation. And the third important thing is the immobilization. So we have different types of immobilization right in there, which includes the bites as well as the stereotactic mass. We made a comparison. Again, it's sub-millimeter. We got a confidence as far as the tech is concerned. Then we have started our first program. Now, in trigeminal, we have done over nearly 433. Yesterday, we have done our 433rd patient, and we have a median follow-up of 7 years, and that ranges from 1 day to as long as 24 years, 23.8 years. And this is one of the highest series on the frameless radiosurgery, and we have around 26 papers in the functional radiosurgery space for the functional indications published in peer-reviewed journals. Now, because I see good number of residents there, I'll just draw your attention to how do you define trigeminal neuralgia, because this is something, what I'll be discussing is a domain which is actually practiced very, very well by all the neurologists. I'm sure a lot of my connects are with neurologists and the neurosurgeons, and very little of oncologists I'm actually connected. So if you want to define trigeminal, there should be at least 3 attacks. It should be lancinating pain, severe intensity, electric shock-like, and for the innocuous stimuli. Whenever you see a patient of trigeminal neuralgia, if it is a young patient, MVD is there. MVD is a microvascular decompression, typically the neurosurgery domain. That is something which we advise. If you find a patient who is elderly or who refuses surgery, and the patient should have non-acute pain. If the patient is having acute pain, never do radiosurgery. This is very important. It should be non-acute pain that we are trying to attempt. If the patient is having acute pain, if it is in V1 domain, we advise balloon compression. V2, V3, it's a radiofrequency isolysis that we do. Now, this is how typically trigeminal neuralgia actually progresses from typical to atypical scenario. In the early part of the disease, you can see there is a lot of lot of remission, lot of, sorry, yeah, let me get the pointer. Yeah, there is a lot of exacerbation, remission you can see in the early part of the disease. Over the later part of the disease, which is dominated by periods of exacerbation. So if you look into the transition, this part is what is called as typical trigeminal neuralgia. If the patient enters into this particular phase, it's called atypical trigeminal neuralgia, when the pain actually becomes much more continuous, prolonged over a period of time, and more importantly, there will be some other characteristics like burning which come into the picture. Now, this is something which is very important. Why the neuralgic pain is coming? Majority of the times, it's because of neurovascular conflict. 60% of the cases happen because of neurovascular conflict. Now, this conflict can be arterial, as you can see here, coming from the superior cerebellar artery, or it comes from ICA or PICA, anterior inferior cerebellar artery, or the posterior inferior cerebellar artery. Now, the other conflict which can happen is called due to venous conflict also. It can happen because of the veins. Typically, the superior petrosal vein or the dandy vein, which we would have read in the anatomy, is more responsible for this neuralgic pain. At times, you can see this patients, whenever there is a compression, there will be a demyelination which happens. So what happens when it is getting demyelinated? There is upregulation of the voltage-gated sodium channels, specifically the NAV 1.3 voltage channels, and that will result in hepatic conductions and the pain genesis. Now, there is another subset of patients, typically the 40% of patients who do not have neurovascular conflict. Now, this is very important for us because many a times when the patient is done having neuralgic pain and you do a MRI, there could be no neurovascular conflict. Now, that is very important because if there is no neurovascular conflict, what is the role of a surgeon? What is he going to do? Go there and do the decompression for? Now, it's very important for us to know, and also when we are discussing with our neurosurgeons or the neurologists, if this conflict is venous, neurosurgeons go and just cut the dandy vein, the petrosal vein. But the complication rates for this procedure ranges usually from 1 to 30%. This is a meta-analysis in around 600 odd patients where the vein was sacrificed. And therefore, the results of neurosurgery or the microvascular decompression for the venous conflict is inferior. The only situation where I am comfortable referring the patient to my neurosurgeon is when there is a neurovascular conflict and it is arterial. If it is venous conflict, or if it is a dual conflict, or if there is no conflict in the first place, and that could be because of the adhesions, or the herpetic neuralgia, or multiple sclerosis, or a dual pathology, or a secondary neuralgia, all these clinical situations, it's a radiosurgery which assumes the important treatment strategy. Now, whenever we speak about the trigeminal neuralgia, it's very important for us to know the trigeminal pathway because in those patients who do not have the neurovascular conflict, this pathway is very relevant for us because from sensory receptors, the signals go to nucleus and from there to thalamus and the somatosensory cortex. Now, importantly, when I'm touching the face, right, majority of those sensations are transmitted through myelinated fibers. But all the pain and the temperature fibers go through the non-myelinated fibers. Now what happens when there is a neurovascular conflict, the myelination is gone. So because of that, the NAV3, now 1.3 channels get overexpressed and there is hyperexcitability in the unmyelinated fibers and that's how the pain gets responded. Now, if there is no neurovascular conflict, let's presume there is no neurovascular conflict. That's very important for us. Then where could be the pathology be? It will be beyond the initial part of the nerve in the prepontine cistern, either in the brainstem or in the thalamus or in the somatosensory cortex. So this is the central hypothesis for the pain genesis. So whenever we encounter a patient who is having a no neurovascular conflict, we do advanced imaging, which is called voxel-based imaging, voxel-based morphometry. That gives us an understanding about the changes which are happening inside the thalamus, inside this. And if there is a problem there, ladies and gentlemen, mark my word, the response is not that good. So what would be the ideal situation when I would be comfortable? I am not seeing any VBM changes, or in the next phase, I should not see any DKI changes also, because if this neuralgia is for a long period, patients will have white matter changes, patient will have gray matter changes inside the central trigeminal pathway. So our beauty is to pick up those changes. If you are able to pick those changes upfront, then you are able to better prognosticate the outcome. So white matter plasticity is something which we use also for this kind of patients who are having long-standing duration, because these tracks which are evaluated are those which are involved in the perception, in the modulation, in the cognitive affective system and the motor reaction. So if you are finding some characteristic changes there, your outcomes are inferior. Similarly, if you are seeing multiple sclerosis with NVC, that is also a disastrous situation which actually doesn't give us good results with MVD. You know, I'm just giving you an example where radiation will be getting an upper hand over surgical series. So let's say if this patient we have selected and we are planning for radiosurgery, there are two areas where I could usually place the target shots. One is the distal shot, which is typically near the plexus triangularis, and the other one is a proximal shot, which is very little close to the brainstem. As you can see, with brainstem, there will be a higher rates of pain relief, but also higher rate of complication, which includes a numbness or anesthesia doloroso. So that's precisely the reason why we don't use the proximal shots. So whenever we do it, our shot is typically placed in a zone which is called as OR zone. Now this is actually the transition point between the Schwann cells and the oligodendrocytes. And this typically ranges like this as an envelope, and we have to place our shot somewhere there. And the dose is what we use typically is in the range of 85 gray, not beyond 85 gray, because that's the time when we see increased rate of complications. Now there is a certain clinical condition where we are not comfortable. If the patient is having a pacemaker, like yesterday we have treated a patient who is having a pacemaker. Okay, that was an old pacemaker. We have the option of switching off the pacemaker. So you cannot switch off the pacemaker. Then what is the option which we have? We can do what is called as CT cysternography. And CT cysternography is something which we use also in situation where there is MVD failure, microvascular decompression failure, because when the Teflon sponge is kept, you cannot delineate the nerve. It's very difficult for us to delineate the nerve because there is a sponge there. So what we do is we use CT cysternography whenever the MRI is contraindicated, or in certain situations where there is a cavernoma which produces a paramagnetic effect, as you can see here, and we have delineated, we have difficulty in delineation. Now, when we are shooting 85 gray on the trigeminal nerve, what is it that really happens? You can see here, the myelin sheath is actually partially collapsed. There is dissolution of axon. This is actually a baboon experiment because no human experiment can be done ethically. So therefore, this is something which was tested on baboon. But what happens on histology, let's correlate it anatomically on MRI. And probably this was the first publication from our side, where we looked into serial MR imaging. Post-longitudinal serial MR imaging is something which we have done. And you can see after 72 hours, there is a focal enhancement there. After 1 week, there is little amount of brainstem edema, and that is kind of sustained over a period of 3 months. And post that, there is a regression of the pain. Now, we always were wondering, this was the initial part when we were trying to figure out, are we using the right tools for this functional radiosurgery, shooting 85 gray. So what we have done is, after 3 months, whatever enhancement we got, we mapped it with our original planning scan and looked at the errors of the target, where the enhancement is and where our target is placed. These differences in the Euclidean space is something which we have analyzed and published, and it was coming to less than 0.5 millimeters, and we were pretty happy with the targeting accuracy of the tools. But what we have noticed during this problem is there is always some motion also which is seen during the treatment. We were shocked, how can this motion come when we are using a stereotactic mask? So what I would like to tell you is, when you are using a stereotactic mask, there is something which we are missing out. Number one is, whenever the patient actually swallows, we swallow typically 3 to 4 times a minute. That is subconscious, and it cannot be actually, it's not voluntarily controlled, it's subconscious. But whenever the patient swallows, just have a look here. This is how you can see the palate movements, everything. These movements, subtle movements, you can see there is a small motion which is happening there. So this intrafractional motion is particularly relevant when you're doing the treatments in the functional space. Now, we try to analyze, okay, what is the impact of this motion on the overall treatment dosimetry, that also really worries me. As a radiation oncologist, I'm a motion fanatic guy, and if I see motion something there, I'm more worried about, because I don't want to burn my hands. So what we did is, we deformed the doses from the original plans to the cone beam CT, which are electron density corrected, and then evaluated the doses. And you can see there is literally not much difference with regards to the target, but with regards to the brainstem, there is a little bit, I would say 1 millimeter dose variation which we have seen. That is clinically acceptable. That is very much clinically acceptable from my side. Now, this is the time in 2012 and 11 when everybody was saying, okay, faster treatment will give us better time. That is the time when everyone started speaking about unflattened beams. Triple F beams was something which was more, fad in 2011, 12, and all the vendors were trying to push for unflat beams. During that time, I have seen a publication which showed that higher dose rate on gamma knife actually improved the outcomes. So far, we have been treating the patients on unflat beams. 6 MB unflat beams. Flattened beams, not unflattened beams. So what we thought is, we have actually done a dosimetric study comparing the unflat and flat beams. The differences in the beam on time. With unflat beams, the beam on time has come to 18 millimeters. In fact, if we have very good physics with us, we can still reduce it to around 12 minutes. That's phenomenal reduction. Now, when we transition from flattened beams to unflattened beams, what we have seen is the pain outcomes, the response outcomes were better with unflattened beams, not with flattened beams. So we were kind of shocked. How can this happen? When you're using unflat beams, the only difference is I'm decreasing the time the patient spends on the couch. But my results using unflat beams were superior over the earlier series where we have used flattened beams. So this begs the question, something again is happening inside the brain which is more relevant. So I went back to my neurosurgeon. I asked him, doctor, do you see motion? Yes, we do see fantastic motion. So we have done an echoplanar cine-based amplified MRI scan. And I would like to draw your attention to this particular area, this diencephalon, the central brainstem, which actually shows motion. And this synchronizes with what you say is a cardiac systole and diastole. Now, our target is something here. It is placed there. So when you see this motion inside the brain, you are actually, though you're focusing the shot, you're actually giving a discrete shot. It's not a focus shot. So this is probably one of the reasons why, in a shorter treatment time, the number of clinically relevant pain fibers are much more when you are abbreviating the treatment time. The second important thing is the trigeminal neuralgia is a disease of elderly, and you can see there is so much of atrophy. So when you are having a good space there, the resonance you see of the nerve will be little amplified. So what is happening? You are decreasing the time of treatment from 28 to 30 minutes to 18 minutes or 10 minutes. You are actually getting more of the relevant energy into the focus shot in an abbreviated format. So we have published all this work, the faster treatments, less personal, increased delivery accuracy. This is probably one of the hypotheses which we have done. The most important imaging which is very relevant for us in the clinic is the tractography. In tractography, we look into the MD, RD, AD, and all this, and FA values. FA value is something which is very important in tractography. And what we have done is, all the patients, judiciously we do tractography pre-imaging and tractography post-imaging. What we have noticed, you can see this is 1 year, 3 months post-radio surgery. You can see an enhancement, and you can see the problem, the tractographic changes which you are seeing there. Now in the tractography, we evaluate what is called as fractional anisotropy, FA values. Now when you are doing at the FA values, what we have noticed is if the FA value drop at the end of 3 months is greater than 30%, these are the set of patients who are having better pain outcomes. So this is one of the important prognostic tool that we use in response prediction. So I always tell the patients, after 3 months, we do a tractography and look into the way how these things change. Now, these are typically the kind of the responses you get. You can see these are the patients who had oral triggers and cutaneous triggers. You can see this is one of the patient, how horrible the cutaneous trigger is. This patient, actually, I got a call from my neurologist at night 1 o'clock. He attempted suicide twice since morning just because he could not tolerate the pain, and the very next day morning he was sent on an ambulance, and we have done the treatment. Immediately after the treatment, look at the response. So there are ways we can actually provide solace using radiation as well. We have done good number of patients who had bilateral trigeminal neuralgia, and this is also one of the patients. You can see this patient had no neurovascular conflict. What you see here is a T2 hyperintense band. So we were a little worried. When you are having a T2 hyperintense band in the brainstem, our first differential is the multiple sclerosis, but it is something which is seen in young patients. In the elderly patients, there is something which is called as MOG antibody disease. So monocyte, oligodendrocyte globulin disease, that's what it is called. So there is no role for surgery when such situation comes. So we have done radiosurgery for this patient, and you can see the kind of responses. You can see there. Trigeminal schwannomas are the classical secondary trigeminal neuralgia causes. This is very important for all of us. These patients, any schwannoma you see, you're not supposed to cut the nerve. You can only decompress the relevant, disease which is actually causing the mass effect. And the important, I would say, the management strategy would be the radiosurgery. And you can see this is one of the patients whom we have done the treatment, 24 months post-treatment. This is actually dissolves. So the second important indication, as you can see here, beyond trigeminal is glossopharyngeal neuralgia. Now, glossopharyngeal neuralgia, whenever the patient eats, they get severe pain in the ear. The majority of the times, these patients get misdiagnosed as trigeminal neuralgias. But you have to enter into the depths of the history to differentiate what is the real diagnosis. And one of the important things which neurologists misses out is what is called as Eagle syndrome. Eagle syndrome is the elongated styloid process, and that actually compresses the glossopharyngeal nerve. So 10 days before, I had a patient who was referred for glossopharyngeal neuralgia radiosurgery. We have done a simple X-ray, orthogonal view, What we have seen is a styloid process which is measuring 4 centimeters. We referred that patient to our ENT colleague to do styloidectomy. Patient had a very good pain response. So getting the diagnosis properly is very important when you are seeing a patient of glossopharyngeal neuralgia, and try to exclude Eagle syndrome, which is very important for us. Now, if there is a diagnosis which happens, right? The neurovascular conflict is typically from the anterior inferior cerebellar artery. As you can see here, the green one is the vagus nerve, and this is the glossopharyngeal nerve. We are going to hit the nerve in the glossopharyngeal meatus, and you can see these patients post-treatment, how beautifully they have food without any pain. This is immediately after the treatment. And you can see here, and this is also, the problem with microvascular decompression in glossopharyngeal neuralgia is the complication rates are higher. So the patient, this patient is an auto driver, and he said he's the only earning member. He doesn't want to risk his life and family. So that is the reason we have done glossopharyngeal radiosurgery, and the patient is absolutely pain-free and still almost 4 years post-treatment pain-free. The third important pain indication is a cluster headache. And this headache, as you can see here, the pain actually is in the V1 domain, where it's literally, I would say cancer is much better disease than functional indications. Cancer is much better disease because pain is something which you see in the end stage, when you find disseminated disease. these patients, actually they beg for treatment. They search for us. They search for us. Cluster headache, again, is one of the pathetic condition. Surgeons have no role there, but definitely radiation has a role. And you can see we can hit the sphenopalatine ganglion, and if there is no response, then we do trigeminal radiosurgery. This is, interestingly, a patient, as you can see here, hemifacial spasms. You can see the spasms inside the spasms you can see here. That's typically the blepharospasms as well as the trigeminal pain. So what we have done is we have done dual targeting, where we have targeted the VCF bundle as well as the dress, and you can see 1 week post-treatment the kind of response these patients have. This patient I treated almost 3 years back, incidentally developed laryngeal cancer, and later on, of course, that was another malignancy. So he was a smoker and he developed laryngeal cancer. And then we have done radiation, the conventional radiation for that patient. But honestly, yes, I treated this patient almost 6 months before, but radiosurgery we have done 3 years before. Patient is absolutely fine, no pain and blepharospasms at that area. Now, the second important indication is the movement disorder. So we have heard about the neuralgic pains, the trigeminal, glossopharyngeal, and the cluster headaches. Now let us go to the second important indication, which is, okay, I still have 12 minutes, okay. So the second important indication is the movement disorders. It's very important for us to understand which movement disorders can be treated with radiation. Parkinson's disease is something, essential tremor is something which can be used. Now these are the diseases which need to be medically refractory. Any intervention in functional indications is only in a situation when it becomes medically refractory. Now, diagnosing Parkinson's disease for any intervention is very important, because there is another subset which we call as atypical Parkinsonism, which includes MSA, the multiple systems atrophy, the Lewy body disease. Exclusion of that particular disease is very important if you want to intervene. And the second important thing is the UPDRS score should be greater than 30. That's typically the metric which we use to define the intensity of tremor or the problem which the patient has. And the third important thing is a response to dopa agonist, whatever is being used. That's very important. The patient responds to this, then we are dealing with Parkinson's. If the patient doesn't respond to it, we are dealing with atypical Parkinsonism, and we should not treat those patients. So the first question I ask with the patient present with movement disorders is, have they used dopa, and how is the response? Then the duration. If the duration is more than 5 years, then only you intervene. Otherwise, don't intervene, because if it is less than 5 years and it is progressing very severely, the results will be very, very bad with radiosurgery. Now, the second important difference, essential tremor, the hand just flaps like this. It's very difficult, patient cannot hold anything. How horrible it will be. It's just pathetic. The other important thing is essential tremor runs in the families. And these are the patients who have voice tremor also. If they want to speak, they have to speak like this. There will be tremor inside the voice. And whenever you find voice tremor or a typical head tremor like this, don't do radiosurgery, because the results of radiosurgery will be inferior. But when you are finding a tremor in the hand, which is very significant, more than 1 centimeter, UPDRS score more than 30, radiosurgery is an option which can be explored. If the patient is having rigidity, cannot walk like this, don't do radiosurgery. Those are the patients who actually get benefited with DBS, deep brain stimulation. So we have to draw lines clearly, the red lines I would say, where I say this is the place where I'm going to interfere. This is the place where I'm not going to touch the patient. So this is something which we have to keep in mind. And so when these patients come for intervention, there are multiple options, which includes MRI for radiofrequency lesioning, radiosurgical lesioning. And the targets one chooses, typically this is the flow diagram that we use when we are advising radiosurgery. What we look into is, if the patient is having bilateral tremor, never do radiosurgery. Very rarely we do. I've done it only in one essential tremor who really couldn't afford DBS. But bilateral, if the tremor is there, definitely
DBS is the first option. If it is unilateral, patient is on pacemaker, anticoagulants, medical comorbidities, radiosurgery is the first option. No, if the patient doesn't fit into it, then we look into the important thing, whether the patient can lay flat on MRI for 3 hours. The MR HIFU is something which can be used. Or we look at the skull depth ratio, which is SDR, what we call more than 0.4. That is the time we can advise MR HIFU. And the third important thing which you need to keep in mind in decision making for DBS, is deep brain stimulation, is these patients should not have dementia. If dementia is there, DBS should not be done. And of course, all these patients go from thorough neurocognitive tests. So there are several targets that we use, which includes the GPI, the subthalamic, and the WIM, the WIM nucleus of the thalamus. Typically, when we are doing radiosurgery, we never touch STN, subthalamic nucleus, because that will produce what is called as hemibalismus. You know, these patients, they will land up into problem if the STN nucleus is knocked out. So our comfortable target is WIM nucleus. The ventro-intermediate nucleus is something which we are shooting, and this is typically the target for us. We localize it by matrix technique, and this is one of the patient whom you can see here. The tremor is suffering from Parkinson's, tremor-dominant disease, TDPD. That's the classical indication for radiosurgery. You can see there is a bilateral tremor for this patient, right? So this right side, it was more dominant. So we have done left WIM thalamotomy, and you can see immediately after the treatment, please note this is a video, there is no tremor there. And the contralateral tremor actually improved post-radiosurgery. This is yet another patient you can see there. The tremor, how horrible. You know, these patients come and beg for the treatment. Doctor, please do something. I'm just not able to take the pain of the muscles. It is just, the tremor is just horrible for us. And these patients, again, as I said, they have very good solace with radiosurgery. As always, you know, when you're shooting 110, 120 gray on the thalamic nuclei, what is the radiologic, you know, the imaging which happens after the treatment? I'm always worried about that, because as radiation oncologists, we are more worried about the toxicity. We were never trained during our residency period about shooting doses of 85, 110, 120 gray. Neurosurgeons, I'm not really sure whether they understand the importance of these doses. Very meticulously, just someone has done this 180 gray, they just go and prescribe it. But we need to be really realistic and understand what is the best way we can prescribe doses, balancing the outcomes versus complications. And this, every patient we do longitudinal MR scanning, space 3 to 6, up to 2 years, up to 6 months, every 6 months, up to 2 years, and you can see there is not much toxicity right in there. And all these patients, one thing which I would like to draw your attention to, few of the patients, they have minimum reaction, few of the patients, they have normal reaction, and few of the patients, they have hyperreaction. This is very important. Those patients who have hyperreaction, they have better outcomes. So at the end of 3rd month, if you are able to document hyperreaction in post-thalamotomy, these patients have better outcomes post-intervention. And this is the other important thing. This I would say caveat, but mark my words, I've been debating with my neurosurgery colleagues, my own neurology colleagues. I mean, we have a very healthy discussion. There is no offense meant to anyone. And honestly, these patients are referred to me from them. You know, my neurologist says, Shankar, we are seeing this. What can you do? I said, please do. Like last week, I've seen a patient who is having rigidity. He couldn't walk. So I referred the patient to my neurosurgery colleague, told him to do radiofrequency lesioning of the GPI, globus pallidus internus. Wonderful response. Immediately after the lesioning. These cases, they don't get benefited with radiosurgery lesioning. So that's very important. You have to learn to choose your battles very, very carefully. And the second important investigation that we do in our clinic started doing in our clinic, I'm sure, after seeing this publication. Because when we do PET-CT in a patient of Parkinson's disease, tremor-dominant Parkinson's disease, what you see is a decreased temporo-occipital metabolism. there is a greater likelihood of failure. So this paper actually has shown a very good way how your entire neuronal circuits get altered when there is hypometabolism there, and we started doing this in our patients. We have so far luckily not seen any hypometabolism. Only one patient I have done thalamotomy as a bilateral thalamotomy, and this is something which I don't want to take risk, and the gap which I give between the second thalamic shot and the first is typically around 2 years, not immediately after the first shot, not 3 years, but this is the earlier patient who had dystonia, and you can see this dystonia has to be primary dystonia, not the monomorphic dystonia as you can see there, where we have done globus pallidus radiosurgery, and this is called pallidotomy, and immediately 6 months after the treatment you can see that is totally gone. So again, I don't say all the patients, pallidotomy is a little risky compared to thalamotomy, but honestly yes, I would say it can be done, and the success rate is around 50%. The third important indication is epilepsy, as you can see there. And in epilepsy, if there is one indication in the entire neurosurgery space which needs extensive imaging and interpretation, it is the epilepsy. And I can say there are several tools which we use. Seizure semiology is more important of it than the video EEG. The anatomical and the anatomy, clinical and electrical, these are very important. This is called AEC hypothesis. In anatomy, what is it that we are doing? The MRI, PET, SPECT and magnetoencephalography. And in electrical, we do ictal and interictal EEG and depth electrodes or the surface grids. And in clinical, of course, semiology is there. So when we advise depth electrodes is very important. That's something what is called as stereo EEG. And stereo EEG is something when there is anatomically negative, you don't find any abnormality there. Or whenever there is a mismatch between the clinical and the electrical data, or when you're seeing a dual pathology. These are the situations when we do depth electrodes, and you can see these electrodes are placed inside the deep zones where you're suspecting the EZ zone is, and from there, once the doses of the anti-epileptics are tapered and the E zone is triggered, you can catch the waveforms, and that's how it is done. So typically when you're dealing with epilepsy, there are 4 strategies that we incorporate. One is the resection, disconnection, ablation and stimulation. So our role is more in ablation. I don't say ablation, it's more modulatory. Everyone would have done, I'm sure many of you have done for gelastic seizures. Gelastic seizures is something which is common in hypothalamic hematomas. Anything in hypothalamus which is just 5 grams, it's a dangerous location. That's something which no neurosurgeon would be confident to go and meddle with hypothalamus. So what really happens is they just want a non-surgical option there, and radio frequency is something which is used, but better than radio frequency is radiosurgery, and you can see it's a single shot. We shoot around 22 to 24 gray based on the doses you're getting on the optic chiasma, and we have some phenomenal response. And if you look into the neurocognitive outcomes, the endocrinologic outcomes, the tumor control outcomes, radiosurgery scores over the other intervention modalities. So hypothalamic hematoma with gelastic seizures is something which we can choose for epilepsy patient. The second important indication is mesial temporal lobe epilepsy. MTLE is something which is very important. When do we do it? When the patient is young, with a high level of functioning, socially adaptable, on the dominant side. So the patient has to fit into this criteria for me to advise radiosurgery. And when you're doing radiosurgery, you typically target the amygdala, hippocampus, and the parahippocampal gyrus. And what happens is, post-radiosurgery, there is a glial skull formation. There is an increased dendritic sprouting, which you see there, and the cortex actually gets reorganized, and that will decrease the neuronal excitability. Now, this is very important for us to keep in mind. When we do mesial temporal lobe epilepsy at 12 months, if you are seeing a good amount of T2 edema, mark my words, these patients are going to be the best, having what I would say angel class 1 response is something which you see there. Now, this is another important area, which is called the insular area. If you are having insular epilepsy, no surgeons would be again comfortable going and meddling with insula. I'm sure many of you would have treated GBMs of the insulas or the astrocytomas. The surgeons actually leave something there. No one is confident about going and doing something there. This patient had epilepsy with a focus. EZ phone was in the this is called FCD, focal cortical dysplasia. FCD has happened. The surgeon has resected. Again, it has recurred. Then we have done stereo EEG, mapped the depth electrodes, and you can see these are the depth electrode localization. And post that, we have done radiosurgery. The fourth important indication is corpus callosotomy. Now, all must have heard about something which is called as drop attacks. These are the patients who actually don't walk. They literally crawl on the floor when they are coming and meeting you, because the moment they stand, they will have the attack and they'll fall down. In fact, many of them come with a lot of injuries. So in this situation, it's more the disconnection that is needed, and corpus callosotomy is something which we can kind of explode. And what we do is we do either anterior callosotomy or posterior callosotomy, and this is typically, you can see the anterior and the posterior callosotomy which is actually done. And the results of anterior callosotomy are little inferior, so we started advocating the posterior callosotomy. For next week I have a patient whom I am doing a selective posterior callosotomy. The last one is the psychoradiosurgery, and what we do is typically the OCD patients. These are the patients who really beg for the treatment. What we do here, we do bilateral double shot ventral capsulotomy, and you can see how the disconnection actually happens. So to conclude my presentation, ladies and gentlemen, we have transitioned from archie-radiosurgery to neo-radiosurgery. Gone are the days when we speak about lesioning. Today we are speaking about modulation, and the responses you're getting for this is because of the modulation. Thank you so very much for your patient listening, and I would like to thank my all Apollo Neurosciences team who are proactively engaged with me in this journey of functional neurosurgery. Thank you so very much.
Thank you so much, sir. I would like to invite Dr. Binduji, Professor and Head, Department of Radiation Oncology.
Thank you, Dr. Sangha. It was a nice exposition of the technical side as well as the practical. I would like to ask you one question.
Please.
What would be the percentage of dry eyes you would find in the TN?
TGN radiosurgery.
Yeah. Because especially with the posterior.
So far in the 400 odd patients, 433, I have not seen even a single patient. Corneal keratitis is something which you are going to get. That is one of the complications. But that's something which you see typically in V1 neuralgia, exclusive V1 neuralgia, right? The patient should be having V1 neuralgia, not in V2 and V3. If you are having in V1, then the chances of the dry eyes is high. What we have, majority of our patient, we had V2 and V3. V1 and V2, that's the kind of combination we had. If you are having isolated V1, then that is clusteretic if it is kind of seasonal, number one, and if it is accompanied with autonomic symptoms. But even in those patients, we do dual targeting. We hit the sphenopalatine ganglion first and then shoot the trigeminal tress. So we have not seen in any of the patients.
Thank you.
Yeah.
Thank you, sir.
Thank you, sir, for your excellent presentation. It's a rather less known or less explored area.
It's less explored. And every neurosurgeon, they think, when I go and speak in the neurosurgery conferences, thinking beyond scalpel, they say, Mera pet kyo mara? Why you are eating my stomach? Honestly, we are not eating your stomach. We are actually supplementing the good work that you are doing. Where they are actually faltering, that is the time we can actually supplement them with better outcomes. Yeah.
Thank you, sir. Can we take a few questions? We can take a few questions.
As we are running short of time, sir, we would be
That's
proceeding further.
Thank you once again. And
thank
thanks,
you,
Arvind,
sir.
for the kind invite, and the Kerala Aroicon chapter office bearers for the invite. Really appreciate that.
Thank you, sir. I would now like to invite Dr. Binduji, Professor and Head, Department of Radiation Oncology, GMC Kannur, to felicitate our presenter and our chairpersons with a memento as a token of appreciation. Thank you, ma'am. Next, we move on to our formal inaugural ceremony.
വെരി ഗുഡ് മോർണിംഗ് എൻ്റെ പ്രിയപ്പെട്ട സുഹൃത്തുക്കളെ. ഞാനിന്ന് ഇംഗ്ലീഷിലും മലയാളത്തിലുമായിട്ടായിരിക്കും ഇവിടെ കാര്യങ്ങൾ സംസാരിക്കുന്നത്. Because of Dr. Surendranath Senapati and because of Dr. Manoj Gupta, I will speak in English, and for the others I will taking in Malayalam. അപ്പം ഞാൻ ഒത്തിരി സമയം എടുക്കുന്നില്ല, വളരെ ചുരുക്കിയ സമയത്ത് തന്നെ. കാരണം നമ്മുടെ ഇന്നത്തെ ഈ ഒരു കോൺഫറൻസ് നമ്മൾ തുടങ്ങിയ സമയത്തിന് 8 മണിക്ക് പറഞ്ഞതെങ്കിലും 8:45 ആണ് നമ്മുടെ ഇന്നത്തെ പരിപാടി തുടങ്ങിയിരിക്കുന്നത്. അപ്പോൾ അതുകൊണ്ട് ഞാൻ ഒത്തിരി സമയം എടുക്കുന്നില്ല. നമ്മുടെ കാര്യങ്ങളെല്ലാം നന്നായിട്ട് നടന്നു പോകേണ്ടതുണ്ട്. അപ്പം ഒറ്റ വാക്കിൽ എല്ലാവരെയും ഞാൻ ആദ്യമായിട്ട് തന്നെ പറയുന്നു. അപ്പം അതിനോട് കൂടി തന്നെ എനിക്ക് പറയാനുള്ള പ്രധാനപ്പെട്ട 2 പോയിൻറ്റുകളും കൂടെ പറയാനുണ്ട്. ഒന്ന്, നമ്മൾ ഈ കോൺഫറൻസ് നടക്കുന്നതിന് ഞാൻ പറയാം, മലയാളത്തിൽ പറഞ്ഞിട്ട് ഞാൻ അതിൻ്റെ കണ്ടൻറ്റ് ഇംഗ്ലീഷിൽ പറയാം. നമ്മൾ ഈ കോൺഫറൻസ് നടക്കുന്നതിനകത്ത് ഉള്ള ഒരു പ്രധാനപ്പെട്ട ക്രൈറ്റീരിയ എന്ന് വെച്ച് കഴിഞ്ഞാൽ, നമ്മുടെ അസോസിയേഷൻ ഓഫ് റേഡിയേഷൻ ഓങ്കോളജി ഓഫ് ഇന്ത്യ കേരള ചാപ്റ്റർ പ്ലസ് നാഷണൽ ചാപ്റ്റർ, നമ്മുടെ പ്രസിഡൻറ്റ് എലക്റ്റും ഇവിടെ ഇരിക്കുന്നുണ്ട്. അപ്പോൾ ഇതിനകത്ത് വേറൊന്നുമല്ല, നമ്മുടെ കൂട്ടത്തിലുള്ള എന്നെപ്പോലുള്ള ഒരാൾ, ഞാൻ എക്സ്ക്ലൂസീവ്ലി കീമോതെറാപ്പി പ്രാക്ടീസ് ചെയ്യുന്നുള്ള 2016 ഞാൻ എൻ്റെ ഡിഗ്രി പാസ് ചെയ്തിറങ്ങിയത്. 2016 തൊട്ട് ഇന്ന് വരെ, ഇന്നിപ്പം 2025 ഞാനൊരു റേഡിയേഷൻ മെഷീൻ വർക്ക് ചെയ്തിട്ടില്ല, തുറന്നു പറയുകയാണ്. പക്ഷേ അതിൻ്റെ പേരിൽ നമ്മുടെ സ്പെഷ്യാലിറ്റി മോശമാണെന്നാണോ? അല്ല. അപ്പം നമ്മുടെ സ്പെഷ്യാലിറ്റി എല്ലാവരെയും ഉൾക്കൊള്ളണം. ഞാനിന്ന് നമ്മുടെ സാനുദേവ് എന്നിവിടെ വന്നിട്ടുണ്ട്. അതുകൊണ്ട് ഞാൻ മലയാളത്തിൽ പറയാമെന്ന് വിചാരിച്ചാൽ കൊണ്ട് തന്നെയാണ്. കാരണം ഇതിനകത്ത് കുറച്ച് മനസ്സിലുള്ള കാര്യങ്ങൾ വരണം. സനുദേവ് നമ്മുടെ എന്നെ പോലെ തന്നെ DM എടുത്ത് പോയൊരു വ്യക്തിയാണ്. എന്നെ പോലെ വെച്ചാൽ ഞാൻ പറഞ്ഞല്ല, ഞാനും സനുദേവൊക്കെ ഒരുമിച്ചിട്ട് ഞങ്ങൾ റേഡിയേഷൻ ഓങ്കോളജി കഴിഞ്ഞിട്ട് DM പോകണമെന്ന് വെച്ചിട്ട് ഇരുന്ന വ്യക്തിത്വങ്ങളാണ്. സനുദേവ് അതെടുത്ത്. പക്ഷേ സനുദേവനോട് നമ്മുടെ കൂട്ടത്തിലുള്ള ഒത്തിരി ആൾക്കാർക്ക് എതിർപ്പുണ്ട്. ഞാനത് തുറന്ന് പറയുന്നത് അതുകൊണ്ടാണ്. ഞാൻ ഈ പ്രസംഗ സമയത്ത് ഞാൻ 5 മിനിറ്റ് എടുക്കത്തുള്ളൂ, പക്ഷെ ഞാൻ തുറന്ന് പറയുകയാണ്. സ്ഥാനത്തെ എന്ത് കുറ്റം ചെയ്തിട്ടാണ് ആ പ്രശ്നങ്ങളൊക്കെ? അപ്പം നമ്മൾ അതിനകത്ത് നമ്മുടെ ഒരു സ്പെഷ്യാലിറ്റി, നമ്മുടെ ഒരു പേരൻറ്റ് സ്പെഷ്യാലിറ്റി ആയിട്ട് ഇതിനെ കാണണം. ഇല്ലാതെ മുന്നോട്ട് പോയിട്ട് കാര്യമില്ല. കാരണം നമ്മളാണ് വർക്ക് ചെയ്യുന്നത്. വി ആർ വർക്കിംഗ് ഫോർ ദ ഡി എം മെഡിക്കൽ ഓങ്കോളജി. നമ്മളിപ്പോൾ ഒത്തിരി ഇടപെട്ടെന്ന് വെച്ച് കഴിഞ്ഞാൽ എന്താ, നമ്മൾ ഡി എം മെഡിക്കൽ ഓങ്കോളജി എഴുതാനായിട്ട് MD റേഡിയേഷൻ ഓങ്കോളജി ആൾക്കാരെ വേണം എന്ന് പറഞ്ഞിട്ട് നമ്മൾ കേസ് കിടക്കുന്നു, നമ്മൾ കത്തെഴുതുന്നു, എല്ലാം നമ്മൾ ചെയ്യുന്നു. അപ്പം അങ്ങനെ ചെയ്തിട്ട് നമ്മൾ ഇനി അവരൊക്കെ നമ്മുടെ എതിർ പാർട്ടിയാണെന്ന് പറയുന്നത് ശരിയല്ല. അവരെ നമ്മുടെ ഇൻക്ലൂഷനായിട്ട് തന്നെ കാണണം. അതാണ് എൻ്റെ ഫസ്റ്റ് പോയിൻ്റ്. പിന്നെ എല്ലാവരെയും സ്വീകരിക്കണം എന്നുള്ള കാര്യം, അത് എന്താ പറയുക, ഞാനല്ല പറയേണ്ടത്. എന്നെക്കാളും സീനിയറായിട്ടുള്ള ഫാക്കൽറ്റി, നമ്മുടെ നാഷണൽ പ്രസിഡൻ്റ് ഉണ്ട്, നാഷണൽ പ്രസിഡൻ്റ് അറോയി ഉണ്ട്, നാഷണൽ ചെയറുണ്ട്, എല്ലാവരും ഉണ്ട്, അവരാണ് പറയേണ്ടത്. പക്ഷേ എൻ്റെ ഒരു സജഷൻ ഞാൻ പറയുകയാണ്. ഞാൻ സമയം എനിക്ക് 3-4 മിനിറ്റാണ് തന്നിട്ടുള്ളത്. ഞാൻ വെൽക്കമാണ് എനിക്ക്. പക്ഷേ ഞാൻ ഈ പോയിൻ്റ് പറയേണ്ട ആവശ്യമുള്ളതുകൊണ്ടാണ് ഞാൻ പറയുന്നത്. നമ്മുടെ ഒരു പേരൻറ്റ് സ്പെഷ്യാലിറ്റി ആയിട്ട് മാറേണ്ട ആവശ്യം നമുക്കുണ്ട്. DM മെഡിക്കൽ ഓങ്കോളജിയുടെ പേരൻറ്റ് സ്പെഷ്യാലിറ്റി MD റേഡിയോതെറാപ്പി ആകണം. അത് MD മെഡിസിൻ ആകരുത്, MD പീഡിയാട്രിക്സ് ആകരുത്. നമ്മളായിരിക്കണം ആ സ്പെഷ്യാലിറ്റി. നമ്മുടെ കൂട്ടത്തിൽ നിന്ന് നാളെ ഞാൻ DM എടുത്തു കഴിഞ്ഞാൽ നിങ്ങൾ എന്നെ എതിർക്കുമോ? അതാണ് എൻ്റെ ചോദ്യം. ഞാൻ നാളെ DM എടുക്കും, നിങ്ങൾ എന്നെ എതിർക്കുമോ? ഇന്ന് ഞാൻ സെക്രട്ടറി ഇവിടെ. അപ്പം അത്രയും പറഞ്ഞുകൊണ്ട് ഈ ഇരിക്കുന്ന എല്ലാവരും ഞാൻ വെൽക്കം ചെയ്തുകൊണ്ട് ഒറ്റ വാക്ക് നിർത്തുന്നു. നന്ദി, നമസ്കാരം.
Thank you, sir. Now I would like to invite Dr. Francis V. James to deliver the presidential address.
Good afternoon, everyone. Our respected leaders on the dais and all the people in the audience, I welcome all you to this meeting. Now, it's quite pleasing to see that now there are more than 200 members for Aroicon Kerala chapter. And there are about 100 residents in the state, which is a big number. When in the olden days, we used to have very few people, and the treatments were very few. And radiation oncologists used to see all new patients without asking. Everyone used to refer our patients. So we are loaded with patients, and we struggle hard. So we never looked around. We kept ourselves in the department, not letting anyone know that what we are doing. Now the scenario has changed. Now there are lots of other oncologists, medical oncologists, surgical oncologists, pediatric oncologists, gynec oncologists, head and neck oncologists. So now we are not working in the olden days. So we are working among a big group of different types of oncologists. So unlike in the past, we never looked around. Now we have to look around, and we have to convince them what we are doing. Because previously, we only had to do our work. Now we have to convince others that we are doing good job, which is terrific job. We are curing lot of patients. We are giving adjuvant treatment for lots of patients and making their life better. And we are also offering palliative radiotherapy. All these things have huge impact on the society. We are making, when we cure a patient, their family got a father, their family got a mother, or they got a child alive. All these are huge effects, which we have to convince and show to the society that we are doing this thing. This is very important, which we are not doing, concentrating. We just concentrate on the department, do the job, and go home. I think for all youngsters, you will have to make big Excel spreadsheets and collect data of all our patients we are treating, and have to record our outcomes and toxicity so that we can convince others that this is the result of our patients. We cure so many, we reduce recurrence so many, we achieve palliation for considerable number of patients, and also we produce very limited number of toxicity. Those things we have to collect, show the society, show the fraternity, and convince everyone that this is a wonderful specialty. Then we will get respect. Thank you.
Thank you, sir. We would wish to inaugurate this event by lighting the lamp. It's my honor to invite Dr. Surendranath Senapati, our National President Aroy, to come forward for the lamp lighting ceremony. And I would request all other dignitaries to join in. Thank you, sir, and thank you all. Now I'd like to invite Dr. C.S. Madhu to come forward for the souvenir release.
ഈ ഒരു സെവനിയർ റിലീസ് സത്യം പറഞ്ഞു കഴിഞ്ഞു കഴിഞ്ഞാൽ നമ്മുടെ അറോയിൽ ആദ്യമായിട്ട് നടക്കുന്ന സംരംഭമാണ്. ആസ് എ സെക്രട്ടറി എനിക്ക് അതിനകത്ത് സന്തോഷം ഉണ്ടെങ്കിൽ പോലും എൻ്റെ കഴിവല്ല ഇത് അരുൺ സാറിൻ്റെ അദ്ദേഹത്തിൻ്റെ എഫർട്ട് മാത്രം കൊണ്ടാണ് ഈ നടക്കുന്നത്. അദ്ദേഹം ഇതിനകത്ത് ഇട്ടൊരു എഫർട്ട് കാരണം വേറൊന്നുമല്ല, ഈ ഒരു സെവനിയർ ആസ് എ സെക്രട്ടറി റിലീസ് ചെയ്യുമെന്ന് ഞാൻ പ്രതീക്ഷിച്ചു പോലുമില്ല. അപ്പോൾ അരുൺ സാറിന് ഒരു നല്ല ക്ലാപ്പ് കൊടുക്കണം, കാരണം അദ്ദേഹത്തിൻ്റെ എഫർട്ട് മാത്രമാണിത്.
I would request Dr. Surendranath Senapati, National President Aroy, to come forward for the inaugural speech.
Respected dignitaries on the dais and the members of ARI, you know, ARI is the largest oncology community of our country, having its membership more than 5,500 plus. So this is our family, and you all are the brilliant stars of this family. And I am lucky that you have full confidence on me. With me, my predecessors, Professor Manoj Gupta, my successor, Professor M.S. Madhu, and in front of me and also on the desk, the pillars of our association. Actually, whatever mistake that will commit, the beautiful pillars who are sitting in front and also here, they guide us that yes, this is our society and this is our association. With the blessing of all of you, I told that this is the largest community, and we are also not so poor. I know when I started my career and when I entered into the ARI as a HUT member, first I was the junior vice president. At that time the budget was only 20,000.
Now it's more than 5 crores. So friends, this is our society, but this society is meant for all of you. You are the stars of this society. Sitting as the president of ARI, I have also given my message in the ARI in 2024 when I took as the president. What should be my aim and vision? Actually, I could not follow what Sabina told. You may excuse me. But very important, the future prospects of our members. We are in a process to know actually what is the exact scenario of the cancer treatment in our country. We do not know. But if we take the data, majority of the cancer patient care are being taken by the radiation oncologist at the not only in center but also periphery. I am giving a small example. In my center, there is 5 topics the super specialized there. We are going to start the DM medical oncology this time. But do you know there are 6 posts of the DM medical oncology post is vacant? Because those who are DM in medical oncology, they are not coming to join. But if you see the radiation oncologist in all the medical colleges or at periphery, it's only radiation oncology they are giving services. But we have no data. So we are going to collect the data. And once we collect the data, we'll definitely approach the government that yes, this is the standard of the radiation oncology and our aim is to start the radiation oncology unit in each and every medical colleges. So that there is good job opportunity. I appreciate the effort of Dr. Manoj Gupta when he was the president and also I was the yes, at that time he has taken a lot of effort. Because there is, at certain point of time, we the radiation oncologists were not eligible for the DM medical oncology. And the question pattern has changed. But it's due to the effort of Dr. Manoj and the team that we could succeed. That yes, we are eligible for the DM medical oncology. And also the question pattern, what it was before, that is still persists. And we have also made some subcommittee. For the first time we have made subcommittee that representation for the FARO, representation for the ASCO, representation for the ISTRO and the government liaisoning. And we said that the site-wise, we have also made some subcommittee so that they can take up the responsibility and also we can go ahead. But very important, we need your feedback and also interactions from your side so that the head office can know actually what is happening. Regarding the teaching program, we have taken a lot of effort. And for this time, we are also going to introduce the ASCO teaching course. It was not there. We had the ISTRO teaching course, like 3 ISTRO teaching course in gynae, head and neck oncology, and also modern technique. And 3 ICRO teaching program every year. And also +1 at the annual conference. But gradually what we are observing that there is little less response from the postgraduates. Friends, actually this program is meant for all of you. You can derive maximum benefit from these teaching programs. Because I know the teaching pattern in all the medical colleges or in all the facilities are not same. The infrastructures are also not same. Basing on that, we decided to have all these teaching programs so that our students will be benefited. And once they attend this program, they can also ventilate this message to their friends and their colleagues. And all the materials are uploaded in our website, the ICRO teaching program material. You can utilize this for your teaching purposes. Very important, we are also trying to have more and more interactions regarding AI, because AI has come out in a very big way. And we are also trying to have some programs about AI so that artificial intelligence, we, the people, can also maximum utilize the AI in our technology. With this, I really appreciate this Tamil Nadu chapter, this Kerala chapter, that you are having the maximum number of representations, maximum number of members of the ARI. And you are all the eye-opener for the future of the ARI national chapter. So with this, I thanks the organizer for inviting me and also our national executive to have this best scientific program. The morning program I have already witnessed, and also I'm going to witness the coming 2 days program. Hope this program will be one of the most successful program, and I request the chairs and also the secretary to have a short writing and also with the photographs to send the headquarters so that it would come out in our, yes. Thank you, friends. Thank you once again.
Thank you, sir. Now I would like to invite Dr. C.S. Madhu, President-elect National Roy, to address the gathering.
Respected Chair, Roy, Dr. Professor Manoj Gupta, President AROI, Dr. Surendranath Senapati, President Kerala Chapter, Dr. Francis V. James, President-elect, our beloved Dr. K.L. Jayakumar, Secretary Kerala Chapter, our Shabarinath, and Dr. Nibin Bose, dignitaries of the dais, my dear colleagues. The first thing which I would like to say to Kerala chapter members is a big thank you for supporting me in the election process, because without all your support, it would not have been possible for me to be victorious. In this context, I would like to specially mention the efforts by Professor Francis and also by Professor Jayakumar and our beloved Secretary, Dr. Shabarinath. Actually, it is all motivation by Dr. Shabari and Dr. Francis that I finally decided to contest for the presidentship. And of course, Kerala is a small chapter with only around 170 to 200 members. So I am also highly indebted to my alma mater, the alma mater of the radiation oncologist in me, that is Madras Medical College, from where I could get good support. So that is also one of the reasons why I could finally win. Now coming to our specialty related issues. We all know that we are facing a lot of challenges. First and foremost, I think of my student days. At that time, we had a posting in radiotherapy. It was actually posting in radiology. And it was, the department was not bifurcated at that time. So in the morning, we used to have radio diagnosis up to say 10 o'clock. Then we used to go for coffee. And then we used to have very good teaching program in radiotherapy. I remember my teachers, Professor Krishnan Nair, Professor Padmanabhan, Professor T.C. Nair, and Professor V.G. Sudhakaran, Dr. Rajan, all these people taught us. And by the time we passed out, we were very, very informative, and we were all convinced that early cancer can be cured. And at least 5 of us took radiotherapy for post-graduation. When that was the situation then, now think of today. The department got the radiology at that time, as per the Medical Council stipulations for 100 MBBS admissions, the head of the department can be either a radiotherapy fellow or a radiodiagnosis fellow. But with regard to associate professor, there was a need of one from radiotherapy and one from radiodiagnosis. So, in other words, our specialty was a compulsory one. But now, that is not the situation. Now there are radiotherapy departments in many of our government medical colleges. The newer government medical colleges do not have. But there are so many private institutions where, the private medical colleges where there is a specialty. There are many private institutions where this specialty is not existing. It is all because of their pressure that the Medical Council is not making this specialty an obligatory one for 100 MBBS admissions. So we have unemployment, we have to change this, and now we find that in the NMC documents, there is a mention, there is one paragraph about need of radiotherapy department. So what has happened over the years is that the people who pass out do not have any knowledge regarding the radiotherapy and its effectiveness. In fact, most of the MBBS students, who appear for NEET, and then when they get a rank and when they are to choose the specialty, they don't take up radiotherapy because they think that there is a lot of radiation hazard. We know that the radiation hazard in the modern radiation oncology department is practically nil. But they are so much ignorant about all these things. And as Professor Francis told, in the past, it used to be the radiotherapy department used to handle all the referrals. But now the situation has changed. But when the specialty association was formed, the name of the association could have been the clinical oncology. But at that time, there was no medical oncology, there was no surgical oncology, no gynecology oncology. But even then, our leaders at that time somehow decided that it should be radiation oncology. Because that time there were no challenges. That is why it happened. But now, everywhere we are doing all the works. We are administering chemotherapy in most of the government institutions, government medical colleges in the country. We are also handling chemotherapy in many private institutions. More than 60% of the chemotherapy, etc., are done by the so-called radiotherapists or radiation oncologists. But the name of this specialty remains as radiotherapy or radiation oncology. So here, I would like to specially mention the name of Dr. Sabarinath, because actually I am not criticizing our national chapter, but it is following a case filed by Dr. Sabarinath and some other colleagues of us, that there was a meeting held at the Medical Council level, and there were some opponents also. from the medical oncology side, he approached to change the name of the specialty to clinical oncology, but there was opposition from our medical oncology friends, and Shabarinath alone was there to argue for our specialty, whereas there were 5 or 6 people on the other side. There were nobody from our association. There were no senior oncologists at that time. We all know that when there are many people, many brains work together. So those at that point of time, there could have been better solutions. But past is past, but we should act now. So it was following that discussion and the court involvement that finally the name of the specialty has changed from radiotherapy to radiation oncology. So even though we were the real oncologists, we were radiotherapists till then. But at that point of time, we became oncologists. We know that the practice of specialty in United Kingdom, how it is, and now there is a faculty, in the Royal College, there is a faculty of clinical oncology, and the name of this specialty is clinical oncology. Clinical oncologists have, many of our MD radiotherapy holders have passed FRCR successfully, and some of them have got registered with the Medical Council, and the Medical Council has given the acceptance of clinical oncology as a specialty. Now this is the time for us to move forward and start a DM course, which is a must, because when it comes to the selection of directorships, when it comes to, say, multidisciplinary tumor boards, etc., the radiotherapy is a broad specialty. Radiation oncology is a broad specialty, whereas the surgical oncology and also medical oncology, they are super specialty. So this has to change. So we should have a DM course. It is immaterial whether it is a clinical oncology or radiotherapy and oncology, but DM course is a must, and the course should give coverage for all aspects: the pharmacotherapy, the molecular oncology, the genetics, radiotherapy, radiation physics, radiobiology, as it is in as it is in the syllabus of FRCR course. So our aim should be mainly for starting such a course. And now the NMC has invited proposals. Now we expect our leading departments from Kerala and also from other states to submit proposals to the NMC, and definitely the NMC will take it up, and we will be able to start DM course in many institutions. So we have to be united in this. There should not be, what happens in our annual general body is that we are not still decided about the what should be the name of the specialty, etc. So these things have to change. Now we have decided, now there is a radiotherapy and oncology course already being conducted in Jodhpur. So like that, let it be, whatever it be. Whatever be it, whatever be the name, there should be a DM course, and it can be radiotherapy and oncology. So, we should be united, and there should not be any sort of disagreement between our members in these things. And I don't want to prolong my talk. As Dr. Surendra Senapati rightly pointed out, the scientific sessions were excellent. The talks by Dr. Sridhar and Dr. Shankar Vangipuram, both of them did very well. And I wanted to have a chat with Dr. Sridhar on many of the things. I didn't get a time to discuss during the session. But anyway, a lot of insights. Anyway, I don't want to prolong further. We have to be united. We should act strong and come forward. And our aim of starting the DM course should definitely be a success. With regard to our Dr. Shabarinath, he is very hardworking. He speaks very good English. He communicates very well. He is a good oncologist. But today he was speaking in Malayalam, which I did not like. But, otherwise, I was looking forward to him coming to the national scenario as a secretary, because he has done maximum for the association. I want to request, I would like to request Dr. Senapati and also Dr. Manoj Gupta to forgive him for his today's Malayalam speech. He is very good. He should come forward. He should have a good future. I don't want to talk too much. Anyway, thank you all for electing me. I will try my best during my tenure, if God permits. Thank you all.
Thank you, sir. I would now like to invite Dr. Manoj Gupta, Chair Roy, to deliver the keynote address.
Thank you very much. I will not take much time. I think all of us are feeling hungry. I will only say that, yes, Kerala can be a small chapter, but I always appreciate Kerala community of radiation oncologists for their innovative ideas. And, this is my second conference I am attending. So the idea which they have given to us is destination conference. I have heard about destination wedding, but destination conference is an innovative idea which I learned from Kerala chapter. But on a serious note, the innovative idea which I liked was district oncology program, which is already prevailing in Kerala state, where most of the district hospital are having radiation oncologists who are providing services to cancer patients. I firmly believe that radiation oncologists are the real cancer specialists who are involved right from diagnosis to awareness to treatment to palliative care to end of life care. So I firmly believe that radiation oncologists are the true oncologists, and if we really want to see last man in the queue to have treatment facilities for cancer, I think it is very essential that this Kerala model should be implemented throughout the country. And right now, if you see, right now, and on this topic, I already, discussed with the government. I was one of the member of the committee constituted by government to improve the infrastructure of radiotherapy in our country. So I already proposed that every district should have a radiation oncologist, because now government is planning to have a medical college in every district, and right now data says that we have almost 707 medical college, and we have around 780 districts in the country. So we are almost going to achieve the goal of one medical college in one district. And if we appoint a radiation oncology oncologists in every medical college, I think we can provide the treatment services to the door of the patients, and this will generate more employability for the radiation oncology. So with these words, I thank the organizing committee for having invited me on this destination conference. Thank you very much.
Thank you, sir. Now I would like to invite Dr. K.L. Jayakumar, President-elect, Aroy Kerala Chapter, to felicitate the gathering.
Respected members on the dais, my dear friends and students, I am happy and delighted to be associating in organizing this important meeting, Kerala Aroicon 2025, at this wonderful place, Munnar. I am also happy that many of the young members are attending this conference, and they have joined and they have presented their papers, which usually was not the previous thing. Now many youngsters are coming to associate with our association. So that way also we are very happy. This is not a single man's job. All the members across Kerala of our association have jointly involved in organizing this important meeting. The scientific sessions were excellent, deliberations were good, and also the postgraduate students have got the opportunity to present their papers. That way it is good. So with these few words, I congratulate the organizers who are in forefront, and also wish this meeting a big success. Thank you very much.
Thank you, sir. Now I would like to invite Dr. Nibin Bose, Treasurer, Aroy Kerala Chapter, to deliver the vote of thanks.
Respected dignitaries on the dais, teachers, senior faculties, and my dear friends, I think it's a great privilege to be here to deliver a vote of thanks to the most eminent personalities in the specialty across the country. So, but we are running out of time, too late. So I express my sincere gratitude to, on behalf of Kerala Aroy Chapter, to Senapati sir, Manoj Gupta sir, Madhu sir, Francis sir, Jayakumar sir, and Shabarinath, to joining with us and enlighten us with your presence. Then a special thanks to Dr. Arun Shankar for the sincere efforts taken for the souvenir. And I thanking all of you to coming all this way to Munnar to attend this program. And I express my gratitude to the pharma friends to associating with us. Thank you all of you.
Thank you, sir. With this, we have come to the end of our formal inaugural ceremony. Thank you all for joining in. Now you'll be taking a break for lunch. Lunch has been arranged at the restaurant, which is at the -1 level. I request all delegates to gather back by 2:15 p.m. for our next session, which is Gynec-Oncology Tumor Board discussion. Thank you.
Because of the delay in the morning program, the GB is postponed to 6 p.m. So it will be after the...
You can see our experience is about 55% of them are some form of hypofractionation and SBRT. Of course, you can do conventional also. You can do conventional 25 fraction, 35 fraction, 30, any number of conventional fraction also is possible. Most importantly, with this machine, it's proven now that the toxicity, especially the grade 3, is lower with this machine. Of course, there are multiple papers showing that the normal tissue complication probability is significantly lower with this machine. And a lot of parallel trials are going on. The experience, as I mentioned, you can treat almost all types of cancer. It is not just for very soft tissue oriented like prostate, pancreas. The clinical experience shows you can treat varieties of cancer with this machine. This is just one example where from MSK-CC, you get this 50 gray delivered in 5 fraction for pancreas, and they are reporting no grade 3 toxicity. And this one is from UMC, where they are delineating additional arteries to preserve the erectile function and maintaining the local tumor control. This is a 2 fraction prostate example from Royal Marsden. This is a classic liver case. Of course, you can appreciate why we need an MR Linac here. You can produce a huge better dose gradient with our agility MLC. This is an example of gating where you see whenever there is that orange display appears, we stop the beam instantaneously. V means the machine stops automatically. We take our hands off. Yeah, so there is this clinical trial that shows it is going to be very useful to reduce the CTV margin as well, GTV margin as well. So I'll skip considering time. Okay, this is a case where you can directly track the cord. I believe you don't need to rely on any other. This is a response guided radiation therapy, which we used to talk. Now we can really do that. This is another example of gating, where you gate and stop the beam. Yeah, okay, this is a beautiful example where you deliver. We never take risk with this kind of cases, but you can now comfortably treat these kind of cases just with 3 mm CTV to PTV margin for beating heart. That is only possible because of this that you are seeing now in the screen. You can real-time track it. Yeah, of course, for cervix, you can have a considerably lower PTV margin, I believe. This is a case where DWI will be helpful. It already shows a difference. You can see T2 is not showing any difference, but ADC picks up a difference, which will enable you to take a dose escalation or de-escalation strategy. So overall, we are giving you a machine which will give you a beautiful image quality, and it will allow you to do online adaptation. And of course, you can treat real time when you are seeing, and gate the beam automatically with the different gating options. And of course, you can do biological guided radiation therapy. So that's about this machine. Do I have time to go further, or 1 more minute? So maybe I can take a question. I cannot go with the other machine now, time constraint. Maybe I can take any questions. Sir, I showed 2 workflows. One is adapt to position, which is relatively a simpler one, where you just move the dose cloud like this rigidly. It takes about 10 minutes, 15 minutes. But the other one, which is an exhaustive online adaptive replanning procedure, which might take about anywhere between 20 to 40 minutes.
If you do that in a traditional Linac, the treatment time is only 2 to 3 minutes. So there isn't enough time for bladder filling or changes in bowel. Your advantage is lost by the extra time you taken to treat. So it is advantage to see and treat with narrow margin, but if you allow more time for treatment,
absolutely,
then that's lost.
That is exactly why we are giving a dynamic drift correction approach, sir, where if there is any filling happens, dynamically you can correct the field. You don't need to again do a full-fledged planning. You can just correct for the fillings.
And for planning, what algorithm you use?
Dose calculation, sir. Monte Carlo, sir. Yes. Sir, I am not a sales guy.
Just want to get an idea.
No, sir. I am probably. Okay, thanks. Thank you all.
Thank you, sir. Now we'll be moving on with our next session, which is a gynecology tumor board discussion, moderated by Dr. Naveen Kumar, Assistant Professor, Government Medical College, Trivandrum. To join the discussion, I invite Dr. Krishna Ji, Professor, Department of Pathology, Sri Gokulam Medical College, Trivandrum. Dr. Chitratara K, Professor and Head of Department, Surgical and Gynecology, Lakeshore Hospital, Cochin. Dr. John Joseph, Associate Professor, Department of Radiation Oncology, RCC Trivandrum, and Dr. Anu N. Joseph, Consultant, Gynec Oncology, Bharat Hospital, Kottayam. I invite Dr. Naveen sir onto the dais.
Aravi@gmail.com.
Hello. Good afternoon to all the delegates. I'd like to welcome all of you to this multidisciplinary tumor board session on gynecological malignancies. Before we start, I'd just like to inform you all that this would be a closed session, which means, unfortunately, we would not be taking any questions during or immediately after the session. However, we'll be giving you a number and a mail ID if you have any questions, and we'll clarify it. Okay, thank you. So if the consultants are all ready, shall we start? Okay. So we'll start with the first case. It's that of a 40-year-old lady who has completed her family. Okay, let's continue with the case. So she's a 40-year-old lady, completed a family with 2 living children, ECOG performance status of 1, with no known comorbidities. She was evaluated for intermittent bleeding, intermenstrual bleeding and postcoital bleeding of 2 months duration. On clinical examination, the cervix looked unhealthy with an erosion of the anterior lip with bloodstained discharge at the os. All the other parameters were normal. Fornicis, mucosa, parametry were all normal. An imaging was done which showed an endocervical lesion measuring 18 into 20 millimeters with disruption in the stromal hypointensity extending less than 50%. The lesion was also extending to the lower uterine segment, causing endometrial thickening and partial disruption of the endometrial myometrial junction. So radiologically, it was opined that it could be a malignancy of the endocervix or the endometrium. And a biopsy was taken from the primary lesion. Now I would like to ask Krishna ma'am on how to proceed with the, in this particular scenario, how to proceed with the biopsy.
Now, the biopsy of the endocervix and endometrium both will show only adenocarcinoma. If the pattern-wise, morphology-wise, it is very difficult for a pathologist to pinpoint in this situation where the growth is extending from the endometrium up to the
lower uterine segment.
LUS is also involved. So the tumor can extend up from the endocervix also. So morphologically, it will show only a glandular pattern, and even mucinous areas, which is mentioned for endocervical adenocarcinoma, you can get mucinous areas in the endometrium also. So what we do is, now we resort to a panel of markers. But when we choose panel of markers, you have to be very judicious, and a single marker will not give you a confirmatory result. So it's very important on the part of the pathologist to use a panel of markers, which I'll show you here. Now you all know that endocervical adenocarcinoma is recently been divided into 2 groups, which is HPV related and HPV non-related. And usually the differential diagnosis in the difficulty comes when the endometrioid carcinoma is of low grade type. And so the markers which we employ, the panel should include an ERPR, P16, P63 and HPV when if it is available for diagnosis. HPV ideally demonstrated by fish technique. So ERPR is usually negative in both HPV related and HPV non-related cancers, where it is usually very strongly diffusely positive in endometrioid carcinoma with or without mucinous component. Now coming to P53, it will exhibit a wild positivity in HPV related endocervical adenocarcinoma. It may be a wild or mutant pattern in endocervical HPV non-related carcinoma. I hope the audience know the interpretation of P53 staining, which a pathologist has to know very thoroughly when you interpret the staining with the IHC. Now, the low-grade endometrioid carcinoma will also show a wild positivity. Briefly, I will say that wild positivity means a patchy positivity, a mosaic pattern. Here and there, some of the nuclei will take up, but it will not be a uniform staining. That is wild positivity. Now, coming to P16, which is the clinching marker, it will be diffuse and strong in endocervical HPV-related cancer, but focally it may be positive in non-related cancer, but it is a weak positivity. But coming again, endometrioid, and then endometrioid also it is variably positive. So the positivity may be focal, but it is diffuse positivity. Now coming to the HR-HPV, the viral genome which is getting demonstrated, it's usually positive only in HPV-related endocervical adenocarcinoma, whereas the other two will turn negative. So if you look at these markers, if you employ these 4 in your panel, you will be able to tell your clinician the definite diagnosis, whether it is endocervical adeno or an endometrioid carcinoma.
Thank you, ma'am. So the biopsy, as ma'am said, came out to be...
But then there are just 1 minute. Next slide, please. Now this is the pattern which we say when there is a diffuse positivity. You can see that the uniform brown staining of the nuclei, that is saying that is diffuse positivity, where there is the presence of P16, that high risk DNA will be staining. The other one shows the B. The slide shows only a focal positivity. Next slide. Now this the differential diagnosis will again come when there is endocervical HPV related and a high grade endometrioid carcinoma and a type 2 carcinoma of the endometrium, that is endometrial serous carcinoma. There again we employ this battery of markers, the same markers, ERPR, P53, P16 and HR-HPV. As you can see, this ERPR is again uniformly negative in endocervical HPV related cancer, whereas in high grade it is usually positive, but serous carcinoma will also turn negative for hormonal markers, unlike the type 1 endometrial cancer. So P53 is again wild in HPV related endocervical, but P53 again in high grade endometrioid, it is wild or some mutation you can see, but in serous it's again a mutant pattern always. Again P16, as you can see, it is positive in HPV related, variably patchy positivity in endometrial high grade endometrioid, and it is usually very positive, diffuse positive in serous carcinoma. And HR-HPV, the endocervical HPV related will turn positive, but endometrioid high grade is usually negative, and the other one serous is also negative. Thus, whether it is an endometrioid carcinoma, high grade, low grade, or endometrial type 2 serous carcinoma or clear cell carcinoma, with endocervical adenocarcinoma, these 4 markers will definitely help the pathologist to cleanse the diagnosis. Okay. Next slide. Now, in HPV non-related endocervical carcinoma, there are different types. Gastric type is there. And then in those situations, they recommend employ other markers like carcinoembryonic antigen, which is positive in HPV related endocervical and it is negative in endometrial also. These 2 markers, CEA and vimentin, can also be used to differentiate the endometrioid carcinoma and endocervical adenocarcinoma. One more slide is there. So that is what I was going to mention, that non-HPV related, which is the gastric type, clear cell or mesonephric, P16 is negative or focally positive, but hormone receptors are always negative. So those hormone receptors, ER and PR, could clearly tell you whether it is a non-HPV related gastric carcinoma where P16 is actually negative or only focally positive. And in mesonephric morphology, GATA3 could be employed, so that becomes positive. So that is non-HPV related adenocarcinoma of the cervix, and the endometrial adenocarcinoma will not cause much a problem for the pathologist for differentiation, because morphologically also there is definite features to say they are the non-HPV related endocervical adenocarcinoma. Added to this, you can employ these markers, especially because P16 will turn negative and only focally positive in these two carcinomas, these types of carcinomas, but hormone receptors is always negative. So combination of these markers will definitely help the pathologist to pinpoint the differentiation in the malignancy.
Thank you, ma'am. So the final pathology report came as stage 1B1, carcinoma of the endocervix, adenocarcinoma. Now the MDT has to decide on a treatment plan. Shall we start with Dr. Anu Joseph?
Okay, she is a young patient, 40-year-old, and clinically, radiologically, it was an early invasive cervical carcinoma, which is confirmed by IHC also. So we go for surgery, because as we know, the surgical part and the radiation at the early cervical cancer, almost both of them have good results. But this lady is a 40-year-old, and radiologically and clinically it's stage 1B1. And on the behalf of surgery, you can see if you go through the latest NCCN guidelines, you can see that in 1A to 1B1, simple or as type A hysterectomy is as the guidelines. Because a recent trial, that is a SHAPE trial, which compared the simple hysterectomy versus radical hysterectomy in small size lesions, less than 2 centimeter lesions. They compared the morbidity and the overall survival, 3-year overall survival, which shows there is no significant difference in the overall survival between the type A hysterectomy or type B hysterectomy. And the radical hysterectomy has more of these urological morbidities are also there. So, but some criteria should be met in the 1B1. That must be the tumor size should be less than or equal to 2 centimeter, which is here it is 2 centimeter. And the MRI suggestive of a depth of invasion should be less than half of the stromal invasion. Or if we have done a conization, sometimes we do the conization procedure, and if it is done, the depth of invasion should be less than 10 millimeters, and preferably no LVSI in the conization specimen. So, in that, if all the conservative measures are met, and this is adenocarcinoma, so that should be grade 1 or grade 2, and all squamous cell carcinomas. So, if all the criteria have been met, we can do a type A hysterectomy.
Dr. John, do you have an alternate plan of action for this patient, or do you concur with Dr. Anu's decision?
No, the evidence to select the treatment modality for this patient comes from this trial, which is the major trial comparing surgery versus radiotherapy in early stage cervical cancer. This is the 20-year update of this Landoni et al. Trial, and you can see that the overall survival and disease-free survival of both modalities are almost comparable, as Dr. Anu pointed out. So the outcome is similar. The difference is only in the toxicity. If you use surgery, you are expecting more of urological toxicities, and if you are using radiotherapy, you can expect more of bowel toxicities. And as pointed out earlier, the size of the lesion is critical. As the size increases, the advantage of RT comes in. So there are recent papers that says that up to 3 centimeters only you limit your surgical option, and more than 3 centimeters you consider RT. And these are some of the recent trials which also show that the 5-year overall survival for these patients, all these trials included 1B1 and 2A patients also, comes to around, both the modalities comes to around 80%. So the decision is based on whether you have to spare the fertility and the histology. The adenocarcinoma usually tend to behave less, respond less to RT, but the outcome with surgery also may be a little worse than the squamous cell carcinoma cervix.
Okay, so do we have a final MD decision? It is to go ahead. Yes.
A little clarification, because in SHAPE trial actually they have used type A hysterectomy, because whatever they have used simple hysterectomy, that is type 1A corolomoro, that is different from a simple hysterectomy. So they should not, people should not carry that message. And currently the accepted treatment for this B1 is according to NCCN guideline and ESCO guideline, it is a radical hysterectomy level category level 1 evidence.
Okay, so the final decision is to go ahead with the radical hysterectomy for this patient or radiotherapy. Right. So that would bring us to the end of the first case. So the next case is that of a 24-year-old nulliparous lady with no comorbidities, a good performance status of 1. She was evaluated for a recent onset abdominal distension, and an ultrasound done showed a large abdominopelvic solid mass with a small cystic areas. A CT abdomen and pelvis showed a large pelvic mass arising from the left adnexa, measuring 12 into 18.4 into 18.6 centimeters, which is mostly solid with cystic areas suggestive of a left ovarian malignance, neoplasm. Considering the young age, tumor markers were done and only serum LDH was elevated. So the possibility of a left ovarian germ cell tumor was considered. So what would be the treatment plan for such a patient? So I'd like to ask Chitratara ma'am what the initial treatment plan would be for this patient.
We can go with the upfront surgery staging, because according to this, she's a 24-year-old young adult, yeah. And according to the adolescent and young adult guidelines, patient should go for if 24 is of course fertility sparing surgery and a peritoneal staging with the peritoneal washings and peritoneal biopsies, and omentum, all the abdominal viscera should be examined and abnormal areas should be sampled. And omentum, if normal, a large biopsy is advised, and lymph nodes, if enlarged or abnormal, we can do the biopsy, and we have to see the pre-operative imaging also. If there is some abnormal lymph nodes, we can remove it. Otherwise, it is not recommended for the...
So we will go to the fertility preserving. However, proper staging is required to plan the exact adjuvant treatment. Dr. Anu,
we can avoid a lymphadenectomy in this germ cell according to the guidelines.
Yes, the imaging did not show any significant disease outside of the ovary. So what would be the considerations given for fertility preservation? Dr. Anu, if you could.
She is 24-year-old nullipara, so we only go for the unilateral salpinge oophorectomy. That means we are taking the tube and the ovary and conserving the other ovary and the uterus for the further fertility. So, and regarding the this one, particularly dysgerminoma, up to 38% upstaging can occur with the lymphadenectomy in literatures. So, lymphadenectomy in dysgerminoma is a very controversial topic because this is as such will not increase the overall survival. We all know that it's very chemosensitive tumors also. So, as Madam said, we have to open the retroperitoneal spaces and see whether the nodes are enlarged or not. If enlarged, we have to take it because in dysgerminoma, the lymph node metastasis is more common. So the other comprehensive staging that includes the peritoneum from the POD and everything that has to be taken, and peritoneal washings also.
Okay. So the stress is on proper staging.
Yes.
At the same time, preserving fertility.
Yes.
And would you advise the patient for a completion surgery once a family is complete?
No, until now it's not recommended because if recurrence occurs, we know that it is very chemosensitive tumor. Usually the patients get the menstrual cycle. More than 84% of women will have this menstrual cycle and reproductive life after 1 or 2 years, even after chemotherapy. So we don't advocate completion surgery in these patients.
Okay. So now the coming to the pathological evaluation. Krishna ma'am, how would you go about to differentiate the different types of germ cell tumors?
Now, the common germ cell tumors, the most common is a teratoma or a immature teratoma. Those things actually will not pose any diagnostic difficulty with the morphology alone because it's very classical picture and you'll be able to give the diagnosis. Dysgerminoma also, the histology is very classical, no need for markers. But certain situations like yolk sac tumor and mixed germ cell tumors, these are the common ovarian tumors which we get, you may have to employ the markers to, especially to decide the component in the lesion. So grossing, I think, it's not very relevant to this audience. I'm not going into the grossing of an ovarian or a salpingio-oophorective specimen, which the surgeon has already done. Of course, the capsule has to be checked, whether there is any rupture or not. The surgeon may have mentioned, may not have mentioned. And it's very important to sample the entire tumor surface. 1 section per centimeter has to be studied because the tumors could be mixed ones. So if you employ markers, dysgerminoma, as in this case, the serum marker which was elevated is only LDH. All the other markers were negative. So it itself points to this tumor, dysgerminoma. So if you consider the IHC markers, dysgerminoma cells will exhibit a strong cytoplasmic membranous positivity for placental alkaline phosphatase, membranous positivity for c-KIT antigen, that is CD117, diffuse nuclear positivity for the transcription factor OCT4, and the new marker SALL4, that's also a transcription factor, whereas the yolk sac tumor will strongly give you the expression of alpha-fetoprotein. Next slide. In embryonal carcinoma, which could be a component hidden usually in combination with yolk sac tumors, the cytokeratins will turn positive, which is a cytokeratin polyclonal cocktail 81 and 83, and a CD30, which is classically positive in embryonal carcinoma with glypican 3 positivity. In immature teratoma, as I said earlier, it does not pose any difficulty in diagnosis with its morphological features. If at all you want to employ the markers which turn positive would be SALL4 and glypican 3. Ovarian germ cell tumors generally do not pose any difficulty for the diagnosis under the microscope with morphological features for an experienced pathologist.
Thank you, ma'am. So finally, we had the diagnosis of a dysgerminoma of the ovary with a surface rent, and the surface is free of tumors. So it was staged as 1C1. And the post-op tumor markers were within normal limits. Now, Dr. John, if you could tell us about the plan for the adjuvant treatment for this patient.
So stage 1C1 dysgerminoma, if you look into the ESMO guidelines, you can see that if it is properly staged, surgically staged, you can keep her on active surveillance. And they have stated this from the evidence of the MITO study, which included around 58 patients of dysgerminoma also, stage 1. And it has shown that the only factor which was statistically significant was the whether patient underwent peritoneal staging or not. So if in this case the peritoneal staging was properly done, so she can be kept under follow-up. And usual clinical scenario is that patient undergoes TH conservative surgery without surgical staging. And in those cases, we manage with single agent carboplatin AUC 7 cycle, which is extrapolated from the testicular tumor evidence. The active surveillance, the ESMO guideline is a bit complicated. They suggest ultrasound, and for the testicular counterpart, it is more useful. They suggest CT scan, which is done 2 times first year, 2 times in the second year, 1 at 36 months and 1 at 5 years. And first 2 years, 3 to 4 month marker examination.
Thank you, Dr. John. So the final MDT decision would be to go for a unilateral salpingo-oophorectomy with proper staging. And in this case, being 1C1 with properly staged, we are planning to keep the patient on active surveillance. Thank you.
If the patient doesn't want active surveillance, we can give her 2 courses of chemotherapy, isn't it?
If she's non-compliant.
If she doesn't want, she cannot be followed up or not.
So that's something which we have to discuss with the patient and decide. Thank you. So that's about case 2. Now moving on to case 3. This is a 65-year-old postmenopausal lady with a history of systemic hypertension and dyslipidemia. Otherwise, she has a good performance status of 1. She was evaluated for 2 months history of postmenopausal bleeding. Clinical examination did not reveal any relevant findings. An ultrasound showed that the endometrium was thick, measured about 10 millimeters. It was followed up by the MRI pelvis in the abdomen, which showed an irregular polypoidal thickening of the endometrium along the anterior wall and with areas of diffusion restriction. And the dynamic study showed that the endometrial myometrial enhancement was fairly preserved, but there was a disruption along the posterior wall, which was extending to the outer myometrium. There was no serosal involvement, no cervical parametrial involvement. There were no radiological evidence of any pelvic or paratic lymphadenopathy. So radiologically, appeared to be like a carcinoma of the endometrium, stage 1B. A biopsy was taken, and it was reported as endometrioid adenocarcinoma, grade 2. So my question is to Chitratara madam, what would the initial treatment be for this patient?
From the scenario, it is seen that it's an organ-confined disease. So we can go with the THBSO and then sentinel lymph node biopsy. So we have to follow the sentinel node algorithm. From all the trials, recently SHREC trial and SENDO trial, all these trials are telling sentinel lymph node has got a high sensitivity and high negative predictive value. It's almost 99 to 100% negative predictive value, and 96 to 98% sensitivity is there for the sentinel lymph node. So we are using a cervical injection and ICG and technetium 99 labeled sulfur colloid also. Both can be used. So usually for it's a standard of care is minimally invasive surgery, but you can go for open also, depend on their doctor's experience or the availability. So this sentinel lymph node, so if it is mapped both sides, it's well and good, you can stop with that. But if it's not mapped on one side, we have to proceed with a site-specific lymph node dissection. So in endometrioid adenocarcinomas 1 and 2, the pelvic lymphadenectomy only is enough. But in high-risk endometrial carcinomas, we have to go for a parietic lymph node dissection also if it is not mapped.
If it is not mapped. Okay. So that would be the initial plan, THBSO and a sentinel lymph node biopsy, because it's a stage 1B.
Organ-confined disease.
Organ-confined disease, and we are planning to go ahead with a minimally invasive technique, which is as good as the open technique, which we used to follow. So patient underwent a BSO and sentinel lymph node biopsy. And now moving on to the post-op pathological evaluation. Krishna madam, if you could tell us about the relevance of histology and molecular-based examination nowadays.
Endometrial carcinoma is one carcinoma. The diagnosis has made a paradigm shift in the management with the integration of molecular classification. As you know, the 2020 WHO molecular classification system, actually it is a morphological and molecular classification system. Substantial genetic and morphological heterogeneity do exist in this malignancy. And classical pathological parameters and molecular have to be integrated in one pathology report, because you have to correlate both these features, that is the morphological and molecular features, to the risk groups for a better multidisciplinary definition of that patient outcome. And the treatment is actually accordingly tailored to the tumor biology which is exhibited in that particular case of endometrial adenocarcinoma. Next slide. Now, the TCGA has defined 4 molecular subgroups based on the somatic copy number alterations and tumor mutational burdens. A novel diagnostic algorithm has been shown promise in refining your adjuvant treatment. Now, there are 4 types. You may all know this, but just to refresh your memory, the first one is the ultra mutated type, which is characterized by 5 variants are there in this one group, which is characterized by pathogenic variants in the exonuclease domain of the DNA polymerase, which you call it Pol type. Hypermutated, which is characterized by microsatellite instability, and the copy number low subgroup with a low mutational burden, and copy number high group with a frequent TP53 mutation. But mind you, retain that slide please, because in each one of this, in the Pol type and the MSI, you can get, there is a sub-variety, but you can get passenger mutations, so that it becomes multiple mutations will be there along with the main one. That means Pol may have a P53 along with it. Same as MSI, cases can have a P53 along with it. So that such type of characterization is important for the tailored therapy and the subsequent assessment of prognosis in the patient. Next slide. I'll just try to be more clear with this. So you assess the Pol status in this patient, and it may be Pol pathogenic or Pol wild type, because surrogate markers, immunohistochemical markers, are now available to assess all these types of molecular variants. So if it is Pol pathogenic, the pathologist has to give the integrated diagnosis, endometrial carcinoma, Pol mutant. And now the Pol mutant also exhibit, studies have shown that certain morphological features in the light microscopy as high number of tumor infiltrating lymphocytes, giant cells, etc. Now people are doing studies on correlating the histomorphological features and the molecular subtypes of the endometrial cancer. So then the MMR status. So if Pol is wild type, you go for MMR, and it may be MMR deficient or MMR proficient. If it is MMR deficient, you can give that as EC-MMRD. And if it is MMR proficient, you have to go for P53 status, which may be wild type or mutant. The wild type is designated as endometrial carcinoma NSMP, that is no specific molecular abnormalities. The other one is endometrial P53 mutant. Now P53 mutant, I am stressing again, it can occur along with your Pol and the MMR. So nowadays I think P53 is uniformly done for all endometrial carcinoma. That's all, I think that's the practice now.
Thank you, ma'am. So the final pathology came out as...
We are doing IHC with the MMR proteins and P53 IHC, and since Pol is also required, sometimes we may not go for IHC, or directly go for sequencing, gene sequencing. Yeah, because Pol is always sequencing. IHC is not there for us.
Pol is...
NSD is the correct method of doing this molecular typing, which is very, very expensive. I don't know how many patients of yours will... NSD not expensive? May not be expensive in Lakeshore patients, but it is definitely expensive.
It is outsourcing. You can also outsource it. Lakeshore, it will be expensive. But with the IHC, it is less than IHC when you compare, this combine with the poll, it is less than the IHC, the sequencing.
IHC, each marker will be costing around only 1,500 to 2,000 rupees. That is why all the companies have come out with surrogate markers. But NSG sequencing, what I have understood is it will be costing more than 10,000 rupees, which is something very high for our routine patients, not Lakeshore patients.
It is not Lakeshore, I'm telling. It is, you can outsource it.
Yes,
we are also outsourcing. It is Lakeshore, it is costly if you go through Lakeshore.
Yes, ma'am. So we understand the financial implications here. So let's assume that the patient has undergone all the investigations. So the final report has come out as endometrioid adenocarcinoma of the endometrium.
In this report, the LVSI is not mentioned because LVSI is a very important factor for, as far as I know, in assessing the prognosis of carcinoma endometrium. But that is not mentioned here. It is simply said carcinoma endometrium 1B grade 2, FIGO stage and P53 mutant. But LVSI, where it's written? Okay.
So finally, the final stage would be 1B, grade 2 with no LVSI, P53 mutant. Now, how would you plan the adjuvant treatment, Dr. John?
So add to all this confusion, FIGO has introduced a new staging system in 2023. And this patient, 1B, grade 2, P53 mutant. And the analysis of the POTAC patients has shown that as per the molecular types which Madam has elaborated, the pole mutated patients have excellent outcome. Whether or not you give the adjuvant treatment, they have the same outcome that is depicted by the blue line. And the P53 mutant ones do the worst. So this patient is reported as P53 mutant. As Madam pointed out earlier, there can be multiple classifiers, so that this patient may have a pole mutation. So you have to rule out polymutation in this patient, which can avoid adjuvant treatment for this patient. If the poly test is result is mutated, you can avoid adjuvant treatment and keep the patient on follow-up. Since poly is not done routinely, we have to decide by the available data. She has a P53 mutant disease, so she requires adjuvant chemotherapy as per the POTAC 3 reports. And there is a paper which helps in deciding the adjuvant radiotherapy based on the molecular typing. And the paper says that for a P53 mutant patient, EBRT works better than brachy. So our patient ideally requires adjuvant 4 cycles of paclitaxel chemotherapy and EBRT.
Would you give chemoradiation or just EBRT radiation?
On a scientific platform, the ideal treatment would be as per the POTAC 3 program. Chemo-RT followed by 4 cycles of paclitaxel carboplatin.
Okay, so the final decision of the MTT would be to give 4 cycles of adjuvant chemo.
From Kerala, there is one study which is reported by Dr. Santosh, because we have to see when pole is mutated, we have to see whether it is pathogenic or non-pathogenic. If pathogenic, of course, we can avoid the treatment. If non-pathogenic, probably we may have to go ahead with all these.
The other mutations that are available, we might have to go ahead.
And when both are mutated, we have to take it as a pole mutated disease. Pole mutated.
Yes, for the multiple classifiers. For the multiple classifiers, we take the pole status over the P53 mutation. Okay, so the final MTJ decision for this patient would be to go for a proper staging initially, followed by an adjuvant treatment protocol comprising of 4 cycles of adjuvant chemotherapy with paclitaxel carboplatin and pelvic EBRT, external beam RT, to a dose of 45 and 25. And brachytherapy would not be a part of this.
She is Paul mutated, so.
She's P53 mutant.
But when both are there, we have to take
Paul
it as a Paul mutated.
But in this case, Paul is not mutated. It's only P53 mutant.
Okay, you are under my.
Okay, so I think the MDT has come to the final decision here. Okay, with that we come to the end of this session. So once again, there's no time for questions now, but you can always post your queries to this number, or you can mail to sckerala@aroy.gmail.com. Thank you so much for listening.
Now,
Thank you all for
before dispersing, let me express my sincere thanks to the organizers of this conference, especially Dr. Aravind and the team, for giving me the opportunity to be here with you to share my, to share my thoughts on gynae pathology.
Thank you, sir, and our eminent panelists for that very fruitful discussion. I would now like to invite Dr. Francis P. James, Professor and Head, Department of Radiation Oncology, RCC Trivandrum, for felicitating our moderator and panelists with a memento.
Thank you, Naveen, and thank you, the organizers.
Appreciation. Thank you, sir. Next in line, we have a session on recent RT advances in GBM, looking beyond the prism, by Dr. Uday Krishna, Senior Consultant Radiation Oncologist, Apollo Proton Cancer Center, Chennai. For chairing the session, I would like to invite our eminent chairpersons, Dr. Pushpaja KU, Clinical Associate Professor, Amrita Institute of Medical Sciences, Cochin, and Dr. Sonaram Tia, Department of Radiation Oncology, Government Medical College, Thrissur. I request all delegates to be seated.
Hello. So next session is recent advances in GBM. The presenter will be Dr. Uday Krishna from Apollo Proton Cancer Center, Chennai. Let's start the session.
Thank you very much to the organizers for having me here. Dr. Arvind, Dr. Francis. Especially I've been bothering Anup and Naveen for the last few days with my silly questions to know if I can give it online. I thank them for bearing me and my questions and bothering them. Basically, I lost my father 2 months ago, and then I have to do these rituals every day, and so I thought it may be difficult for me to travel all the way, but then I somehow managed. I landed in Kochi at 9 a.m. and finally reached Munnar at 2 p.m. with a lot of roadblocks, which was almost like finding a cure for GBM. It was, I think it would have been more easier to find a cure for GBM than reaching Munnar all the way. So let me start off. It's a very foggy, beautiful afternoon outside, and then I'm going to be talking a very boring topic like a glioblastoma after a fantastic panel and a topic which is very close to all of us. gynecology. So let me try and make it more lively and more interactive so that we don't have people dozing off in the crowd. So all of us know GBM is challenging, the biology is difficult, clinical challenges are there. Clinical trial designs have had a lot of significant modification, basically because you have to answer specific questions and not vague answers. The key problems basically are what many experts across the world feel is that there is paucity of control arm in phase 2 trials. If I have to compare two doses in the GBM, we don't have control arms in phase 2, so it is very difficult. So the stringent criteria for trial participation is so much that we are not able to get more number of patients to be recruited and test and assess new molecules or new drugs and things. There is inadequate assessment of the blood-brain penetration and pharmacodynamics of the new drugs. There is inefficient clinical trial infrastructure, and there is limited development and implementation of prognostic and predictive biomarkers. Over all these things, to keep it very simple, the lower panel I put few pictures. This shows the various phases of GBM. It can be a large tumor, but it could still be a IDH mutant. It could be a small tumor sitting in the high up in the brain. It could still be IDH wild type, GBM, methylated MGMT, unmethylated MGMT, and the two new recent more ones, which is epithelioid GBM and then the histone driven. So like while we are trying to cut the twigs of this plant here, what we don't understand is that the soil, what is growing this plant, and then the seed, what is getting planted, is more specific. So we know it's a very sad story, and still we have to deal with this disease. So for the next 5 minutes, let us forget that this is a sad story and let us try to make it more lively. So in 2021, two interesting things happened. One, WHO made life very easy. So there was no discrepancy among pathologists, no breaking head about what grade it is, etc. Straightforward molecular classification, IDH present or not present, if it is mutated, or IDH wild type. Go simple by the classification, call them by these classes. So it sort of made more life, made more easy, or it made more difficult. The other more interesting thing to me in 2021, what happened was, Joji got released. I don't know how many of you have watched this movie. I have watched it multiple times. So I thought this was the first Malayalam movie I have watched it at full length. Although a super hit Kannada movie called Apta Mitra, I was told was a remake of another super hit movie from Malayalam. What I could draw from Joji is that Joji would be a classic example to understand the pathogenesis and aggressiveness of GBM. It also tells us how versatile the disease is, and if you understand the molecular methods very well, it can be a more personalized care for patients. So I have just put the WHO classification and the WHO definition of GBM on the left side. I have put the various scenarios of Joji here. Just to take it on a more lighter note, there is a family with a more benign son, probably an astrocyte or a benign glial cell or a normal glial cell, with progenitors around him, and there are stem cells and neuroglia. This benign cell attains P53 mutation. So once his father, I'm not sure how many of you have not watched this movie, his father gets a stroke, and he starts noticing and understanding that, okay, there is opportunity for me to invade into the system and do something better. He attains significant proliferation. He gets his sister-in-law support. It so becomes angiogenesis support with him. It becomes necrotic in the way that he kills his own father. And then he finally becomes treatment refractory in the way he is opposing his own brother as well. So Fahad Fazil, all of us know, is an absolute versatile actor. So I will simulate his acting to something called versatility of GBM. I am from Bangalore, so I am a great fan of Rajkumar, and all of us are fans of Kamal Hassan. So if you use these versatility and molecular methods very well, the treatment can be a super hit like what happened in Vikram. If you don't, it can be a disaster like what is in Pushpa. So let us go back in time. 1979, 50 years ago nearly, they saw if you have to treat them at all or just leave them alone, more of a palliative intent. So serially increasing dose from 40 to 60 gray showed that there is improvement in survival over time with increasing in the dose. Then few experts sat together and they saw, okay, we can jot down few risk factors and see who will really benefit by giving radiation, who can just call it a day and give palliative care. So they made a RPA classification. The initial classification was more complex, so I put the more recent one from Minesh Mehta and team. So it was based on RTOG 0525, and they made 3 classes. They said class 3, class 4 and class 5, class 3, 4 and 6, which are all of them almost have same median overall survival or progression-free survival. This slide all of us have seen some millions of times. Roger Stoops trial looking at radiotherapy with concurrent temozolomide and adjuvant temozolomide. A fair bit of improvement in overall survival at 2 years and very few numbers at 5 years. So most important factors which were already seen in the RPA classification were again highlighted in this trial. Complete resection is very important. If it is in the more favorable RPA class, it is better. Younger age people do well. If it is methylated, you can see between giving just radiotherapy in a unmethylated arm, which is like 1.8 months, to improvement as much as 48 months when you combine both RT and temozolomide in an MGMT methylated patient. In elderly, the story has been based on what continent the elderly is sitting. Canada gives just short course of 2 weeks and says that's enough. Some people have tried to randomize and see various dose fractionation, etc. Some people have tried to just give temozolomide and call it a day. But however, what we can see is if you just look at the health-related quality of life alone, when you give temozolomide alone versus RT alone, probably a short fractionated RT and temozolomide is probably the best match to give them best quality of life. So what is the big deal about radiosensitivity and response of radiation and temozolomide in GBM? So people have looked at molecular levels and seen that in an MGMT methylated population, if you add temozolomide with radiation, this is more for students and residents who are sitting here. All of us know it's an alkylating agent acting through MTIC. So if it is MGMT methylated, it becomes more better. What they have found that there is decreased repair capacity if in a patient with MGMT methylated and decreased repair capacity to make it more better. There are biphasic apoptotic peaks, one by temozolomide, one by radiation. So both are acting together. There is failure of DNA mismatch repair system, and the long-lived nicks in the DNA are enough to cause more damage, and these damages are in close proximity to each other. So that's why it is more enhanced. And then eventually when you treat these patients, biochemically you can assess that they have got reduced levels of gamma H2AX, so it is a marker of radiosensitivity. Further, TCGA, the Cancer Genome Atlas, tried to see if there are subtypes of GBM, and they called it as 4 types: pro-neural, neural, classical and mesenchymal. They have specific alterations and specific mutations in each group. So they found that classical and the mesenchymal tumors probably fare better compared to neural and pro-neural subtypes. And so they added this onto the existing RPA classification, and they made it more classified, and they saw that if you can assess MGMT in the blood, not just in the tissue, and if you can add that to the age and also a biochemical parameter called C-MET in these, you can classify them as group 1, group 2 and group 3, and each one has got its own class. So the group 1 with MGMT methylated and age less than 50 and then a C-MET positive is known to have the best prognosis. Can you do anything more in these methylated MGMT methylated patients? People have tried to add CCNU, but then the trial was not powered enough to see if CCNU is giving the impact or is it just the improved survival overall. Bevacizumab they have tried. All of us know 2013 2 landmark trials from one from a European group and one from North American group, both were a failure. So beyond conventional RT, temozolomide, etc., what can you do? They have tried sildenafil, which is integrin antagonist, didn't work. They have tried EGFR vaccine, didn't work. They have tried EGFR conjugate, didn't work. So what actually is causing therapy resistance, especially the radiotherapy resistance in glioblastoma, is what most of us want to know. And is there a way to mitigate this and to understand the tumor bed more better so that you can maximize the control, local control, and so that's when the overall survival becomes better. So when they looked at the factors controlling the angiogenesis, there's hypoxia, there is invasion, intrinsic radiator resistance, factors like stem cell radiator resistance, and radiation-induced tumor cell plasticity. So of all the factors what they have looked at, they have seen that FGF2 is the most important, and farnesylated Rho B also, and crosstalk between these two is more sort of at a biochemical level seen that it is causing resistance. So what we could do is probably we have to define the tumor bed and what we are going to treat with radiation properly, probably create a gradient or what we call as painting. You could look at escalating the dose, either the dose completely or dose per fraction, and also adapt to the tumor changing over time in the course of 6 weeks. So if you look at this into two broad headings, they have tried to intensify radiation without chemotherapy. So they have tried to give 2 radiotherapy doses. They have tried to do multiple dose fractionations, hyperfractionation, etc. Everything failed. Of late, what they have tried to do is with chemotherapy intensification, they have tried to use particle therapy. Not a great trial, not much result. But there is an ongoing NRG BN001 trial scheme. I will fondly call this as a Bahubali trial because the Bahubali part 1 was a failure. So they don't know why Kattappa killed Bahubali. The dose intensified IMRT did not improve the outcomes compared to standard doses of radiotherapy. So what exactly is happening is, all of us know the patterns of failure in glioblastoma. The 2 centimeters beyond the bed also has to be covered because that's where the maximum concentration of microscopic disease is lying. As you go beyond, there is no much disease. So all of us use MRI and CT for fusion. Some of us use spectroscopy. Some of us use perfusion. Volume delineation, again, there has been a lot of discrepancy between how the ESTRO and ENO defines it and how ASTRO defines it. But if you come to one common consensus and understand this, all of us know that if you completely remove the detectable tumor, which is called CRDT, not just the enhancing tumor, that should be the ultimate goal to achieve a GTR. So which means, apart from removing the contrast enhanced area, you have to push your neurosurgeons to ask them and try to remove as much as flare abnormality as possible. So what the 2 big trials, RTOG 0525, which looked at dose-dense temozolomide, and then RTOG 0825, which is bevacizumab in addition to radiation and temozolomide, both of them saw that the neurocognitive failure and the patient-reported outcomes were absolutely better if the patients had GTR compared to those who had STR. So Rano came up with a criteria and classified extent of resection as class 1, 2A, 2B, 3A, 3B, based on how much you are able to remove. So anything beyond supramaximal resection is, if you can achieve that, is what you could improve in outcomes. When that is the case, if we just include only the contrast enhancing area in our treatment portal, we may be giving the flare abnormality only a dose of 46 gray. So the entire world is now concentrating and seeing, can you give the entire area which is non-enhancing as well around the disease up to a dose of 60 gray. So probably an integration of novel imaging approaches to add multiple various functional imagings will help in understanding understanding the area better and then get better treatments. So on that perspective, a lot of translational research has been done to see if you can intentionally create an MGMT silencing. Can you do anything at the radiotherapy level in handling the genes like polymorphisms in the BT, B2, etc., or can you create specific inhibitors of CHK1 and CHK2 checkpoints, which actually is known to be propagating CD133 related stem cell radio resistance, and that's why if you could do checkpoint inhibition at that level, probably you could improve survival. But all these are at molecular levels. You can see that the blue graph is there, which is actually a preclinical level. All of us know this famous study from 2000, before the millennium, where the BTV was actually defined, the biological target volume. So along with physical conformity, what we also have to do is a biological conformity and thereby create an evidence-based multidimensional conformal therapy. So most of the centers across the world have used basically MRI, although PET also has been there. So one such study from a group in US, they looked at if you could improve the DICE defined MR perfusion into the, if you could include the DICE MR perfusion defined volume into the MR planning, their survival was slightly better. And this over time, if you saw that the area which had higher DICE MR perfused area, and if you gave full radiation to that area, that reduced over time and it improved survival. So PET, all of us know that multiple people, historically people have tried to incorporate FDG, but FDG is not specific in brain because of the background activity. People have tried to use MET PET-CT, people have tried to use FET PET-CT, FDOPA PET-CT with various combinations and modalities. So among the dose escalation studies, two important studies, one was from Paris, which tried to use spectroscopy in a three-dimensional manner and try to see in a study called SpectroGlio. I think they are awaiting the final results now, which they went up to 72 gray, which was spectroscopy guided. And the part 2, the Bahubali part 2 is awaited, which is proton therapy comparing proton therapy related dose escalation compared to standard dose given by photons, because the part 1 is already failure. So we are eagerly awaiting if proton therapy can make it better. Amidst all these things, there are two new variants inculcated in WHO 2021 classification. One is in adults, one is in peds. So the adult part, all of us thought if somebody is living with GBM for 6-7 years, there could be a fantastic case report, but apparently most of these had something called as BRAF V600E positive in them, which actually is called a epithelioid glioblastoma, which is apparently the mesenchymal transition from a PXA. In these patients, after you give radiation and radiation alone, not temozolomide, based on an NEJM paper on children with progressive low-grade gliomas, and also a phase 2 trial looking at these tumors in people who have failed in high-grade gliomas, if you could add dabrafenib and trametinib in these patients, basically because it's a MAP kinase inhibition, you could improve the survival and create longer PFS. However, BRAF is an important marker, so you have to have both fusion and mutation. The imaging characteristics of these patients is very good, but the problem is how long do you have to give and how do you match the toxicity, and of course financial burden in our country is very important.
control of the disease with the systemic therapy. See, after the surgery and after the radical radiation treatment, there may be residual disease, but patients who are on temozolomide, there are situations where even after 12 courses of temozolomide, the disease is stable. As per medical oncology thoughts, it is not right to continue with temozolomide. But when temozolomide is doing good, is there any point in changing over to PCV or other agents? That is always a dilemma. But there are patients with me who are surviving for 5 years or more even. There.
So we probably feel they are all IDH mutant tumors, and that's why probably they are responding to temozolomide also, because most of these patients will have MGM demethylation. In our center, like you said, we go on under the guidance of Dr. Jalali. We usually tend to continue, but then in younger patients, it is known that this phenomena can cause hypermutation in other part of the brain and create new second primary problems in the other part of the brain. So unless until we are really justified, we don't continue beyond 12 seconds.
When the patient is having a stable disease, we know that such an aggressive tumor. My medicine professor taught me that that time, there was no CT scan available. Carotidangiogram was shown that there is a tumor blood. So this is a ECP also. He told me that this is aggressive tumor problem. So the answer is to give to subject the patient for surgery by lunchtime and to give radiation in the evening. That is what he did as a professor of medicine in 1976. So I still think that we are not right in leaving those patients without any treatment when it is stable with some systemic treatment.
That's right.
Thank you, sir. As we are running short of time, we won't be taking in more questions at the moment. So I would like to invite Dr. Aparna MP, Assistant Professor, Department of Radiation Oncology, RCC Trivandrum, and Dr. Judith Aaron, Consultant Radiation Oncologist, Caritas Hospital, Kottayam, for felicitating our speaker with a memento as a token of appreciation. Thank you, ma'am. I would now like to invite Dr. Prema K.R., Professor and Head, Department of Radiation Oncology, GMC Thrissur, to felicitate our chairpersons with a memento as a token of appreciation. Thank you, ma'am. There's an announcement. Delegates kindly note that the attendance sheet for the day 1 and 2 of the program is being circulated in the main hall. I request all delegates to mark their attendance in the same. Next in line, we have a session on cervical cancer and parenthood, navigating fertility and pregnancy by Dr. Amarna MP, Assistant Professor, Radiation Oncology, RCC Trivandrum. Our second speaker, Dr. Snigdha, could not join in due to health issues. I invite Dr. Aparna onto the dais. To chair the session, I invite Dr. Ajay Kumar, Professor and Head, Department of Radiation Oncology, GMC Calicut, and Dr. Jacob John, Consultant Radiation Oncologist, Muthoot Cancer Center, Korancheri, onto the dais.
Aparna. Please start the talk.
Good afternoon, everyone. So my topic of presentation today is navigating fertility and pregnancy in cervical cancer. So if you see the likelihood of pregnancy rate among cancer surveyors, you can see that the cervical cancer has got the least probability because of the obvious reasons that the disease itself and its treatment can impact reproductive capacity of an individual. Radiation therapy causes primary ovarian insufficiency, and also it causes damage to the uterus as well. So 30% of patients newly diagnosed with cervical cancer are under the age of 45 according to the Western data. But if you are seeing our pattern, actually we have the incidence rate of cervical cancer in reproductive age group is very less in India, in our population. According to the hospital-based cancer registry, we roughly see 400 patients a year, and we used to get around less than 20 patients in the sea. So discussing the fertility preservation options in the early stage cervical cancer, the treatment options are fertility preserving surgery. So I'll be elaborating more on coming slides. And the rare option is a uterine transplantation in a post-hysterectomy patient. So in literature, there is a cervical cancer patient survivor who has undergone a uterus transplantation leading to 2 live births. But it's a very complicated procedure, needs immunosuppressive therapy and assisted reproductive technology. So if you're planning for a fertility preservation in an early stage cervical cancer, a thorough examination is a mandatory, preferably under anesthesia, and you need a biopsy proof. MRI pelvis is mandatory, and you should always rule out any metastatic disease prior to offering a fertility preserving surgery. So in the early stages, cervical colonization is method of choice for staging in early cervical cancer and could be associated with lymph node staging. If you are planning for a colonization, loop or laser colonization is preferable compared to cord life colonization in a fertility preserving surgery. And counseling in these patients is of paramount importance because you should discuss the oncological and obstetric risk associated with this procedure. And patient should be also aware of the fact that fertility sparing abandonment if there are positive resection margins or lymph node involvement. So you can see the MRI. You see the lesion, the size of the lesion on the MRI, because more than 2 centimeters is a contraindication. Deep stromal invasion is a contraindication. And ideally, from the superior border of the tumor, you need a 1 centimeter margin. From the superior border of the tumor to the internal os, you need at least 1 centimeter margin to allow for a healthy anastomosis. So the fertility sparing surgery, this is in a nutshell. The criteria is patient should be of age less than 45 years and tumor size should be less than 2 centimeter. It should be of squamous cell carcinoma or HPV associated adenocarcinoma, and pathological surgical assessment of the lymph node is mandatory in a fertility sparing surgery. So the diagnosis of 1A1 and 1A2 is based on colonization specimen. If you are doing a colonization, the unfragmented specimen should be examined by an expert pathologist and should come in on the depth of invasion, margin status, coexisting pathology, and a reliable assessment of the LVSI. If there is an LVSI, that is a marker for lymphatic spread, and patient need to undergo a pelvic lymph node assessment, dissection, or central lymph node biopsy using endocyanin green. In a patient with a tumor size more than 2 centimeter, neoadjuvant chemotherapy and followed by fertility preserving surgery has been described, but it is not the standard of care at present because the optimal number of chemotherapy cycles, chemotherapy regimen, as well as the extent of cervical resection following neoadjuvant chemotherapy is still a matter of debate. So 1A1 and 1A2, the recommended surgery is colonization, 1B1 without LVSI, simple trachelectomy, and 1B1 with LVSI, radical trachelectomy is advised where they remove the strip of cervix, vaginal margins, and supporting ligaments, while leaving the main body and fundus of the uterus intact. So these are the conditions where you should avoid or go fertility surgery. Any histologies other than squamous cell carcinoma or HPV-associated adenocarcinoma, and pelvic lymph nodal involvement is an absolute contraindication. Any patients with extracervical tumor extension should not be considered. And technically, since at the time of surgery you're finding that there is a less than 5 mm from the internal cervical os, or during the intraoperative frozen section, it is coming that superior border margin receives positive margin. In that case, you should abandon the fertility preservation surgery. And other things like histologically confirmed endocervical margin, endocervical curettage that they usually do above the resection, or endometrial involvement of final pathology. In those situations, fertility preservation surgery should be abandoned and proceeded with chemotherapy. So post-procedure, a permanent encerclage is done, and they usually suture the vagina to close the cervical os to prevent frequent infection. Delivery can only be performed by cesarean section. So any pregnancy following fertility preserving therapy should be considered as a high-risk pregnancy and should be managed combinedly by an oncologist, gynecologist, obstetrician, and neonatologist together. This is a systematic review which shows the reproductive and oncological outcomes after fertility preserving surgery. If you go through the last row, you can see that this study includes more than 3,000 patients, and the mean live birth rate was around 67%, and 20% among them received an artificial assisted reproductive technology. And coming to the oncological outcome, the mean cancer death rate was only 0.6%, which shows the oncological safety of the procedure. So the recommendation strictly tells about the size, tumor less than 2 centimeter cutoff. These are according to the EEE guidelines, SJS-ISB guidelines. They are not mentioning about the 1B2. That is a tumor size more than 2 centimeter up to 4 centimeter. While the SJO and European Society of Human Reproduction and Embryology guidelines, they recommends that fertility sparing treatment can be considered in selected patients with more than 2 centimeter. If you look at the trials using neoadjuvant chemotherapy in fertility preservation, varying regimens including cisplatin, paclitaxel, and ifosfamide has been tried, and only limited number of patients. And there is, at present, this is not the standard recommendation. This is a systematic review showing comparison between abdominal radical trachelectomy versus chemotherapy followed by vaginal radical trachelectomy. Even though the obstetric outcomes are better following neoadjuvant chemotherapy followed by vaginal trachelectomy, there is a recurrent rate of around 10 to 13%, and it means that it is oncologically not acceptable. Moving to the locally advanced carcinoma cervix, was treated with radical chemoradiation. There's no live pregnancy has been reported after chemotherapy because of the effects on ovary and uterus. Ovary, you know that LD50 is 2 gray only. If you see this diagram, that ovarian reserve in a woman's life cycle is maximum around 22 weeks post-conception period. That is around 3 lakhs. And that drastically drops to around 16,000 at the age of 35 years. And also there is a wide gap that is ranging from 1,900 to 11,000. So some patients will have a low reserve, and your 2 gray of radiation can knock out 50% of the oocytes. So ovaries no longer divide after fetal stage. The mature follicles and the process in the maturation are damaged equally, and compared to males, since hormonal secretion is associated with follicular maturation, sterilization and menopausal symptoms occur concurrently in females. Come to the effect of RT on uterus. Radiotherapy has got a detrimental effect on elasticity of the uterus. It can cause significant effect on the myometrium and fibrosis, resulting in the smaller uterine volume, reduced endometrial thickness, and most of the damage is happening in the uterine artery that makes it resistant to hormone replacement therapy. That will result in lower clinical pregnancy rates, higher prevalence of complications. So no pregnancies after ovarian tissue grafting in females exposed to radiation despite ovarian graft success. So if any patient coming to you in a reproductive age, you should refer the patient to a fertility clinic, and you have to communicate to the fertility preservation clinic that the age of the patient, stage of the patient, whether it is a curable malignancy, type of the treatment you are going to offer, and apart from other factors like ovarian reserve markers. So come to the advanced stage treatment, whereas treatment modality is radical chemoradiation, not much options left behind. One thing you can consider is the cryopreserved oocytes and embryo can be retrieved prior to chemoradiation and can be used to achieve genetic motherhood via surrogacy. Another option is to use donor oocytes, surrogacy using donor oocytes. Ovarian tissue cryopreservation and ovarian transposition are just to support the endocrine function. That is not going to serve in the fertility preservation. So you should know that oocyte cryopreservation is available in the reproductive medicine department, SAT Trivandrum. Ovarian tissue cryopreservation is available in AIMS New Delhi. And we do have a Surrogacy Act in India. So which recent amendment in 2024 shows that if a couple suffers from a medical condition that necessitates the use of donor gamete, the use of donor gamete is allowed. That means surrogacy must have at least one gamete from the intending couple. The assessment of ovarian reserve is usually done by measuring the anti-Mullerian hormone assay and an ultrasound andro follicle count. That fertility preserving physician use this assay to use to select the gonadotropin dose in the case of ovarian stimulation. So we need to retrieve and preserve the eggs before chemotherapy and radiotherapy. Timing is crucial as it delays cancer treatment. If it is urgent, modified protocols for ovarian stimulations can be used. It's coming to the ovarian transposition. In the ovary, along with its pedicles, will be moved out of the radiotherapy field. Usually they will keep in the paracolic gutter or a lower part of kidney. But technically speaking, it is a very difficult achieve to keep the ovary outside the pelvic field and to achieve a dose of less than 3 to 5 gray. Its ovarian transposition is offered to preserve endocrine ovarian function, and you should understand that over the age of 30 years, and if you are using concurrent chemotherapy, the preservation, it can experience more ovarian failure. So there is a data on systematic review of 1,300 patients of ovarian transposition in cervical cancer. They reported that ovarian metastasis is very low, to the tune of only 0.4% only. Another thing is combining options, that one ovary you reserve for cryopreservation and transposition of other ovary may be discussed. And you can use laparoscopy for surgical retrieval of the ovarian tissue prior to ovarian stimulation. In all these fertility preservation options, the support system is very important because we need to manage not only the financial toxicity, emotional distress, and other social problems as well. So coming to the conclusion of fertility preservation, cancer patients of reproductive age undergoing curative treatment should be offered ongoing fertility counseling and should be referred to a fertility clinic. The thorough communication is of paramount importance, and a general wisdom that you need to wait at least 2 years to get through the early risk of recurrence period. So next 10 slides, I'll go through the management of carcinoma cervix in pregnancy. I'll try to finish it soon. So the definition is that pregnancy is defined as a tumor diagnosed in a pregnant woman up to 1 year postpartum. It's a very rare situation, and every patient diagnosed with cervical cancer in pregnancy must be counseled by a multidisciplinary team. The management is depending on the patient's intention, tumor stage, and gestational age of pregnancy at the time of cancer diagnosis. You should understand that the primary aim is oncology safety of the pregnant woman, followed by fetal survival without additional morbidity. So pathological confirmation is a must, and con biopsy is only appropriate during the first trimester of pregnancy, unlike other cervical cancer patients. Endocervical curettage is contraindicated in this situation. And pelvic MRI is the investigation of choice for local staging. It can be challenging due to the fetal movement and cervical artifacts, but ultra-fast MRI sequence can minimize these artifacts. gadolinium-based chondrite is contraindicated in pregnancy. And for metastatic workup, again, whole body diffusion weighted MRI is recommended. So you have to rule out any suspicious lymph nodes. You have to rule out that it is tumor-free. That's the most important thing in a patient with pregnant woman with cervical cancer. And minimally invasive approach should be considered before 14 to 16 minutes of gestation. And sentinel lymph node biopsy using indocyanine green is still experimental in a pregnant patient. So this chart is taken from Triple guidelines. It explains cervical cancer in pregnancy. First of all, you have to check whether the patient's desire to continue pregnancy. If there is answer is no, pregnancy termination is advised, and I have to manage based on the stage. If patient wishes to preserve pregnancy, you have to check whether any conservative surgery is possible. If you can get along with colonization on trachelectomy, proceed with colonization, encirclage, and lymph node staging. If it is not amenable for conservative surgery, then you check whether what is the status of the fetal maturity. If the fetal maturity is approaching, you can wait for some time, delay the oncological treatment until fetal maturity, that is usually 34 weeks of pregnancy. If there is a delay, and you can consider chemotherapy until term of pregnancy, that is up to 37 weeks. In case of considering neoadjuvant chemotherapy, at least you need a 2 weeks interval between the chemotherapy and surgery. So in patients with locally advanced disease or residual tumor after surgical procedure that cannot be completely removed, chemotherapy based on cisplatin and carboplatin are usually considered, and it should be started only after 14 weeks of pregnancy. Combination of taxane is an option, and bevacizumab and checkpoint inhibitors are contraindicated in pregnancy. When we are administering chemotherapy, before each cycle, you have to assess the treatment response using either clinical examination or transvaginal examination. And if no response is achieved after 2 cycles of chemotherapy, you have to seriously think about termination of pregnancy and proceed with the further treatment. So the natural delivery has been associated with a detrimental outcome. There has been episiotomy site recurrence and vaginal recurrence has been reported. So the cesarean section is the recommended mode of delivery. And at the time of cesarean section, definitive cancer treatment can be conducted. I'll skip up the slides at the time. So the conclusion, the prognosis of cervical cancer during pregnancy is similar to other non-pregnant women, and international guidelines and high quality evidence will be crucial in optimizing the care of pregnant women with cervical cancer. This is for the benefit of PGs I have added. Every year, 17th November, WHO, we celebrate cervical cancer elimination and day of action. And you should be aware of the target 90, 70, 90. That means 90% of the women before the age of 15 should be screened for HPV, and 70% of the screened women of age 45 should be screened for cervical cancer, and at least 90% of the women should be offered cervical cancer treatment. This is to achieve a goal of less than 4 cervical cancer patients, 1 lakh population. Thank you.
Thank you, ma'am. Now the session is open for questions, if any.
Are there any questions? Thank you, Dr. Aparna.
It is very excellent talk, Dr. Aparna, because we oncologists, we never think about such a situation, because this is carcinoma cervix. But now with the age of marriage getting advanced, we have to discuss with the patients regarding this thing. And I think Madhu sir may be remembering we have treated some patients with pregnancy who have become pregnant 6 to 8 weeks, who had come to us with 6 to 8 weeks pregnancy. And because it's very simple that day, because they will be multi-para, most of the patients are multi-para, and their age was past 30, and none of them wanted to continue pregnancy. So what we do is that, and it was also advanced, not an early stage. Say we used to continue, we start radiation and continue it, and they automatically get terminated. And we have never come across any. So it's very scary when you think that period is not now, it's recent, 20 to 30 years back. I think Dr. Madhu would be having the same experience.
was thinking of any role for iodine 125 in a very superficial early carcinoma of the cervix.
I'm not aware of that, sir.
Yeah. But that is an isotope which can be used without producing much radiation to ovaries, to the cervix alone.
Thank you, sir. I would now like to invite Dr. V.U. Tangamma, Professor and Head, Department of Radiation Oncology, Pushpagiri Medical College and Hospital, Tiruvalla, for felicitating our speaker and our chairpersons with a memento as a token of appreciation. Thank you, ma'am. Next in line, we have a panel discussion on the evolving treatments and its clinical impact on first-line DLBCL treatment in India, moderated by Dr. Mintu Matthew Abraham, Consultant Oncologist, Kakinose Cancer Center. I invite our panelists, Dr. Malu Rafi, Associate Professor, Department of Radiation Oncology, RCC Trivandrum, Dr. Sanudev Sudanandan, Assistant Professor, Department of Medical Oncology, GMC Calicut, Dr. Samir Salahuddin, Consultant, Department of Medical and Radiation Oncology, Travancore Medicity, Kollam, and Dr. Jofi Vergus, Consultant Pathologist, DDRC Ageless Diagnostics, onto the dais. I invite Dr. Mintu onto the dais to moderate the session.
Good afternoon, everyone, and welcome to the panel discussion on evolving treatments and their clinical implications for diffuse large B-cell lymphoma patients in India. So, these are the panelists. So, if everyone is settled, we can start with the discussion. I just have one case and a scenario for discussion. So the case is not a common one, but the discussion will be going to the basics of DLBCL treatment and its newer modalities of treatment and what can be done in the future in practice. So diffuse large B-cell lymphoma was previously considered as a single entity, but now this is the NCCN recommendation for diffuse large B-cell lymphoma subclassification. So there are like 10 or 12 subclassifications of diffuse large B-cell lymphoma. Treatment-wise, there is a few differences which we will discuss towards the end of the presentation. But this is mostly for the pathologist to interpret and understand what is happening with the DLBCL subtypes, and prognostication is the most important part in this subclassification. So earlier, treatment was easy. If it is diagnosed as DLBCL, CD20 positive, then R-CHOP into 4. Reassess with the PET if available, and if PET shows good response, complete 6 cycles, else do a repeat biopsy and go for salvage chemotherapy and transplant. So this was a straight line management of DLBCL, but now is it really that simple? That we have to discuss. So this is the case. This is a 67-year-old male, known case of coronary artery disease with history of recent myocardial infarction, hypertension, diabetes on treatment, presented with tenesmus, constipation of 6 months duration. Initially, he underwent a sigmoidoscopy which showed only friable mucosa, and the biopsy was negative. And then the person had persistent lower GI symptoms, and we did a PR. The PR showed a proliferative growth extending from the anal verge to 6 centimeter. So naturally, we would assume that it is a CA rectum, anal canal, something like that. Detailed examination of the rectal examination was not feasible because of the patient was having severe pain. So we did a biopsy and it was sent for HPR. So Dr. Jofi saw the pathology and maybe she can interpret the, this is further.
This is like a poorly differentiated. We can't call it whether it is carcinoma, lymphoma, sarcoma, whatever it is. But being in the rectum, first diagnosis came to me must be a poorly differentiated carcinoma. There is one thing striking is there is lot of crush artifact. You can't separately the cells are not visible. So characteristic cytomorphology is not evident in the slide.
So this is H.
Okay, this is actually
the order is.
The clinician is always stringent on the biopsy material that you provide, and we expect larger acres of tumor to interpret. But in this case, Dr. Mintu was very stringent. It was 2 small bits, and what I could see, the first panel we try is CD45 cytokeratin P63. So I think it's in the next slide. So this is CD45 positive, and back. Okay. And, okay. Previous. CD45 positive. The next thing I tried was CD3 and 20. CD20 was diffusely positive. CD45 was positive. So it's a lymphoma. CD20 positive. This is a repeat biopsy. Next slide. Next slide. So this is Ka67. We can't clearly say that what is the count of Ka67 proliferation index. If you ask me, I won't be very sure because it's lot of squashed. We can't clearly count the cells, but still it is high. And CD23. So when you see Ka67 high, you can expect it can be a germinal center in a reactive follicle. But CD23 is negative. So it is not a follicle, not a germinal center. So it must be a large cell lymphoma. We can't call it large because the size of the cell can't be clearly delineated. So then we go for CD10 and BCL6. The first biopsy that you provided was totally insufficient to categorize whether it is CD10 positive, BCL6 positive, or what. Everything was like a vague, weak positivity. So I asked for a repeat sample, though Dr. Mintu was not very happy with that. But CD10, afterwards, the second biopsy came positive. So this is like CD10 positive. Next slide. BCL6 negative. I think it's done. So I called it after the second biopsy only, I could categorize and say that it can be a germinal center B cell like subtype. The next possibility that we can consider is a large cell transformation of a mold lymphoma. But I couldn't find, we can't say whether there is any lymphoepithelial lesion in this, and there is no clear-cut evidence to call it a mold lymphoma, the biopsies being too small. So we can call it as a diffuse large B-cell lymphoma, germinal center B-cell type, CD10 positive.
So basically a rectal biopsy came positive as DLBCL. So Dr. Samir, what would you do next? What imaging?
Hello. You should go for a PET CT. After proper clinical examination, you should go for an FDG PET CT.
Okay. Do you need a local imaging? Usually in a CA rectum or anal canal, we prefer MRI of the pelvis. So in a DLBCL histology, do you need a local imaging for any purpose? Do you think?
Routinely, we do not need.
Yeah. So we went ahead with the PET CT. So PET CT, we would expect normally that it is a generalized lymphoma with a rectal deposit. So we were surprised to find that there was only uptake in the rectal region, rectum with a few tiny pararectal nodes. And this was the total uptake, that's a bladder uptake. Only the rectum and pararectal nodes were positive. So this is again confusing, DLBCL isolated to the rectum. Dr. Sanudev, would you, this repeat biopsy was done anyways because Dr. Joffe was finding it difficult to interpret on the small specimen. So site of biopsy, which would you prefer? From the rectum itself, or would you prefer that small node to be taken out, small pararectal nodes?
Taking out a pararectal node will be very, very difficult. I think
maybe you try repeat biopsy if you are unable to get it. If you have any accessible intact node, then that will be the choice. If it is not possible, go for an incision biopsy for a bigger node which you cannot excise completely. Once you have an entire node, you will get the exact nodal morphology, infiltration of the pattern of infiltration of lymphocytes, a lot of information. But there are situations like this where you may need to go for a true cut biopsy or a bigger true cut biopsy, or you will get enough chunk of tissue for doing all the tests.
So, for the sake of the PGs and residents here, what are the difficulties a pathologist faces when they get a biopsy sample versus an intact node? Which all lymphomas are difficult to interpret from a biopsy sample, true cut biopsy?
In this case, if I receive a true cut biopsy, I'll be okay with that, because now we have already proven a higher grade lymphoma in one site, and now you are looking for whether there is a nodal involvement. In this case, it's okay if you give a true cut biopsy, if there is lymphoma in that. But otherwise, if you get a true cut and you see CD23 retained, and I call it a follicular grade 3A, if there are centrocytes, 3B, no centrocytes. In that case, it may be like ruining the diagnosis, but because it can be only a patchy presence of follicular dendritic cell measure. Rest of the area, it may not be there. So, seeing a focal, one core showing the intact FDC measure may be misguiding. So, better to give an intact entire lymph node for examination. In this case, it's okay.
So anyways, generally it's always better to get an intact node. True cut biopsy is feasible only in some cases, abdominal nodes only. Then it is difficult. So here comes the importance of clinical examination of the patient. Before going to the PET, if you are doing a biopsy, clinical examination might reveal nodes which may be easily biopsied, and you get an intact node biopsy. Okay, so repeat biopsy as...
PET direct biopsy, that should be discussed, because PET used to be difficult. People used to go to Bombay to get a PET done years back, maybe 10 years back, they had to travel to Bombay. Now we have PET CTs coming up everywhere, and probably in the near future, most of the super specialty hospitals will have PET CT in their centers. So if in doubt of a malignancy, ideally, not this scenario, if it's a malignancy we are doubting, PET should be advised first.
So the advantage of PET-directed biopsy is that we take a biopsy from the highest SUV site. That is the area where we get the highest chance of highest grade of lymphomas. These lymphomas might be mixed, follicular low grade and high grade mixed. So if we take a biopsy from the area of highest SUV uptake, that would be giving the highest grade of lymphoma, and then that is the lymphoma which is to be treated with most intensity. So when there is a mixed low and high grade, we always treat it with the higher grade lymphomas histology.
And one more thing regarding the primary bowel lymphomas. So these are all primary bowel lymphoma. So they used to tend to be very high grade and may present in the pediatric age group. They may present to a surgeon with an obstruction or maybe bleeding, and they may undergo surgery. And their staging is based upon the resection specimen status, LDH, and the remaining disease in the PET. There are criteria like NHL, BFM for criteria and staging risk groups, R1, R2, R3, and R4. That's for the pediatric age group. But adult, we may sometimes follow those protocols, or we may simply follow the standard regimen. Sometimes we may get a whole chunk of tissue when they resect a small bowel specimen. So that time we'll be able to ensure the exact pathological thing. Rest of the things like, so for this case, we won't go and do a resection and anastomosis for this particular patient. So we hardly get a bigger tissue for doing the entire IHC. So we may need to resort to a smaller tissue biopsy sample.
So, just consider as GCP subtype. The pathologist, what does a GCP subtype imply, and which diagnostic algorithm do you use?
GCB is like CD10 germinal center markers, like CD10 and BCL6 will be positive. If MUM1 is positive, post-germinal center. So it is, we'll call it as activated B cell-like subtype. So GCB, I believe it has got a better prognosis compared to ABC type. And GCB has a higher possibility for a double hit mutation than ABC, while ABCs can be double expressors like BCL6, BCL2, and CMYC can be positive.
So algorithm you commonly use is?
What we follow is like BCL2, CD10 and MUM1. So if CD10 is positive, we can call it germinal center B cell-like subtype. And if it is BCL6 positive, after that we can again call it GCB. And if MUM1 is positive, we have to call it activated B cell-like subtype, post-germinal center-like.
So these are the basic algorithms used. Common ones are the Hans and the Tallies algorithms. Other ones are the Muris and choice algorithms. They may also be used. This is basically a set of IHCs on which they interpret if it is GCB versus ABC type subtype. So about the treatment of Dr. Sanidev, how do you counsel? Do you really counsel between the prognosis of ABC versus GCB to the patient?
This is for this particular patient or?
No, generally in ABC versus GCB, do you?
Yeah, I do discuss along with stage IPA score, CNS IPA and the cell of origin concept. ABC and GCB, I used to say that ABC, the prognosis is worse when we combine. No, see, we will not say ABC, but we'll say GCB versus non-GCB in our IHC panel. So if it is non-GCB, I would say that your prognosis will be slightly lesser, and we have new agents which we can add, which may do better results in this thing. So
do you
we can
routinely
use
practice escalation of treatment for all patients with the, because the guidelines are not very clear, that's why.
Not escalation, I may add some agents, but when the data like R square CHOP or R Ibru CHOP and bortezomib plus R CHOP, those, the data is not that strong, so that they may benefit certain subtypes, but to push for that, we need more data. And escalation beyond R CHOP, apart from R Pola CHP, we don't have that much results. And many of the guidelines don't mention those agents till date.
Dr. Samir, your opinion?
The standard practice, as your initial slide was, is R CHOP. That has not changed. Maybe there is a PFS benefit for Pola in high-risk advanced disease. With regard to your question regarding discussing ABC versus the GCB type to the patient, it depends on the knowledge capacity of the patient as well as
do you
the
offer
relatives.
an additional agent like lenalidomide in a fit patient? Would you offer after counseling?
Ideally, that should be offered. I think that should be offered because most of the ABC type, they will recur. More than 50% of the ABC type will recur. So that has to be informed. In this era when patients have all the facility to look into their mobiles and get all these things, and they're getting back to us after second and third opinion, before that we give all this for a knowledgeable patient. With a doctor family, for example, doctor family or a IT professional who goes and looks into everything, we know when we assess the patient as well as the relatives, we know what to tell. So not to confuse with other patients because they will get confused. The normal scenario patients, we won't be telling all those bad prognosis things at first, but we will have in our mind that this is going to fail and we'll have to have a close follow-up. And all these options of ibrutinib, even acalabrutinib are there, phase 2 trials are there.
Yeah, so these are agents which are already available, but we are not using it because the data is not very strong. So lenalidomide, bortezomib, similarly available agents, cheap agents, but we cannot use it because the data and the toxicity profile is not very. That's my.
For the PGs, why is this so? Maybe 4 or 5 years later, we will be discussing on tissue agnostic treatment for lymphoma. So the basic difference is that the GCB type versus the ABC type. There, the pathway is different. It's more of notch pathway, NFK beta pathway, whereas which has a more aggressive course of disease, whereas the other are the routine JAK2 mTOR pathways with respect to GCB, right?
Those agents were tested in an era where our molecular classification has not evolved. So now there was a publication from 2016. By back 2016, they have targeted sequencing, identified selected subgroups, and some NOS. Basically for DLBCL NOS, they have combined everything: PMBL, DLBCL, primary CNS lymphoma. So they could get a classification C1 to C5. That is the latest classification. Somewhere the driver is MYD88 and ABC type and poor prognosis, and the other subset you will get notch pathway alterations. At least when those things comes into the practice, depending upon the molecular pathway, when we add lenalidomide or bortezomib, those patients may get benefit. Not the entire subset you are treating 100 DLBCL. 100 DLBCL, all of them are not the same. So we may not be selecting patients wisely. That's why we may be getting these negative results.
So this is the stratification. IPA scoring is used, and I'll not go into the details because of lack of time. And CNS IPA is also used to stratify patients if they require CNS prophylaxis or not in DLBCL. And as I said, this is NCCN guideline. They also say that CNS prophylaxis role remains controversial, but can be considered in patients with high risk factors. And the systemic high dose methotrexate is the recommended regimen, but it is very difficult to give in between the CHOP schedules. And ITMTX can be used, but it has not the data as much as high dose methotrexate. So usually what we do is give our cycles of high dose methotrexate afterwards. That was a practice in RCC. I think that is commonly used everywhere in high risk CNS risk patients. Okay. So this is the genetic alterations that he was talking about. There is a lot of genetic mutations under study used for stratification, targeted therapies, but these are all usually in the phase 1, phase 2 studies only. So coming back to the patient, as I said, he had a cardiac comorbidities, and the ejection fraction was 45% only. And the cardiologist said to us, it is less than 50%. It is very high risk for cardiac toxicity with anthracyclines. So what now? In options for patients not fit for anthracyclines, is RCVP really enough? Dr. Samir, do you think that in this very isolated rectal only lesion, would I be justified in giving RCVP alone for this patient?
67-year-old, reasonably young. I would not prefer to give RCVP. Maybe to start with RCVP, but give other options as well with respect to polatuzumab.
Yes. So, no discussion on DLBCL at the current era is complete without discussing the polatuzumab vedotin, which is a CD79B monoclonal antibody with antibody drug conjugate. So it was the efficacy was proven in the Polaric study, which it is the only new agent after R-CHOP which has been added, which has shown significant benefit rather than as PFS and OS benefit was shown with the polatuzumab vedotin. And the PFS and OS benefit are also maintained at 5 years. There was a recent update to the study, and the PFS OS benefits are still maintained. So it's not a transient benefit. There is definitely a benefit with adding this drug. It is added instead of vincristine, not instead of adriamycin. So cannot be replaced adriamycin, but it's an option to replace vincristine, and there is survival advantage. And favorable results. 5-year follow-up also shows favorable result, as said. And what we had discussed, the cell of origin subgroup, that is ABC versus GCB. Remember that the ABC subtype has a poor prognosis, and the polatuzumab, the first graph shows a wider separation, which means that using polatuzumab in a high-risk ABC subtype gives definite survival advantage. So there is definitely a controversy. There are many regimens tried, but Other than R-CHOP, only DIAPOC has shown some advantage in specific subtypes. Then comes the era of polar R-CHOP, which is showing advantage, but it is the price, the cost deters the treatment. So this is the DLBCL current guidelines according to NCCN. What are the first line options? First line options in a fit young patient, it is R-CHOP versus polar R-CHOP, which you can choose either way. Both are category 1. Stage 3 to 4, we can use dose adjusted epoch regimen also. It's not as easy to give as R-CHOP. To the people who have not seen it being given, it's a 5-day continuous infusion usually, and it's usually with toxic, and you need kind of a guts to escalate the treatment to the required level. So it's escalated, dose adjusted epoch means we start at a very low dose and escalate according to the patient's toxicities. So every patient will have some toxicities. So to escalate it beyond step 1, step 2, it takes a lot of guts. And if you don't escalate it, then the advantage of dose adjusted epoch is not there. That's what I see. We give it for the namesake, it's worse than R-CHOP. That's what I felt. Your opinion also is. Okay. And the patients with a poor cardiac function, that is EF poor, that as in our patients, the options are epoch is given. I don't know why, because there is a significant dose of so they are avoiding, I think, adrenaline is given, adrenaline is given, and there is significant dose, but they have given it as an option. So the practical options are adding cyclophosphamide liposomal doxorubicin instead of doxorubicin to reduce the cardiac toxicity, adding etoposide instead of doxorubicin, gemcitabine or procarbazine containing regimens. So these are the other options. These are all also not commonly used, and the toxicities are slightly higher than the routine R-CHOP. So it's, I mean, neutropenia and all, not the cardiac toxicities. So okay, and the elderly patients, the abbreviated regimens are mini-CHOP and other short, even RCVP is the commonly one we use. Avoid adriamycin, usually patients will tolerate the remaining ones. So after 6 cycles.
Actually, this is stage 2E, right?
2E, yes.
Maximum.
Yes.
Or a stage 1E.
Stage 2.
Stage, there are small node, 3 mm node, low FTG of it. You can consider significant or not significant, but if you have stage, it is stage 2E.
Yes.
Stage 2E and our IPA, NCCN IPA score will be low, right?
Yes, yes.
LDH will be low, and so our regimen will include one of those rather than a polar CHP. Polar CHP in stage 1 and stage 2, I basically, when I suggest polatuzumab added to RCHP, is when they have advanced stages like stage 2 with extensive mesenteric nodes and stage 3 and stage 4, when you have a very high IPA score, at least 3 or at least more than 2.
For this patient, polatuzumab is not a very good option because we are replacing only vincristine by the schedule.
When we replace vincristine, we can add pola.
But adriamycin is required. Adriamycin is required, which is not, is not fit.
Anthracycline, when you replace anthracycline, you have data for gemcitabine, but that may not be enough. Lipodox, if you can add lipodox for a cardiac ejection fraction of more than 30, or etoposide, those are the agents which we can add.
I'm thinking of adding etoposide only.
Etoposide.
Or etoposide, it's...
yeah, you can add any of those. And maybe epirubicin, you can add maybe 40 to 50 ranges. You can add epirubicin also. But the question is that whether you give an abbreviated regimen like 3 or do 4, do PET, or 3 PET. If you have a CR, you go for an ISRT and stop, or one more cycle of R-CHOP and stop. That is the question, because you want to reduce cardiac morbidity also, and you may reduce the long-term toxicity of our treatment.
So DLBCL maintenance, there is no role. No.
Maintenance, we don't do maintenance as of now.
And coming to Malu Madam is sitting. So role of radiation in this patient. So can I just give RCVP into say 3 or 4 cycles and RT and stop with that?
This is an aggressive B cell extranodal lymphoma. So I think CAR-T will definitely be part of the treatment. If you ask me the evidence for this recommendation, I don't have any direct
it's a very rare,
evidence,
very rare
but it is mostly based on the two trials that we regularly quote, the Unfold study and the Recover study, where they used consolidation RT for bulky sites and extranodal sites after complete chemo. And this patient has not received R-CHOP, isn't it?
No, adriamycin could not be given.
Yeah, could not be given. So yes, RT does have a role here.
And technique, just 3D CRT?
Yeah, so we most of us have now switched to the ISRT based ISRT guidelines for delivering RT. So again, the volume would depend on the availability of the pre-chemotherapy images. So in this case, we do have a pre-chemo PET. So I would treat the pre-chemotherapy volume to 30 gray. And now the latest ISRT guidelines for aggressive extranodal lymphomas recommend that if we have a good imaging pre-chemo, then we can actually not include the whole organ. You can actually limit it to the pre-chemo tumor within an organ for aggressive lymphomas. But in this case, we only have a PET, so I think I would treat the whole organ, the entire rectum.
To the dose of?
30 gray, depending on, again, the end of treatment PET. So if that is in complete response, we would stop at 30 gray, and if there is residual disease there, we'll go up to 36 to 40 gray. And the technique, we use IMRT technique for all ISRTs, and 30 gray is not a big dose when you compare it to other tumors in this area, but still we'll try to keep all the organ at risk doses to as low as we can.
For the sake of the PGs, what is the overall role of our radiation in DLBCL patient? When are they seen?
Yeah, like Sanudev said, in early stages, we can actually limit the number of cycles of chemo and add ISRT to it. So R-CHOP into 3 plus ISRT if the end of treatment PET is in remission, the interim PET is in remission. And in advanced cases presenting with bulky sites or extranodal disease, RT is often used at the end of chemo for consolidating the response obtained with chemo.
And we will be sending to you after all lines have failed for RT for palliation.
Yeah, RT is also used in relapsed refractory settings, mostly for palliation.
So these are the variants I had talked about. There are 2 minutes. ALK positive large B-cell lymphomas, mediastinal gray zone lymphomas, leg type of DLBCL, cutaneous DLBCL of leg type, primary mediastinal, and transforms from CLL. So these ones are quite an aggressive subtypes, so they need aggressive regimens. Usually the used ones are dose adjusted epoch, or in some cases CHO-EP, adding etoposide to the CHOP regimen. Hyper-CVAD and Codoximivac. Codoximivac is a Burkitt lymphoma, very highly aggressive type of lymphoma regimen. Only if that is that aggressive clinically, then we'll use it. It's a very toxic regimen. And Hyper-CVAD also in very rare cases, very aggressive lymphomas. So that's all. Thank you. Thank the panelists for that.
Thank you, sir, and thank you, our panelists. We won't be taking in questions at the moment. If you have any questions, you can kindly mail or WhatsApp in the number and the mail ID which was projected earlier. I invite Dr. Roshni, Additional Professor, Department of Radiation Oncology, RCC Trivandrum, for felicitating our moderator and our panelists with a memento as a token of appreciation. Thank you, ma'am. Our next session is a couple session on novel things to look out for by Dr. Arunlal M., Consultant Radiation Oncologist, Lizzie Cancer Center, Cochin, and Dr. Durga Purna, Senior Consultant Radiation Oncologist, Astor Medicity, Cochin. I invite the speakers onto the dais. For chairing this session, I invite Dr. Nonam C., Associate Professor, Department of Radiation Oncology, GMC Thrissur, and Dr. Lijish A.L., Associate Professor, Department of Radiation Oncology, RCC Trivandrum, onto the dais.
Good evening, everyone. I think most of us are dead tired after 2 long days. So, when Arvind sir asked to do a couple session, these days we are doing everything with AI. So we asked AI to create a picture of 2 doctors in front of a medical linear accelerator, and this is the picture that was given. I think the trick was I put in couple, and once I put in couples, it became 2 shouting people. I think that is how the AI took couple. So anyway, this is what we are going to do. So be relaxed, nothing big. We will start off the session.
Most of it is on AI. At least I was relieved that it is not a debate, because debating with Arunlal would have been a big task. We start with the famous quote from Patterson, who said that we know, he said in 1969, before half the people here were born, that we know with accuracy about how much dose we are giving in medical radiation therapy. And from then, if you trace the journey of the X-rays, starting from 1960s to 2024, we now talk about MR, LINAC, flash RT, laser-driven accelerators, proton therapy and all that. We'll be trying to touch on a few of these things which are not covered during these today and tomorrow. We start with...
So when we are looking at something that is new, as far as conventional radiology is concerned, we always knew there were 4 Rs. Then by the time at least we were PGs, the 5th R was also there. So radio sensitivity was the 5th R. In 2019, we have got the 6th R. So for the postgraduates who has not yet read about the 6th R, the 6th R is actually reactivation of anti-tumor immune response. So something that we have probably heard in the morning when Dr. Senapati also alluded to it. Basically, for a tumor, to attack the tumor, you need the primed T cells. And to prime the T cells, you need the dendritic cells. Now, for the dendritic cells to prime the T cells, you require some tumor antigens. So where exactly radiation comes? Because radiation's role is a little bit controversial in this entire spectrum. But radiation releases certain agents which helps the dendritic cells to prime the T cells. So there is definitely a sort of, just the way we say that chemo sensitization, radiation is now used as a sort of sensitizer for immunotherapy. So this is the theory that is there. But we have to understand that radiation both has got an immune sensitizing effect as well as an immune suppressing effect. So this is related to the dose, that we are very clear. This is related to the timing of radiation, whether we are using radiation before or after immunotherapy, this we have clarity on. This is probably related to the immunotherapy class of drugs also. But this is an active area of research. We still don't know what is the exact dose at which the radiation acts as an immune sensitizer. But over the last 4 or 5 years, there has been some clarity. The idea, this is a mouse cell, so I'll cut the entire graph into 2 things. So in this mouse, this is the first tumor, this is the other tumor. This patient is going to get immunotherapy. So we gave 20 gray into trials, which says that somewhere around 7 to 8 gray into 3 fraction is when you get your best results. So this has been consistently proven. So if some of you want to go back and try radiation purely as an immune sensitization, the dose schedule that is currently recommended is 8 gray into 3 fractions. There's a lot of controversy around it. So understand that right from the start. And now when you look into it, look into the clinical trials, you know all what happened to Pacific. So in Pacific, the data was that after radiation, when you are giving 1 year of durvalumab, there was a benefit. And this was better if durvalumab starts within 2 weeks of completing radiation. Then we had two pooled large randomized data of pembrolizumab in lung cancer, which again proved that if you are giving radiation along with pembrolizumab, the benefit is better. But for these two data that we have in lung cancer, we have got a lot of data coming up over the last 1 year, which says that this theory does not work in a metastatic situation. Because understand what we are talking about. In a metastatic situation, this patient has got diseases in multiple places. We are going to give them immunotherapy. Along with immunotherapy, we are radiating just one place for 8 gray into 3 fractions, believing that then the immunotherapy will act better on the other sides. This is the theory that we are proposing. But across a variety of sites, GS2 was in multiple tumors. Knives was exclusively in metastatic RCC, and we had another trial from MSKCC on head and neck cancer. In all these trials, what has happened was that this theory did not work. So we still have a lot to learn on this, but assuming you are using SBRT as an immune sensitization, you have to look at 8 gray into 3 fractions. That much is clear. If is actually leading to radio resistance. So a lot of active research is working on the role of radiation on CAF. So this is now called the 7th hour. So from the 4 hours or 5 hours that I studied during exam, for the postgraduates now there are 2 more hours. So that is the takeaway from me.
And so we asked AI to give us a slide on use of radiation immunotherapy, and this is what it came up with, which says that it boosts the immune system, causes sensitization to radiation, and enhances outcomes. Yes, in a broad way, it is right. Because I am sure most of us do not know anything much about use of artificial intelligence. If you asked me last year about what is ChatGPT, I would have called it a Chai GPT. It is used to, the idea is you integrate data science to further clinical practice. You try to use all the images that we acquire during radiation therapy, either for planning or during treatment, and try to look at patterns, try to see if we can predict. Also, it has a role in segmentation, automatic segmentation, to audible audio while contouring patients. And this brings us to another concept of, the next concept that we'll be talking about would be biological dose optimization. There have been studies that looked at, that used the PET-CT to be integrated into the treatment during fusion, magnetic resonance spectroscopy, and oxygen enhancement during MRI.
So there is all this talk whether artificial intelligence will take away many of our jobs and everything. But actually what is happening is that with all new technology, we are finding more and more new indications. Once upon a time, metastatic disease was never a part of our big indication. Now probably at least 30% of the radically treated patients in our scenario will be a metastatic patient. So that shift is happening. Another new indication that is exciting and is coming up is what is called as the cardiac SBRT. So basically ventricular tachycardia has got many. Patient was actually treated in 2012, a 71-year-old male was not responding to the conventional line of treatment. And post 25 gray single fraction, he had a significant fall in his rates of arrhythmias, which you can see in the lower graph.
Adaptation, and typically hypofractionated doses are used. It looks at the shape of the tumor, it looks at of the tumors across multiple images. It looks at histograms, and from the histogram looks at the mean, median, and skewness. It looks at second order textures. That is the relation of, say, a lung tumor to surrounding lung. It looks at other structures like additional image filters and tries to extract data. These are all in the realm of sci-fi rather than actual clinical practice, but this is probably where we are headed. Dosiomics is almost the same thing. It looks at the dose distribution using 3D data, but it tries to predict the outcome from this on the tumor as well as in the organs at risk.
And I really believe that online adaptive RT will become the future. It is the current actually. If you have an MR Linac or an Ethos or any of the new, Elekta has got something called as Elekta, a new car's name. I think there's a session by Elekta now. So basically it's an online CT adaptation is going to be the future, because if you have been to the a machine and try to get the patient in the same position as the CT simulator, it is never going to work. The patient is in one position in CT simulation, patient is in another position during treatment. So the only option is every day your plan should conform to the way the patient is positioned. There is no way you are going to conform the patient to the way you have planned the patient. Till now, that was a difficult task. But now actually the technological solutions has come that is going to be the future. So when we say whether AI will reduce our jobs, AI is not going to reduce our jobs. AI is actually going to increase our jobs, because every day you will have to be present in the RT console to deliver the treatment, because that is what is going to happen in the very near future. In around 3 to 5 years time, most of the time will be spent not in the TPS but in the console. That is dead sure. So coming to the next half of it, something that we have tried is called as TMLI. I think many institutions, Amrita does that, CMC does that, Amala does that. So when you are giving total body radiation for your bone marrow transplantation patients, one step ahead is actually to deliver total marrow lymphoid irradiation. This can significantly reduce the toxicity. This can actually increase the dose of radiation that you are delivering from your usual 12 gray to probably 15 gray. This actually eventually helps with their control of the tumor and eventual results of your transplant program also. It was difficult earlier because of the junction, but then now we have got solution in virtually every system to account for it. You can either do it on a LINAC or you can do it on a tomotherapy. Any of these systems actually allows you to deliver TMLA with junction matching if you spend a little bit more time. The only problem again is that unlike your conventional TBI, contouring for TMLA will take you, it took us around 3 hours. The CMC literature says it takes around 24 hours of active contouring to finish off the contour. So if you are spending a little bit more time, TMLA is one thing that will enter your armamentarium in the very near future.
I guess TMLI cannot be even considered the future anymore, since people, at least in South India, at least 3 centers in South India are actively practicing it. Maybe that is the present. Anyway, I'll come to something again from the future, that is a laser-driven accelerator that we spoke about. So I asked her, I couldn't make out head or tail of what a laser-driven accelerator was. So I asked a physics person to tell us what it was. So what happens is, instead of the vacuum where the electrons are accelerated in a normal linear accelerator, and using our klystron, magnetron and all that, they use an accelerating field which contains plasma. The plasma is what our sun is made up of. It is made up of charged particles, and it is made up of something between a gaseous and a solid state. So, and how do you get a plasma? How do you get plasma from a helium or hydrogen ion and all that? You use high energy lasers. So, you can get energies of electrons that are much higher. Say, instead of our 10 or 15 MeV electrons that we generate in a normal linear accelerator, we can get something like 100 or 200 MeV electrons from a laser-driven accelerator. One. Secondly, instead of our huge klystron and tyrostron and even the proton that takes up so much space, you can probably get it done in probably a meter or even less. And very high energies, very little space, which makes it delivery and transport costs much smaller than before. Even then, having said all this, I would like to go back to Overgaard, who said that the radiobiological questions that we address, the 5 has become 7, and in no time it will become 10 or 15 hours of radiation. And we would still have more questions unanswered than answered.
I think the best way to predict the future is to create it. So each of you here, get yourself oriented into something and do something that will be the future. That is the way we should be looking at it. Thank you.
Thank you, sir, ma'am. I would like to invite Dr. Balamurali Krishna, consultant oncologist, General Hospital, Cochin, for felicitating our speakers with a memento as a token of appreciation.
It was really an excellent session, thought-provoking session, and starting from basic radiobiology to the future strategies, and they did in an excellent manner. It was like a perfectly executed Jugalbandi. Kudos to the presenters.
Very good talk. This artificial intelligence also introduced in engineering college, Trivandrum, where they are making a cell image library that based on the genomic sequence and the genomic instability, they take different patients and artificial intelligence used for that. And also, mainly they are based on the, in our malignancy, genomic instabilities they are taken. Most commonly they are taken the mitochondrial nucleotides. That is increased in malignancy, and that is also decreased after giving chemotherapy and radiotherapy. That is where there is a studies there. Thank you.
I think there is that famous statement, your job is not going to be taken away by AI, your job is going to be taken away by the person who knows to use AI. So we must just learn to use it, that's all.
I invite Dr. Balamurali Krishna, Consultant Oncologist, General Hospital, Cochin, to felicitate our speaker with a memento as a token of appreciation. Thank you, sir. Our chairpersons will be the same for the next session too. Next in line, we have a session on SIP, Simple and Powerful Tool for Wealth Creation by Dr. Cecil Canical, Additional Professor, Department of Radiation Oncology, RCC Trivandrum. I invite the speaker onto the dais.
Respected chairpersons, I sincerely thank the organizing committee for the opportunity to discuss this topic. So in the next 10 to 15 minutes, I will be discussing about systematic investment plan. I usually talk about head and neck cancers in meetings, okay? So this time it's a different topic. So how many of you invest in stocks? How many of you invest in stocks? Okay, invest in stocks, okay. How many of you invest? How many of you invest in stocks as an SIP? SIP investment in stocks. Okay, yes. Then how many of you invest in mutual funds? Okay, most of you do an SIP in mutual funds. Okay, so this is, my lecture is to generate a motivation for the youngsters to start an SIP. I want all the Indians to have an SIP in their portfolio. So SIP means systematic investment plan. It is called the smart investor's preference. The smart investor's preference. So this is the flow of my lecture. One, what is an SIP? Why we should do an SIP? How to do it? What is the best mutual funds to do an SIP? How to maximize the returns in a mutual fund? And how to do an SIP in stocks. So this is the flow of my lecture. And please feel free to interrupt me in between. Okay? So after every slide, please interrupt me. Then what is an SIP? This is the definition of an SIP. SIP means it's an easy way of investment in a mutual fund or stock by regularly investing in a fixed amount of money at a pre-specified interval. So most of you may have a home loan. Okay, so you know that at a particular day of the month, okay, you are getting salary credited on a particular day, and you know that on a particular day, the home loan will be deducted from your account. Okay, you know that. So in the SIP also acts as a good EMI. So you know that, so if you say that to a particular mutual fund, I'm investing say 10,000, 15,000, 20,000, whatever be the amount, and that particular amount will be deducted from your account. That's a simple way of the SIP. And why you should do an SIP? So most of us, when I discuss with many people, we know that the money we get from our job, okay, it may not be needed for our daily activities. Maybe one-fourth, maybe half for us, some of us. So why you need to generate more money? That's the first question I always get. So my answer will be, if you have more money, definitely you can lend a hand. Means you can support some people who are needy people around you. Maybe some by helping people to have education, their marriage, a construction of a house, of giving a small ticket for if they are getting a job abroad. So this is a small way of lending a hand if you have more money. For that, we need an extra income, and also for our kids, so we are preparing, saving for some money. So systematic investment means a smart investor's preference. It is a regular and disciplined way of investing in a mutual fund or in a, just similar to an RD. Okay, so it is very simple. Even you can start with 100 rupees per month. You don't have need 1,000. So whenever I discuss with any resident, say, sir, I have taken a loan. Okay, I don't have money. But you can start a systematic investment plan with 100 rupees per month. So you don't need long amount of large money. And SIP acts as a good EMI and this is a simple way of a long-term wealth creation. So if you're doing an MD, first year or second year, you have almost 30 years in your hand. So if you invest, say, 2,000 rupees every month, in next 30 years, if you invest in a mutual fund which is likely to give you a return of 15%, then you have invested 7.2 lakhs in the next 30-year period. But the corpus you generate is about 1.41 crore. That is the power of compounding. Now, the power of compounding is the eighth wonder of the world. So, and you need not. So, market may crash on a particular day. You don't have to time the market. And when you invest more when the market is down, definitely you will get more points. And if you're investing in stocks, you will be able to buy more stocks if you're investing in. That's the importance of doing an SIP. And how to do an SIP? And always you have different platforms to do that. Either you can invest in a mutual fund house website, or you can invest in direct mutual fund apps. Okay, that's a simple way. Never do an SIP with a broker. Okay, that's my simple suggestion why I will come to that. Because your bank may say that, okay, I can be the broker, I can do. That is called the regular investment. Never do that. Always do a direct investment. So invest either in a mutual fund website, or you invest by any of these apps. These are easy. Yeah, there's a Grow, Zerodha. They are all doing a zero brokerage firm, so you can invest without any cost. And these are the websites which will be useful for you to read when you start an SIP. Then the best mutual funds for SIP, my simple strategy is that, okay, you restrict the number of funds. Okay, and these are three websites. I suggest three websites. One, moneycontrol.com. Second, the economictimes./mutual fund screener. And third is the value research online. So these three websites are really useful for finding the best stocks or to learn how to invest in a mutual fund. And there is another website called Morningstar. That's also important. That's also good. So all these websites are really useful. These are my recommendations. This may vary from person to person. Always you look into your own risk appetite. So here almost the 100%. So if you want to invest in a tax saver mutual fund, that I will come to that later. So this is you can invest. This is the Quant Flexi Cap Fund. Flexi Cap funds, the fund manager has the freedom to invest in large cap fund, mid cap fund, or small cap companies. So that is the Flexi Cap. Then you invest, say, this is around 60%, that will be around in large and the mid-cap funds. And one of the favorite, one of the hot cake in the mutual fund industry is a mid-cap fund from Motilal Oswal. This is also a very good fund. And in the small cap, you can go for a Nippon India small cap fund. So again, this is on an average risk, and if the appetite is more, risk appetite is good, then you can take more risk, you can invest more money in mid cap and small cap. You can change the allocation accordingly. How to maximize the returns? Three steps I want to put forward. One is always do a reverse SIP. This is a concept there from the last decade. Reverse SIP means, reverse ISIP means you have a goal. Suppose if you have a 50 lakh goal, or a 1 lakh goal, 1 crore goal, or a 10 crore, whatever the goal, then you will get, the calculators will tell you how much money you want to invest every month. So that is called reverse SIP. And always you try to increase the investment by 10% every year. So that's by a step up SIP. And third thing is always do a direct 1,000 rupees. If you have after your PG, you start investing in a mutual fund, 15,000 rupees every month for 15 years in a mutual fund which is likely to give you 15% return, and you will become a crorepati within 15 years. So very simple target for everyone, all of us, should be to attain the first 1 crore. Once you attain the first 1 crore, and the next 1 crore will attain the next 4 years. Okay, the first crore, 1 crore is the immediate target. So after the 1 crore, then the second crore will be attained within 4. For the next 25 years, you will reach 10 crore. This is the power of compounding. And when you go to any bank or any people advisor, you're all in insurance policy, you do not need that. You need, if you want an insurance, you take a term insurance and never invest in a ULIP or a guaranteed insurance schemes. And another important point you need to say is that if I want to stress another important point is always step up an SIP. The simple second step is you step up by 10%. So if I said 15, 15, 15. So you invest 15,000, 15 years, 15%, you will reach 1 crore. Okay, very simple. But if you can step up by you increase 10% every year, after the 15 years, you have reached, the corpus will be 1.6, almost 50 lakhs more. So that is why you need to step up. By increasing by 10% every year, then you will reach your goal much early. Another important factor I want to mention, people will be, because I do not know how to invest in direct stocks, direct investment in mutual fund. Then if you have a car, then you will learn the art of driving. In the same way, if you invest in mutual fund, if you want to invest in stocks, always try to drive by yourself. And always you try to learn the art of driving. So more for that, you have to invest in direct mutual funds. The difference is that, so if you have a 20-year period, if you invest say monthly investment is, no, this is a lump sum investment. Okay, lump sum, I will stress this point because I get some consultation from people who are retiring. Okay, so if a professor retires, okay, he may be getting more than that. Just I put 50 lakh rupees. Okay, 53 lakh rupees. So if you invest for another, say, 20-year period, so you say a professor retire or a faculty retire at 60 or 65 years, then for the next 20 years, so if you want to invest that money, I always suggest to invest in a mutual fund, then you give that to a systematic withdrawal plan. I will come to that. So if you invest in a direct mutual fund, I have taken a Kotak Emerging Equity Fund as for example. So this regular investment will be this amount. So after 20-year period, this will be 6 crore 71 lakhs. And it will be 8 crore 67 lakhs, and the appreciation will be much higher, and so the estimated returns is higher. So that is why we need to invest in a direct thing. In the same way, if you are investing every month, say 15,000 rupees for say 20-year period, and this will be like say, you see the difference. Okay. And if you are increasing for a long horizon, like say for a 30-year period, for every SAR, the people call you, always you have to give them lakhs. So the difference is around, say this is for 30-year period. Say if a person is in their 35-year-old person who are after the MT, who are junior consultants, start investing in a regular basis, a direct mutual fund. So 30-year period, in same returns, same 15,000 rupees, for the difference will be say 6 crore 28 lakhs. Here it is 8 crore 44 lakhs, and the difference is 2 crore 15,000. It's a huge money. That's why I always invest in direct. So we never come across, we don't know the difference. So it is 2 crore 15 lakhs. You have to pay for the next 30 years for managing your 15,000 rupees money every month. You understand the difference? So always try to invest in direct mutual funds. Now how to use this money, suppose if you have say 50 lakh rupees with you or 1 crore rupees, you want every month, if you want some money, then I suggest you to use a systematic withdrawal plan. Systematic withdrawal plan is say 1 crore rupees, you want 1 lakh rupees every month, and you will continue to invest in a mutual fund which is likely to give 15% returns. So for the next 30-year period. So this is the amount. So again, that's why you have to use a systematic withdrawal plan. So first generate a corpus, then use that money for your retirement life. So, okay. Now last last part of my lecture is, you want to comment any at this time, or I will go to this SIP in stocks. Okay, I do not invest in mutual funds now. That's a confession. I have stopped investing in mutual funds. I'm only investing in stocks now. Okay, but for a beginner, I suggest you to invest in mutual funds. Then you invest in stocks. Okay. So difference between a mutual fund and stock. You may think that the stock investment is more expensive. No, the stock investment is less expensive than investing in a mutual fund. Okay, the investing in a mutual fund is more expensive because you have to give a fund manager a charge, and the fund house you have to give money for that. But the risk is less, the risk is more if you invest in a direct mutual fund. You definitely have to search yourself. And always the volatility is very less in mutual fund, but it is very high in a direct stock investment. Always you need a demat if you want to invest in a stock, because you only with a brokerage you can invest, so you need a demat. But in a mutual fund you do not need that. And in a mutual fund it is more diversified. And if you want to save tax, by investing in mutual funds you can save tax. In 2010 only I realized that I can save tax by investing in mutual fund. So there is a category called tax saving mutual fund. If you don't have a home loan and you still want to use the old tax regime, you can invest by investing in 1.5 lakhs, you can save that. And you can invest in a tax saving mutual fund. At the same time you can save the tax, and also and also at the same time this will compound. So utilize that. But if you want to invest in stocks, I suggest that you shift to a new regime rather than an old regime. So always you do a stock proper research after if you want to invest in direct stocks. And how to select a stock? Okay, you go by sector. Durga, don't worry, I will send you the slides. Okay, you don't have to take the pics. Okay, it is with okay, it's a public property. Okay, so because how to select a good stock, then these are the 3 websites I suggest. Screener is a very beautiful website, moneycontrol.com and Ticketek. And the Money Control and Ticketek have a paid version also, and this will help you to understand how to select a good stock. These are some of my suggestions, but if someone else may be giving a lecture, they will give a different perspective. And I feel that we are all discussing about the capital market, so all the stocks involved in the capital market are going to do well in the future. Like the CDSL, CAMS, they do all the data for the mutual fund houses. CDSL is the Central Depository Services, and this is where we buy stocks from exchanges, but we keep all the documents in Central Depository Services. And this is the only listed entity in that. All the AMC stocks like HDMC, AMC, Nippon AMC, all are going to do well in the future. And the second thing is all the technology stocks, because all the technology stocks, they are going to do well because they have a capacity to scale, because scaling is not an issue for them. Say like a Zomato, you are all ordering Zomato. And why don't you invest in Zomato? That's how you have to think. And whenever I started thinking about the government announced about Vande Bharat, I looked into only one aspect, which are the company which is manufacturing all these coaches, and started investing. That's how you have to think. And then the E2E is a cloud computing company. This is going to be a future. And the another major theme which is going to play out is the data centers. Network Technologies is a good company, and Sen Technologies is one of the defense proxy player. And we all have used cars, and the most important thing is if you want to invest in car industry, the manufacturing industry, you invest in the software. 2 companies gave the software, 3 companies actually. One is KPIT Technologies. We all heard about the ADAS, okay, ABS. All these are given by the company's software. So this is by the KPIT Technologies. And you have the Tata Technologies, Tata Elxsi. Then this is if you want to invest in the insurance, this is a Mediasset, this one. And we all look into the flight tickets, hotel, because we all see that if you look, it will be 3,500. After say few hours, it will be 3,700. And this company is behind that. That is the Rate Gain Travel Technologies Limited. So invest in that. Okay, and KC International is into the power sector. Gravity India is into the recycling. Okay, we all need to understand when you invest in, this is coming to the last two slides, okay, then the tax implications. There are two tax are there. One is the long-term tax capital gains and the other is the short-term capital gains. It is not based on your bracket. Most of us are in the 30% bracket, but it is not in the bracket. It's frank. So long-term capital gain is 12.5% after the 1.25 lakhs. Okay, so for the first 1.25 lakhs, the profit, if you redeem, then it is non-taxable. After that, it will be 12.5. So if you have a 5 lakh profit, so 1.25 is not taxable. So it is 3.75 lakhs. And the 12.5% of the 3.75 lakhs. So that will be the tax we have to pay. That is 46,875. But if you are a short-term tax is 20%. It is irrespective of whether you redeem next day or within 1 year. It is 20%, and it is 20%. So if you have a short-term gain of 1 lakh, then definitely you have to give 20,000 rupees. If it is 5 lakhs, it is 1 lakh rupees. Then tips to improve returns and do's and don'ts. This is my last the topic. And never lose money, never keep money idle in a state bank account. That's the most important thing. Because most of the time, many I discuss with my friends, I understand that they have a lot of money in their savings bank. Okay, never do that. It is not going to help you or the bank. It is a liability for both. Okay, please use that for the benefit of you and the country. So you invest somewhere. Okay, and always have a medical insurance. That's very important. Emergency fund we all have, and keep the emergency fund either as a liquid for an FD. Okay, FD and online. That should be an online. Never consider your policy as an investment. Most of the time people say that I have LIC policy, this for the daughter, and never take policy for children. It is not needed. They come and attach. Please take a policy in daughter's name. We all have a sentimental attachment. Never do that. They do not need any policy. Take it from me. Never take any policy in their name. If you have insurance, insure in your name. Okay. Then maximum investment in equity, because that's the only way by which you can beat inflation. Small savings are not going to help you. Small savings are not going to help you. PPF, EPF, Post Office, Suganya Samarthi, then National Savings Certificate. No. All these are in the tune of say 6 to 7%, and we are likely to see a interest rate from this later half of this year itself. So, and always we need to understand that we are going to have a low interest. So whenever you come across anything which is going to based on interest alone, or then you need to understand that we are not going to have a sustain that, because the interest is going to come down. Always we should have a goal-oriented investment. Like you try to have this much money, so be disciplined. Always try to top up your SIP, and always do a direct investment. And if you have a lump sum investment, and if you have a monthly investment, monthly returns from that, always do a systematic investment plan. And limit the number of mutual funds. That's also very important. Limit the number of stocks also. Sometimes we come across 60 to 70 lakhs, but it's like 60 to 70 stocks. It's not possible to track all the stocks. Okay, so you limit the number of stocks, understand the tax implications, avoid the sectoral funds or NFO, because whenever there is a new fund offer or a sectoral funds, the people will be after you. The fund managers will be after you. No, please. And whenever you invest in a mutual fund, we always have a tendency to look every day. Never do that. If you investing in mutual fund, never do that. Never do that. Okay, you can have a look within a year. Okay, then you assess whether you want to change in the fund house. Otherwise, the market may crash. Okay, then you will think that no, I should not have invested in mutual fund. No, it is for long term. It is for a long term. Okay, you know that in the COVID period, the market crashed and it became 3 times within 3 to 4 year period. So it will always happen, and never this look only in once in a year. But if you are investing in stocks, always be after the stock and always look into the quarterly performance. Okay, that you can take from screener. And always look into the conference call, what is the future plans of the company, whether any capex plan, All this we have to look, what is the revenue guidance of the company, what is the corporate governance, any of the senior directors in the executive boards have resigned, whether it's a change in the chartered accountant. So many factors we need to consider when you are investing in a stock, but that there is none. Okay, last two slides. This is regarding the announcement and attention for two programs. One is the head and neck, the Astro head and neck teaching course. This is going to be held in Trivandrum between June 5th and 7th. And there are three international faculties coming and 4 to 5 national faculty. So this will be a great learning exercise, like opportunity to learn head and neck. And the theme of this year, it is larynx and hypopharynx, 3-year program. This will include case-based discussions, contouring sessions, and discussion on contouring and homework. So many things are there because it was very difficult to attend Astro courses earlier. We used to travel Europe. Nowadays it is available in India with same quality. And the course, the registration fees was also very less compared to the original Astro course. And it is 12,000 rupees. And if there is a physicist also coming and there is a, then the combination have only 18,000. So physicist plus a clinician. Please utilize that. For residents, it is 10,000 rupees. And only 100 slots are available. Few slots are available. If you are interested, please register at the earliest. Please register, and this is the registration link. And second, this is every year at RCC we conduct the international workshop on precision radiotherapy. And this is going to be held this year in the March 1st and 2nd, Saturday, Sunday. It is a 1.5 day program. The topic is genitourinary tumors. 4 international faculties coming, and from the prestigious institutions in UK, that like Christie Hospital and from Royal Marsden, and the Professor Peter Hoskin and Professor Chris Parker from the RMH and the Peter Hoskin from Manchester, and Sulaid Jain from Belfast, and also our own alumni, Milan is also coming. 4 international faculty and 2 national faculty, the Vedang Mukti from TMH and the Indranil Malik from TMC, the International National Radiation Oncology faculty, and the surgeons. And please utilize this opportunity. I invite all of you for this 2-day program. With this, thank you very much. Any questions?
Any questions?
10 minutes, GB is at 6 p.m.
It was an excellent initiative from Dr. Cecil to create investment awareness among doctors. So he has shown pathways to generate crores. Now you can start thinking about how to spend those crores. So any questions? So we'll wind up the session. Thank you, Dr. Cecil.
Your presentation was very nice, and your idea of investment in mutual funds as well as stocks is good. But in a busy day-to-day life, how is it practically possible? You might have gone a lot in depth into the topic, but is it possible for everybody?
Sir, if you want to invest in mutual fund, you don't have to work on the working hours. Only if you want to invest in the stocks, you have to buy in the working hours from 9:30 to 3:30. But if you want to invest, you can do at evening, no problem. But if you give an instruction to the bank or to an app, they will directly deduct from your bank account. You don't have to think about anything. That will be automatically deducted. Like it is like giving a check online, e-check, ISIP.
What do you suggest? The State Bank has come out with some SIP and other things. What is your opinion regarding that?
So always you go by the fund house and fund house. I have given the recommendations as of now. Then you always stick on to the never think that if you invest in SBI mutual fund that will be more safe. Never think that. SBI mutual fund is a separate company, not like SBI. Okay, and the SBI mutual fund is not even a public company. It is a private company. It has not been listed at all. So never think that if you invest in SBI and SBI mutual fund it is more safe. Okay, I don't agree to that. Okay, these are all separate listed companies, or listed or unlisted companies.
recommendation.
So if you cannot track, please invest in mutual fund. That's by an SIP route. That's invest every month. You give an instruction that will be automatically deducted from your account. You don't have to do anything while you are working, while you are busy. It is like if you have a loan, it will be deducted from your account every month. Same way.
Say you said you should not invest in LIC or any other insurance funds. Say, are you justified in investing in funds which give you an insurance cover?
And insurance, we need an insurance. For that, you need a term insurance. Okay. If you want to invest in, if you want to take an insurance, then you take a term insurance, life insurance. Because whenever you take any other insurance schemes, it is not adequately covered. So that's a concern. Any other questions? Tax is, madam, it is 12 point. Earlier, this is the long-term capital of it, and this is given only when you redeem. As long as it is there in the demat account or is get invested, there is no need to give a tax. Only when you redeem, you need to give the tax. Go 1.25. If it is above, the profit is 1.425, then you have to give 12.5%. Below ne kodukke venda. Yes. Yes, Arun. Yeah, PMS. Yeah, definitely, of course. Free of charge. Yeah, free of charge. So, but one of the concern is that some people, they ask them to give a stock recommendations. I will give the stock recommendations, but they will never come back. Okay, that's the main concern. When you invest in stocks, the main concern is when to exit the stock. That's not a problem with mutual fund. So entry is easy, exit is difficult in direct stocks investment. But every quarter you have to look into the profit. So we need to play the games. If you can move the smart money early, then you will make a lot of money. Yes. Yes.
As your teacher, my only worry is, you have been going very well in head and neck oncology. now all this is getting shifted to SIP. And that is a real worry for me.
Sir, I have started this shift from 2000.
Persons with a memento as a token of appreciation.